corneal irregularities. So in your judgment or taking a decision to do the surgery, it will be false. And it can mislead you in biometry, it can mislead you in keratometry, so you have to be careful because this can affect directly the results of your surgery without the complaint of the dry eye. There is an impact of the dry eye on the post-operative vision, especially with the special consideration multifocal intraocular lenses, as we heard earlier, because the precorneal tear film regularizes the cornea, and this helps you to get the best out of the multifocal lens that is implanted. Regardless of its type, it's going to decrease a little bit the contrast of the patient. So if you have another problem in the quality of vision, he will be really disturbed. A lot of the patients coming after multifocal implantation, if you don't recognize this, he is complaining he's not seeing well. If you diagnose this, give him lubricants very frequent, he will come back smiling and happy. So it's very important to understand this. What is the effect of the dry eye on patient comfort? We all know the cataract surgery can exacerbate previous asymptomatic dry eye patients. That's why it's important to diagnose them preoperatively rather than postoperatively. And dry eye increases inflammation. It's a cycle of inflammation. So this will make the patient have a lot of discomfort that is affecting his lifestyle, and he'll be complaining of all these complaints. And this is really very notorious to the patient and for you as a doctor if you did not discuss this beforehand. This is very important, the effect of dry eye and risk of complications. Blepharitis is the main risk of post-operative endophthalmitis. Blepharitis can increase risk of corneal ulcer and infection, whether peripheral or central. So just neglecting to diagnose this properly, although you might take all the precautions intraoperatively, if the lid margin is exposed under the opsite, you can get a post-operative endophthalmitis just because you did not treat the endophthalmitis. This is a serious impact. So how do we induce dry eye during and after surgery? What are the things that we do that can incite and increase the dryness of the eye? There are things that we do intraoperatively, preoperatively, intraoperatively, and postoperatively. Preoperatively, it depends on how we sterilize, the percentage concentration of betadine that we use, povidone iodine, using non-preservative free or preservative eye drops, whether dilating eye drops, anesthetic eye drops. This affects the surface of the cornea. Non-steroidal anti-inflammatories, using all the preservatives is very hazardous. This is what we do preoperative. Intraoperatively, phototoxicity of the light. This is something we don't think about. Phototoxicity, if you're using high illumination and the surgery is long, this affects the post-operative dry eye. Also, surgical trauma, manipulating too much, touching the conjunctiva all around, this helps to have dry eye. So there is trauma that we do. This will induce dry eye disease, and this will cause a problem. One of the things is the incision, our incision. The incision, if we do incision, particularly if it is large, you cut nerve fibers going into the cornea, like in LASIK. Of course, it's smaller, but this is one of the reasons why, or how can we induce surgery. So the theme is, what we should do is to use preservative-free drops pre-operative, use short surgery, try to be short as much as we can. Smaller incisions are better, faster surgery is better, and wetting of the cornea. Intraoperatively, people are used to have the assistant or the nurse just all the time washing the cornea. This is one of the reasons of increasing post-operative dry eye. The best thing for you to see The best thing for you to see is just put viscoelastic methyl cellulose. It's very simple, available. It will coat the cornea, it will improve the visualization, and it will reduce the need for somebody else to just all the time wet. So these are things that we can do to prevent or lessen the chances of inflaming or increasing the risk of flared dry eye. This is, you see, I put methyl cellulose on the cornea. Visualization is perfect, and this let you, if you see this, let you understand why the dry eye patient cannot see well. It's the same as you are looking through the microscope. If you're not seeing well and you ask somebody to wet the eye, this is how the patient sees. Once you put the methyl cellulose, you can perfectly see well, and you don't need somebody to wet the cornea all the time. Phototoxicity, we have already touched on this. I don't want to go too much into too much details. You understand the point here because we have the Goma prayer. What we should do, we'll touch up on this. What we do in our place, we have a pre-operative questionnaire for the patients coming to our clinic, and particularly those going to surgery. We translated it, it's in Arabic, it's easy, the patients can just circle this. So when the patient comes, you know if he have dry eye symptoms or not, you have an idea. And then you can have diagnosis, so many things you hear about. The simplest thing and the most important thing, slit lamp examination and fluorescein testing. This is the simplest, the main thing that you're going to help you. The slit lamp examination, you can examine all the orifices of the meibomian glands. With the fluorescein, you can see any punctate staining of the cornea. You can test the breakup time. You can see staining of the conjunctiva. If you have rose bengal, you can use it. Lissamine green, you can use it. This is the simplest thing. Good history, questionnaire, listening to the patient, and this is the basic testing. If you do this for every patient, then you're almost good to say this patient has dry eye or not. You can have more complicated things. You all already heard and see in the exhibition. There are a lot of things that you can use. One of the nice things that is simple, all of us almost have a pentacam, or we have an Scheimpflug image. Many of them, you can have a meibomian test and automated dry breakup time testing. So you can ask this test. It's simple. There are other things to test: inflammatory, tear film osmolarity, but the basic, again, is slit lamp, fluorescein. So diagnosis is essentially clinical. Preoperatively, you have to diagnose this. You have to see if the patient have meibomian. You can see the meibomian glands are stuck, occluded. You have to work with this. You can see what we used to call anterior blepharitis. This is Demodex, and this has to be treated. This is a risk for discomfort post-operative, but also a risk of infection post-operative. And both things are really very disastrous things for our patients and for yourself, because you will have a lot of troubles. So this has to be treated, cleaned, and give it time until it heals before the patient go to surgery. You can do treatment in the office. You can give, we know that Demodex or the anterior blepharitis and the meibomian gland, they can improve with like azithromycin or vibramycin, oral tablets with topical antibiotics, some lead hygiene like tea tree oil, wipes, and it's very easy just to tell the patient to use it, hot fomentations to clear up this. But if this is not enough, you can clear the meibomian glands by probing of the meibomian gland orifices. You can suppress this, and you can use all the fancy things, but we have a very simple, cheap machine, which is called MEOM. And MEOM is like other machines. The idea of it have intense heat, and within this intense heat, the the doctor massages the meibomian glands, so liquefies the secretion, and then instead of automated expression, you can manually really express all the meibomian glands, giving a chance for new secretions to come. The great thing about this machine in our country, because of a lot of financial restrictions, so it costs nothing. Yani, there is no disposable thing, there is no session price per session to use something, pack or something. It's extremely simple, and this is how you express. There are many forceps for this. Usually gel or topical anesthesia is enough. And you can express the glands. And really, this way of treatment is extremely helpful, and patients usually improve markedly after first session. They can have a repeated session after 2-3 weeks. Sometimes they don't need, and this can fasten the time for the recovery of the patient to be able to do the surgery earlier. Lubricating eye drops, you can use it with the antibiotics or whatever the diagnosis is, and better to have it as preservative-free. Everything you can use preservative-free is better. And there are some supplements use omega-3, not omega-6. Many of the combined formulation in the market is omega-3 and 6. Omega-3 and 6 are opposite, so you have to use omega-3. It's a lifestyle. You have to tell the patient it's a lifestyle. Many things has to be done. Staying how long on the computer, interruption of the computer, even the air condition. The current of the air condition in evaporative dry eye disease increases the evaporation. And this also you have to tell the patient, don't stay in the current of the AC. And also you have to remember that the AC in the car is even, the current is much stronger, and it can affect the patient dry eye status much more even than the regular AC. So these are things that you should tell the patient. Let me share with you these few cases. This is a 67 years old patient coming for cataract extraction. So I would ask you, how would you proceed in such cases? As you can see in the lid margins, you can see this foam-like effect indicating meibomian gland dysfunction. There is thickening of the lid margin. As you can see, there is some injection in the eye. So what would you do? He's coming for surgery. Obviously, he has cataract. You are eager to go and do the surgery because before he goes to another doctor and do the surgery. So it's very important you control yourself. الجشع اللي كان دكتور حاتم بيقول عليه, we should stop it. You should tell the patient, yes, you can do the surgery, but if we postpone it and treat this problem, I usually photograph the patient and show him what we see, so he can share, understand, and you tell him that we will need to take medical treatment. You have to do lead hygiene. You might need to do a session of the MyBuflow or whatever light pulse machines. And then, after he's controlled, we go for the surgery. Start with the sample evaluation. Do the meibography. This is on our CSO Scheimpflug imaging system. You can see the effect on the meibomian glands, how many glands are completely occluded. And this is the automated tear breakup time. You can see all the red areas. This is a bad tear breakup, bad tear film. And once we do the same, we give him topical treatment, systemic treatment, lead hygiene, and we advise him we need to do a MyBuflow session to hasten the improvement. And meibomian gland expression. And then you can do the surgery once the tear film has improved and clinically he is better. Another case, 2 weeks, this is the classic presentation. You see perfect phacoemulsification, seeing the patient is seeing perfectly. He's coming, usually the time is typical, 2 to 3 weeks post-operative, because during this time has used the eye drops, a lot of preservatives in it. There is exacerbation of a pre-existing meibomian gland dysfunction, and the patient will come extremely angry. Sometimes they call to the hospital and say, like an emergency, it's a lot of pain, I cannot open my eyes, if I go to the sun outside, I cannot open, it's a disaster. And when he comes, you are afraid it's an endophthalmitis, you will see that it's only meibomian gland dysfunction and dry eye or ocular surface problem. So once you see him, it's better, as we said, to avoid it. If we treat him earlier on, whether with the interventional or only medication, we will avoid this situation. But many times, we miss this. And if he comes like this, you have to reassure the patient. You tell him, I know it's a bad feeling, it's very bad, but there is nothing inside the eye. We are going to give you treatment, and you exactly do the same thing, systemic antibiotics if needed, topical treatment, and here you give topical steroid as well to break the inflammation cycle, and you can suggest, if he is not improving, to do a session for MiboFlu. But hot fomentations is very important, and many of us doesn't know how to tell the patient what is hot fomentation. Tell him, you do 2 times a day hot fomentations. But if you ask the doctor or the patient how to do, each patient will have his imagination. Somebody will get tea bags and put it in his eyes. Somebody will get cotton. Somebody will do whatever. But you have to instruct the patient how to do it. The simplest way, there are 2 ways, but one of the simplest ways is just to tell the patient, get a bowl, put hot water, hot, not warm water, because they think just washing with warm water is enough. You put hot water and keep the kettle beside you with a small towel, soak the towel in the water, squeeze it, and then close your eyes and put it over both eyes, not each eye alone. You want the heat to be distributed here, and for 10 minutes, heat the water again, not at the beginning, and then it's cooled at the end. And do it at least twice a day. This will be extremely helpful. Once the patient understands how to do it, and he do it properly, usually within 1 week, their symptoms are better. Even after LASIK or during LASIK surgery, it's important to be aware of this. This is a contact lens wearer, and we know the effect of contact lens wearing for a long time on the ocular surface and the tear film. Coming for refractive surgery, very simple refraction. How would you proceed? If the patient, you can see in the right eye, there is injection. If you just use the fluorescein strips, you will see the conjunctival, bulbar, and palpebral conjunctival staining, some pancreatate staining in the cornea. And then if you do further tests to evaluate the condition, you will see there is dry eye. Of course, if the patient coming for refractive surgery, wearing soft contact lens, which is most common, stop it if you can for 1 week earlier is enough. If you see the status of the ocular surface bad, delay it. This is interesting, and this is the last thing I'm going to share with you, is that this is a 30 years female patient. She has done LASIK surgery 2 years earlier. And she has been suffering from burning sensation over the past year, to the point that she could not perform well at work and taking sick leaves more often because her job demanded using the computer for long hours. You can imagine, during a whole year, she is going from one doctor to another doctor to another doctor. Each one is giving her another eye drops, and she is not improving. And she became really desperate. So this is how her meibomian glands look, not very bad, but there is still occlusions in areas. You can see the tear film is not okay. So once you diagnose the problem, you can tackle the problem. And this patient, after 2 years of suffering, just again diagnosing the problem of dry eye, managing the dry eye. The patient completely recovered. Her symptoms almost disappeared, and she returned to normal life. Just a simple test and thinking of a diagnosis without jumping into simply writing eye drops, particularly with preservatives, for patients, it can turn their life to hell. So in conclusion, dry eye disease is a complex disease. There are multifactorial reasons that make patients have problems and unhappy, and it can make you unhappy. There are major impacts on cataract surgery, either preoperative in decision-making, in IOL calculation, and postoperative at the risk of complication. All needs to be addressed properly to have a happy patient and happy doctor. Thank you for your attention.
Thank you, Dr. Professor Yahya. You mentioned in your topic that there is a relation between the dry eye disease and the selection of IOL. So what is the relation between dry eye disease and selection of IOL, especially I mean a premium IOL, which we know as an active IOL? If there is any difference between the trifocal and EDOF in selection of this type of IOL?
The relation is with any type of IOL, starting from the biometry. You can have a wrong biometry because you had bad topography, bad K readings, so your calculation will be wrong for any type of intraocular lens. Adding more for premium lenses, whether extended depth of focus or trifocal, if you have a bad quality of the ocular surface and tear film, then you will lose quality of vision. And we know all trifocals or diffractive multifocals in general decrease the quality of vision and contrast a bit. So the patient will not be, you will not advise. If it is mild, like the cases you can treat, then you can use this type of intraocular lenses. But if it is severe or the patient is not improving, you will not recommend to the patient to do a premium IOL.
Thank you very much. Second question about the role of anti-inflammatory drugs and cyclosporine in treatment of DED. What's the role? And can you combine it with the artificial tears at the same?
Yes, it's very important. Just one thing, I maybe passed through the slides. Many of the patients of dry eye, they go to different ophthalmologists and they tell them you have allergy, and the patient comes to you and tells you I have allergy. And all of this, they are prescribed antihistaminic drugs. Antihistamines increases dry eye. So you have to check the drops, and for a patient with dry eye, don't try antihistamines. The use of cyclosporins or small immunosuppressants in general is very important, particularly in more advanced cases, and this can be used for 6 months, 8 months, it depends. And it should be used with lubricant, preservative-free, and maybe as well combined with the steroids. And now we have available many types of steroids that are very less liable to increase the intraocular pressure if we use it for a long time. You want to break the cycle of inflammation. So it's very important to correct the main condition, but it is not only by drug, it is by a whole lifestyle. You have to explain to the patient what they should do with the computer, with the AC. In an area like in Dubai, for example, or in the Gulf area, the air condition is all the time used for 12 months. So people should be aware of this.
Thank you very much. If there is any questions for Dr. Yahya?
I think we have 1 minute.
Thank you for this very nice and important presentation. I want to ask about, you spoke about allergy. In some cases, we have cases of allergy, conjunctivitis, and glaucoma. So can we use steroids? Can you use antihistamine for these cases? Also, it's not directly related to your subject, but in cases of sometimes have allergy, dryness, and glaucoma.
What type of allergy?
For example, some cases have continuously eye itching. They have seasonal allergy, for example.
Seasonal, if it is seasonal, it's allergy, but very common with the dry eye symptoms. Itching is the main complaint, and that's why a lot of people mix it with allergy. And also with glaucoma, all the glaucoma eye drops, particularly even if they've done surgery, have been using drops for so many years, particularly preservative eye drops, so they are always compromised for the tear film. But if you have to use for allergic, if it is true allergy seasonal with a glaucoma patient, use a preservative-free, either if it is allergy antihistamine, or mild steroid that will not increase intraocular pressure for a allocated time.
Thank you very much.
Thank you very much, because the time is...
Yes, I think it's...
Thank you, Dr. Yahya.
Thank you.
And thank you for the audience.
Thank you.
Thank you very much.
a couple of have this booklet for the booklet? The names, the booklet, whatever you have. You don't have? Bismillah ar-Rahman ar-Rahim. We'll start our session today. Orbit tips and tricks and so forth. Actually, it's actual didactic, very good lectures about orbit. We have 1 hour. We have to be in time, hopefully. So, Dr. Nizar al-Hashimi.
Thank you, Dr. Mahmoud, and I hope that this session will be nice and fruitful. The first speaker will be Professor Mahmoud Al-Salam, and it will be on orbital decompression in thyroid eye disease.
Fine. I would like to share with you the orbital decompression for thyroid orbitopathy, how I do it, and how it should be done, and the value of this procedure. Okay. Fine. Actually, for TED, the age range usually 25 to 50 years, and it's all proptosis. We know this: eyelid retraction, diplopia, restrictive myopathy, visual impairment, and so forth. There are 6 differences, of course, being more common are in females, but in males it runs an aggressive course sometimes, especially if they smoke. So some smoking is a risk factor. And the course of the TED, thyroid eye disease, between 2 brackets, I don't like to call it thyroid eye disease, but it's I call it thyroid orbitopathy or dysthyroid eye disease. And the course is intermittent. That means it is not a linear progression. And it is acute episodes, which is commoner in the 3 months to a year. And it is unilateral or asymmetrical involvement. It's very common. Lid retraction is the rule unless you have myasthenia gravis. And history of thyroid abnormality on the average in 2.5 years, but 15% of women and 35% of men have no history. And sometimes it end up in an active stage, and it's a disfiguring proptosis, I call it. And in this our age, with the blepharoplasties and with the people who are doing refractive surgery, they don't want to wear glasses. Living with such an image is not nice. So there is a solution, and the solution is surgery at this stage. And it has the best classification for TED is type 1, type 2, type 3. Type 1 is a proptosis with little muscle involvement. That is a soft eye, soft orbit. It's an orbit with a good compliance. That means when you do palpation for the orbit on closed eyelids, and you do little pressure, naturally there is ballotment, as if you really ballot the ball or whatever, and a soft orbit. But if you find that it is hard on retrobulsion, this is, we call it a type 2. This is before and after disease. These are really patients who come to the clinic and they say, I have been like this, now can you do something to make me look better? Okay. And type 2 is a gross muscle involvement, restrictive myopathy, and this is an example of this condition. Okay, and especially if it is hard orbit, and if you do like some neuroimaging, like CT scan or whatever, and you find very thick muscles, even there is no place for the fat. Fat has been atrophied and so forth. And this is type 2 or gross muscle involvement and inflammatory signs, optic nerve compression or DON, dysthyroid optic neuropathy is at risk in these cases. Find fibroptosis with poor compliance, hard orbit. There is another third type, call it third type. It's a gross muscle involvement, inflammatory signs, optic nerve compression, but no proptosis. These are the dangerous one. Very hard orbit, very poor compliance, very tight orbit. These are usually men with taut orbital septum. Taut orbital septum. This is why I have something against exophthalmometry, whatever, and they think, the general practitioner, endocrinologist, whatever, they think exophthalmometry is the end of assessing the proptosis or whatever, and they think that it is the most important, and tell the patient how much they increase, as if it is really every month or 2 years or 1 year or whatever, they will increase 1, 2, 3 milli and so forth. And actually, it is the nature of the disease. For this, they have no proptosis, but they are at risk of DON. And this is, we are doing the retrobulsion, and they are at risk of, for example, this example I will show you later about this patient in details. I call it concealed proptosis, concealed exophthalmos. And actually, these are patients, when you see them, muscles have been thickened so that they really compress the optic nerve, especially at the orbital apex. And many studies have shown relationship between muscle size, restriction, and motility, but not comparable to the amount of proptosis. Okay? And the apical, what you call it, the apical syndrome with congestion of the optic nerve in the orbital apex, best treated by surgical decompression, which is the resection of the medial wall in the deep orbit. For dysthyroid optic neuropathy occurs in 5% of patients with Graves' disease. The older the age, the male gender, and the smoking is a risk factor. And how to diagnose compressive optic neuropathy? It is actually visual acuity, this chromatopsia rapid, and this disc changes and the field changes. This is, of course, you are doing as a part of ophthalmic assessment in these cases. Now, the management of thyroid orbitopathy usually has been mistaken for medical assessment. Medical, I mean, like we tend to give the patient, okay, selenium, antioxidants, go for immunosuppressant like steroid, whatever, and you think the steroid will do miracles. Steroid doesn't do miracles, and now there are new drugs, like Tabiza or whatever, okay, but Tabiza is very, very expensive, so it's not really a practical issue. Actually, this patient has been treated by steroid injection, retrobulbar injection, and he recovered, but he relapsed in 2 months. In 2 months, he was maybe worse, okay? Indication of orbital decompression. These are asymmetrical exophthalmos. Asymmetrical, you cannot live with asymmetry, okay, in this world. Compressive optic neuropathy, prior muscle surgery, exposure keratitis, intolerance to steroid, disfiguring proptosis, and globe subluxation. My working hypothesis of the orbital decompression is that we are blessed of having nasal sinuses around the orbit. Then usually, traditionally, we think of nasal sinuses as a curse, that they are site of infection, whatever, but I look at them as a blessing. It's a kind of the backyard of the orbit. It is there when I need them, I go for them. And they are actually very rewarding. For orbital decompression, actually, essentially, it's a radical or massive, where surgically induced blowout fracture like, okay? This picture actually taught me how the orbital decompression works, okay? Actually, when you see blowout fracture, what happens? Usually there is enophthalmos, because some of the contents of the orbit went in. And this is what we are going to do, but surgically, without producing dystopia and so forth. Try to, as much as possible. And orbital decompression can be only fat decompression. Now, this picture, very important when you do some neuroimaging. Here, look at this, fine. So it's very rare, but it happens here to have sometimes a kind of displacement of the dural sinuses behind the ethmoid. This is rare, but it happens in 1% of the cases. So you should be aware of that you don't go high up in these cases. What's orbital decompression? Either we remove 1, 2, or 3 walls, okay? And it is usually the oculoplastic modern technique is to go direct orbital transcutaneous or transconjunctival. I mean, there is kind of misunderstanding in the past, at least before I started doing the orbital decompression, and usually at that time it was monopolized by the neurosurgeon, maybe ENT and so forth, as well procedure. This is the blessing, I told you, the nasal sinuses, which we are going to use for the orbit, okay? And this is the ethmoid. We are going to remove if there is any optic nerve compression, okay? And lateral orbital decompression has gone into lateral wall decompression, okay? And that was 1911. And transfrontal roof decompression, 31. And medial wall decompression. And all were kind of leaders by the general surgeons and by ENT people. Trans-Caldwell lock decompression that goes behind the second canine, where to go to the maxillary. I call it, this is kind of orbital decompression from without. يعني انت بتطلع بتوصل الاوربت، بس انت محتاج طريق تاني من الانف من الماكسيلاري ساينس أو من الانترا من الانتراكرينيال تفتح and so forth من البرين وتنزل عليه. This is, I call it, from without. But we are doing orbital decompression as orbital surgeons. From within, we go to the orbit and we open it to the outside. And this is, I think it is very big, let us say, step in front for the modern oculoplastic orbital surgery. Fine. This is now obsolete طبعا. This procedure obsolete has been preceded by, this is unaccepted surgical practices nowadays, okay, called Willock and so forth, or call it from, or coronal and so forth. So what we do, actually we do, either we remove one wall, the ethmoid, اللي هو one wall here, this is, or two walls, the ethmoids and the floor, and here it is more the three walls, okay? The ethmoid, the maxillary, okay, the orbital plate of the maxilla, and the greater wing of the sphenoid as well. Lastly, we go and remove the zygomatic arch, These are the four steps. Now, how you do it? We go either transcutaneous في lateral orbital decompression, okay? The medial approach, rarely, I used to do transcutaneous as if I am doing DCR incision. Now I change this into transconjunctival to the semi-lunar. Under the semi-lunar fold, transconjunctival, you go to the medial wall. It's all conjunctival, all transconjunctival. But only the patient will feel the lateral, what you call it, the lateral orbitotomy skin incision outside. This is called combined here. Combined, okay? And this is the inferior here, fine. And this is what they call it balanced decompression, the combined balanced decompression and so forth. For the amount measured of orbital pressure released depends significantly in the factor. First, the removal of the orbital walls, irrespective of which wall. And the second, the incision of the periorbital. Very important, you incise the periorbital and you open in that. Now, these are the steps of lateral orbitotomy. I cannot go, there is no time to go over the steps, but actually you remove, you do skin crease incision, you go into the temporalis fascia, you incise, you remove the temporal arch, okay? And then you dissect the greater wing of the sphenoid, and then you stitch back. طبعا, of course, you remove, you open the periosteum, there is fat, the fat comes behind, and you release it by usually artery forceps and so forth. Fine, and this is at the end. This is what you will have. The medial wall, you have removed the medial wall, and this is the floor, and here the lateral wall. The lateral wall, you remove as much as the trigone. This is, you don't go beyond the trigone, and this is very hard to remove. Once you feel the bone is hard, you cannot remove, this is where you stop. This is where you stop, you cannot go beyond, otherwise you are in the intracranial cavity. But this is the trigone, what you call it the trigone. This is the greater wing of the sphenoid and so forth. You remove as much as of this, okay? I hope I am in time, مش عارف, إن شاء الله. There is kind of, أرجع معلش هذه, endoscopic endonasal optic nerve decompression, and this is usually done by the ENT people, and usually they need the ophthalmologist around and so forth, so that they don't really damage the optic nerve. Now how the whole context, okay, the whole context of the The orbital surgery is you minimize complication, consider surgical objective, meticulous dissection, respect tissue, and know the natural plane, control operative field, and viewing devices, very important, illumination device, proper control of bleeding, prevent post-operative complications, surgical drains, and control post-operative inflammation, طبعا, of course, with the steroid. But not to do, it's not acceptable to do a lateral tarsorrhaphy. This is obsolete, okay? It's not acceptable to do lateral tarsorrhaphy. Okay, these are examples of patients that have been done orbital decompression, and this is a 4 years old, a history of thyroid eye disease in this female, and she had actually inferior and medial walls and 3.5 millimeter effect afterwards. And this is pre and post.
Professor Mahmoud.
Okay, it's almost finishing. Okay, and actually, okay, these are 3 walls orbital decompression. I have 15 minutes, by the way. Is it finished?
It's
15
time,
minutes.
yeah, we are running out of the time.
Okay, طب خلاص ماشي. This at the end, you end up like this, actually. Okay? When you remove these walls and so forth. And this is a man with 7 years follow-up, actually, and this him later on with 3-wall orbital decompression. Okay, and all this I have done orbital decompression. At the end, you cannot really see where is the incision and so forth. Okay, and this as well, this is one of my recent cases that I have done. And actually, no visually dis-threatening complication were seen. Diplopia, inflammatory keratitis, and ptosis were infrequent. Functional visual recovery was remarkable in these cases. In summary, surgical orbital decompression offers better outcome for thyroid ophthalmopathy patient and reduces need for steroid and encourage rapid rehabilitation with cosmetic acceptable appearance. Thank you for your listening. Thank you for
Thank you, Professor Mahmoud, for this very informative topic. The next speaker is Professor Farzad Pakdel, leader opinion in oculoplasty and orbit surgery. He will talk about IgG for related disease. And as we are running out of time, we will put the discussion at the end if we have some time.
Thank you very much for a kind introduction, and thank you for the organizers and Dr. Lamri for inviting me to this wonderful meeting. I'm very happy to be here and talking to you, dear colleagues. So we have 3 more lectures, so I summarize my lecture in the case that we have the time for other 3 lectures. I will talk about this entity. Oh, yeah, thank you.
This is forward, this is backward, and this is the point.
So I have no conflict of interest for any material or any kind of the instruments demonstrated in this presentation. So 201, it was found that the cases that was assumed to be idiopathic autoimmune pancreatitis had high IgG4 syndrome, and this is the birth was IgG4 syndrome. So by definition, IgG4-related disease is a chronic fibroinflammatory disease characterized by enlargement of the affected organ that can be one or multiple organs, elevated serum IgG4 level, and abundant IgG4 positive plasma cells. This is essential for the diagnosis. We should see that increase in the IgG4 plasma cells in the affected organ. It's very important to consider this is a multi-organ disease. So in the case you are seeing pre-orbital swelling, dacryoadenitis, you should search for the other organ involvement that sometimes may be life-threatening for the patient. There is a wide variety of the situations you may see here, from the brain, from the actually head and neck, orbits, lung, kidney, liver may be affected in this disease. So you may see the organ distribution, and I put this slide to show you In some organs like a biliary system, like pancreas, serum IgG4 is lower, and the plasma cell infiltration is lower compared to organs like lymph nodes and orbit, especially in the orbital lacrimal gland. So in the case you are taking biopsy from other regions like orbital fat, from the skin, you shouldn't anticipate to see that much IgG4 plasma cells there. So criteria in each organ differs from the other organ. So this is a new entity. For a long time, we assumed that all cases with idiopathic inflammation of the orbit, named as non-specific orbital inflammatory disease, like a trash box. From time to time, one disease is separated from that trash box. So it's more frequent in the Eastern Asia. The diagnosis is based on the clinical findings, imaging, serology, and especially histopathologic findings. The criteria that is established by Umehara, a Japanese colleague, in 2012 denotes that we have 3 subsets of the criteria: clinical examination, serum IgG4, and histopathologic findings. But for actually serum IgG4, you should remember that about 40% of patients with IgG4-related disease do have a normal serum IgG4. So it's not sensitive and not specific for this disease. And we have serious arguments about the diagnostic actual performance of this test nowadays. So for the orbital involvement, so these are actually other conditions that may be associated with high serum IgG4. And nowadays we are thinking, especially in the orbital disease, maybe total circulating plasma blast, maybe a better denominator and marker compared to the serum IgG4 to diagnose and monitor this disease. So based on these 3 subsets of categories, we can define as a definite IgG4 disease probable or possible. Orbital involvement is very frequent. Up to 50% of patients may develop orbital involvement. It can be bilateral in about 2/3 of the patients, and patterns of orbital involvement is very important. The most common form is dacryoadenitis, can be subacute, acute, or chronic. And it's important to consider that dacryoadenitis may be associated with other elements of the orbit involvement or other organs, like in this case with extraocular muscle involvement. We have inferior restriction, and we have serous lacrimal gland and lateral rectus muscle infiltration. Sometimes it's a diffuse fat involvement, like in this case. And it's very interesting that one of the hallmarks of this disease is enlargement of the infraorbital nerve, one of the actual branches of the trigeminal nerve. And in this section, it's important to see that when you're staining the tissue, you should stain both for IgG stained plasma cells at the same power field, at the same view. You should check for the IgG4 plus plasma cells, like on the D and E. This is our own case that's being published now. And salivary glands are very common to be involved. It can be painless, just enlargement of that. Some assume it's like one of my recent cases, this 8-year-old girl was assumed to have mumps with no fever, no marker for mumps, and referred to me for evaluation. I saw that inferior rectus muscle and parotid enlargement and lacrimal gland enlargement. Taking biopsy, it was found to have serum, IgG4 related disease. Sometimes the IgG4 disease manifests as a mass. Like in this case, it was another girl. You may see so it was very interesting. So one of the differential diagnoses for this girl was rhabdomyosarcoma. And I was very happy to find out it was IgG4 disease. Always check the patient for systemic involvement. When you're seeing the patient in the clinic, I asked the patient to tell me about other problems. I examined the patient. I found that erythema nodosum, in this case with dacryoadenitis here, maybe bilateral. And this is the nerve enlargement you may see on the left slide. I'm not sure if I can show you here. On the left orbit, you may see the actually orbital nerve is enlarged. It's very good diagnostic clue for this diagnosis. One of the worst actually patterns, sorry, the slide is gone. One of the worst patterns of this disease is sclerosing type. It's rapidly progressive. It can distort the actually function of the orbit and poor responsive to treatment. This is not my case. I adopted from Rachika. Sometimes the excretory lacrimal system, like lacrimal sac, can be involved. Scleral and conjunctiva can be involved both unilaterally and bilaterally, and uveitis may be associated. And the dark side of the IG4, aside from the pericarditis, sclerosing cholangitis, nephritis, glomerulonephritis, pachymeningitis, is increase the risk of malignancy, especially the lymphoma. It's estimated to increase the risk of lymphoma to 10%. But other kinds of the actual malignancies, like lung cancers, colon cancers, may happen in these patients. So we always need to check the patient for these kind of the problems. So this is a diagnostic criteria for actual different organs. You may see it's different. And once again, the serology can be helpful, but its diagnostic performance is not that much high for the patient. One of the good things when you work up the patient is check the PET scan to find out the avid area that actually show the involvement of the other parts of the body. On the superior left, you may see bilateral lacrimal gland involvement and both submandibular glands in this patient. Histopathology is the mainstay of the diagnosis of the patient. We do not diagnose this IG4 disease by serology, it's by histology. And we have criteria here. I don't want to come for the details, but it's necessary to see the typical pattern, different criteria we have to actually fit for the patient. About the treatment, in a minority of patients, spontaneous resolution may happen. In the case that's silent, we do observe the patient, not actively treatment. We should remember the relapse is very common. Always ask the patient to come after for follow-up or actually check the patient. The mainstay of treatment still is corticosteroids, and there are different protocols. I may talk about that, but we should remember that relapse is common. My protocol is now to give a maintenance therapy, not just by steroids. I use the actually steroid-sparing agents to keep the patient under control. And one of the famous and actually easy to remember protocols is to give 30 to 40 milligrams of prednisolone over 8 to 12 weeks, like 3 months, and slowly taper it during that 3 months. The initial response is 90 to 100%, but relapse is 70%. Always think about relapse. These are the other other agents that you can use. Rituximab is the most famous. And actually, now we have a good systematic review showing that the rituximab is the most actually common, most effective agent to control the disease and decrease the chance of the response, recurrence, sorry. Thank you very much for your attention.
Yeah, we have some time, so we can go for some questions because we are 5 minutes earlier if you want. We don't have time? Okay. So, you want a question? Okay.
Yeah, excellent presentation. So, when you have mentioned that the infraorbital nerve was involved in most of the case, something which differentiates IgG4 disease, which I have found in my practice from the normal, orbital inflammatory disease, is pain. Most of these patients have very painful inflammatory symptoms, and possibly most of these cases have perineural infiltration and inflammation. So there is a neuritis component, which is very common in IgG4 disease. And that kind of, puts it apart from the other inflammatory disease. Do you have any comment on that?
Very important. Despite the high frequency of the trigeminal branches involvement, the patient has no symptom, has no pain. And it's because the degeneration of the nerve doesn't happen. We have just infiltration of the plasma cells in the nerve. The histopathology findings has been well described, and although the nerve is enlarged, but the patient has no symptom.
And do you add methylprednisolone intravenous as a treatment modality? Yeah.
Yeah, very good, actually, question. In the case that I'm facing with sclerosing type, apical involvement, diffuse types, I usually start with IV methylprednisolone. This is my protocol to attack the disease, then bring it under control, and then go to maintenance therapy. So I usually do not continue with steroids. After attacking the patients, I go toward the other agents and control that disease with other agents to avoid the complications of the steroids.
What is your favorite agent? What is your favorite agent?
I use infliximab, adalimumab, and sometimes rituximab. So with 2 injections, it's amazing. With 2 injections, the disease slips. But with the steroids, from time to time, we will see recurrence.
Dr. Fairuz, Professor Fazad, thank you for the discussion. Next talk, Dr. Professor Mahmoud, the one-stage surgery for thyroid-related orbitopathy for 10 minutes. Thank you.
Fine. I try to be as short as possible. And actually, this is about the one-stage surgery for TED, or combined simultaneous oculoplastic procedure in thyroid orbitopathy. And actually, in one study, 13% of patients with TED had eyelid surgery, 9% strabismus, 7% orbital decompression. As a general guideline, surgery is not advised until euthyroid state is maintained and thyroid eye disease has been stable for at least 6 to 9 months. The stages are active and inactive case. The classical teaching for management of thyroid orbitopathy is orbital decompression first, for high intraorbital pressure, of course, and so forth, and then management of muscle imbalance, the squint, and then eyelid retraction, and fourth, the blepharoplasty, which is 6 months apart. That means the surgical process is planned over 2 years usually, and so forth. However, these guidelines are changing now. And I will see this patient who has, I showed you his picture before, and actually he has run into this actually with the concealed ophthalmos. I told you, no proptosis, but he had remarkably very high intraorbital pressure in retropulsion. And in a neuroimaging, it shows that the muscle fills the whole orbit. There is no place for fat. And he had restrictive muscle disease in all directions. And actually, visual acuity was down to hand movement in one eye, counting finger in the other. And he has straight ahead optic nerve compression in both eyes. He was a school teacher, was referred to us, so what we could do, and actually we did decompression. No, that was in the same day, bilateral orbital decompression, 3-wall orbital decompression, and his visual acuity improved to 618 in the right and 6.9 in the left. And that was the first stage. The second, actually, when he came, there's combined horizontal muscle surgery and blepharotomy. Okay, that was in the year 2001 and so forth. However, he had residual dystopia, hypertropia, and in the right eye. And then we did the adjustable suture procedure, and this was the third stage. And his blepharotomy as well was done before, and actually, he became functional again. Now, why combined procedure? The combined procedure is not uncommon in practice in ophthalmic surgery, and this has been addressed many occasions. However, the issue of combined surgery wasn't really discussed in the oculoplastic surgery, though we need it badly. So what I did is that I reviewed all orbitopathy patients that had been operated by the surgeon, that's me, as a combined procedure in the last 20 years were reviewed as indication, type of procedure, time of surgery, complications, and whether the patient needed another interference or not, and the patient were undergone combined procedure, okay, with orbital surgery and so forth. There is combined procedures in one group. This is group one, those who had simultaneous combined orbital decompression and muscle surgery with or without eyelid. The group two had staged muscle surgery. Okay, and this is an example of the combined procedure. In the in the left eye, he has dystopia as well as a proptosis, and he had orbital decompression and muscle surgery in the same setting. Okay, and this is the patient before the surgery, proptosis and severe inferior rectus tethering, and this is him after the surgery where we did the decompression and we did the inferior rectus recession at the same time. And actually there is another patient who is 55-year-old with bilateral exophthalmos and bilateral three walls orbital decompression was carried on, bilateral blepharotomy was done. That was in the year 2016. And this is actually after 5 years. Actually, very good results, single surgery, one-stage surgery. And this is another school teacher. He came from Saudi Arabia at that time, and unilateral orbital decompression with compression. And he asked for the left eye, actually. And at that time, I did the cutaneous incision, the medial cutaneous incision, and actually he had a little bit problem with the cautery and so forth. But we did very good decompression and blepharotomy in the same time. Now, this is the 33 years old with asymmetrical proptosis, gross dystopia, and chin position. That was in the year 2021. And actually, he had chin elevation, and he was crippled. He cannot drive a car, and he had very bad dystopia and very bad vertical diplopia. For whom we did the bilateral orbital decompression and generous inferior rectus recession. Okay, hopefully. There is a video here. Hopefully it will show. طلع شمالك يمينك فوق تحت دغري علي ممتاز ممتاز احنا عملنا عملية واحدة صح؟
نعم صحيح.
It's one single surgery, orbital decompression and blepharotomy in the same site, in the same time. And only 3 out of 32 patients needed further muscle surgery. And these are the diplopia in 2 cases was vertical diplopia, horizontal diplopia, and was ptosis in the 3rd case. And actually, this is where I thought I did a 3-wall orbital decompression for a case with a spontaneous global luxation in his right eye, because it comes in out while he's sleeping. This is where I actually I regretted. I regretted that time I didn't do the blepharotomy at the same time. You cannot really work in the recommendation what is mentioned in books and adhere to it. You should manage cases in its own merits. The results show that 32% with 52 eyes had combined simultaneous procedure, orbital decompression with muscle surgery, horizontal or vertical, and eyelid retraction. Only 3 patients of the 32 needed another surgery. While group 2, there were 25 patients with 40 eyes had stage surgery, approximately in a year period of time. The mean follow-up was 3 years. The changes in the margin, the reflex distance, were not significantly different among the 2 groups. The improvement of diplopia were not significantly different among the 2 groups. And in conclusion, simultaneous orbital decompression with strabismus and eyelid retraction does not affect the outcome of orbital decompression in the term of proptosis reduction and resolution optic neuropathy. Improvement of the diplopia and eyelid position were comparable to the outcome of the staged surgery. Although it made the operating time slightly longer, the combined simultaneous oculoplastic procedure with orbital decompression would have a favorable outcome in many occasions as it shortens the recovery time and has a lower cost. This recommendation has been also achieved by others, Zycorant, Uni, and so forth, and actually people are doing it now, actually, and more publishing good results with combined procedures at the same time. Thank you for your attention.
Thank you so much. We're running out of time, so let's go on to the next speaker. May I request Dr. Sameer Karma regarding orbital fracture, trapdoor fracture. Over to you. And the next speaker will be Dr. Khaled.
Good afternoon, everybody. My name is Sameer Karma. I come from the beautiful city of Amman. I will talk to you quickly about a very important neglected problem, trapdoor fracture. Unfortunately, we as oculoplastic surgeons and ophthalmologists, we treat the floor fractures, orbital floor fractures, as one unit. This is something which has to be really taken care of. We are talking about totally different problem. Trapdoor fracture is a peculiar type of orbital floor fracture which has to receive proper attention because it is life-threatening. It is unlike many other oculoplastic or ophthalmic problems. It's life-threatening because it can cause oculocardiac reflex, bradycardia, systemic problems, nausea, vomiting, fatigue. This is the first fact. The second fact is that crucial and quick management is vital because if you leave the tissue entrapped there, it gets ischemic and the game is you are losing time. Success is decreasing as you waste time. So you have to be prompt in your management, in your assessment and making the accurate diagnosis. It needs totally different surgery from the classical orbital floor fracture. If you did not diagnose and know that this is a trapdoor fracture, you will probably, as most maxillofacial surgeons will do, they will think that this is a floor fracture. They will treat it just like any other floor fracture with a huge mesh and the battle is lost. And then he will have to go for another 2-3 further surgeries to try to solve the problem. This is the classical orbital floor fracture we see with massive disappearance of the bone and herniation of the contents. Yes, this needs mesh and needs RF, orbital floor reconstruction and reconstruction of the floor. Yes, I agree with this. But when you have the classical trapdoor fracture, when you have a very small fracture, by definition, the fracture size is very small, as you can see here. The bone, very minimal crack with huge or amount of fat and periorbita being herniated. That's where you should use your brain matter and say, my goodness, this is trapdoor. This is not a floor fracture. So you see how much limited the movement because the bone in children is membranous and the wave of physical trauma has caused the crack of the sutures and something has got stuck there and it's stuck there, the bone recloses. You have to use physics to understand the pathophysiology of the fracture and the management because surgery depends on understanding this, what I just mentioned. You will see another example. This is what they call as white eye blowout fracture because it has pathognomonic signs It's different from any other orbital floor fractures. Why it's different? Because there will be minimal bruising, not much edema or bruising. But there is gross limitation of eye movement in the vertical gaze in particular. There are systemic complaints, nausea, vomiting, bradycardia, fainting, fatigue. So this should ring a bell that, my goodness, this is something different. There will be no or little in ophthalmos because the size of the fracture is very minute. There is no justification to place a mesh. Rather, mesh usually is the problem. When the maxillofacial conventional surgeons, they use their huge meshes, and that's what makes fibrosis and the problem further more difficult. The management. You have to keep always in mind that the fracture is as a wave of energy. There is a crack in the suture and something has got stuck there. So you have to reverse the mechanism of injury. You have to go in, widen the suture, use your transconjunctival approach as a definition. Use force duction test. Start with force duction test. Whoever has done this, I'm sure many of you have done this sort of fracture repair. You will not miss that the globe is stuck. Use tooth forceps on the inferior rectus. Try to elevate the globe. You'll find it stuck, frozen to the rim, in fact. So that's where your starting point is. Transconjunctival incision, dissect the periosteum, and you will come face to face with the fracture, with the herniated and stuck contents. Widen your fracture. This is against the routine work. Widen the fracture. Lift out the entrapped contents, and you do force duction test. You will immediately feel that it's going. The globe is going, is moving. My goodness, I won the war. That's the end of the surgery. No sutures, and the surgery is done. Ask your anesthetist to stop the patient from the general anesthesia because the problem is gone. No mesh, nothing to use at all. I usually spend 12, 15 minutes maximum repairing this not because I'm a hero, but because I know the pathophysiology of the fracture and I know how to solve it. I have seen many morbid cases when they go to the maxillofacial surgeons and they know nothing about this trapdoor fracture. I do at least once a month a trapdoor fracture, and this is my routine practice, and I find that I can solve it easily because I understand the pathophysiology. This is the force duction test, and here you go, I'm finished. If you want to ask me anything, because I might leave, in fact, in a moment. I'm sorry, Dr. Mahmoud.
Any question for Dr. Samer? And anybody does blowout fractures here? In this room? Some orbital surgery. Okay, fine. I don't think it is possible for the general ophthalmologist to do. You need to have some practice with the exposure of the lower fornix and the transconjunctival and so forth, of course. And you are using celastic.
In fact, Dr. Mahmoud, as I mentioned in my talk, that the size of the gapping of the bone and the amount of bone loss is insignificant, in fact. So the less is more, as they say, less is more. In fact, I find no need to place anything physically which can do any harm.
You free the muscle.
Yeah, you can use Surgicel if you like, because this fracture size is small, tiny, and it will not herniate because the amount of the gapping is minimal. It will not herniate. The principle when we place a mesh, we want to correct the enophthalmos. We don't want further herniation.
So no stitch surgery at that?
Nothing, sutureless, 12, 15 minutes, and you are done.
Yeah, I'm totally agree with you because unless you enlarge the fracture of the orbit, at that moment you have to put something.
Of course.
Meanwhile, if you just remove the tissue, the trapped tissue, it's good to leave it as it is, because when you do the force reduction test, you will find that the muscle is moving easily, so you don't need to put anything at all.
Absolutely. And, you know, the later you operate, the more difficult the surgery is. I mean, if you operate, what my routine practice is, same day or second morning, I operate. I find it very easy to widen and mobilize the contents. When I get late referrals, you are dealing with stuck fibrotic tissue, you are in trouble, and I give family guarded prognosis because the tissue has gone ischemic and it's stuck. I'm not that confident that I will do this widening easily and reduction of the contents.
Fine. We have to proceed with the last case now, the last presentation.
Thank you, everybody.
Should be, this is 10 minutes. Last but not least, it's our host.
Assalamu alaikum. So, today I will just give a brief updates about the DCR. So, we'll start with history of DCR. So, as a DCR operation, it started 1893 with the Caldwell professor, and it was started as removing most of the part in the nasal cavity, for example, the tubercles and also the nasolacrimal canal duct and also the canal. So they have this idea a long time ago. And then they have improved it a little bit because it was an internal approach through the nasal. And then they started as an external approach with the TUTI in 1904. And since then, it was the gold standard for the DCR to overcome the problem. But it is one of the most aggressive with an external scar, so they wanted to improve it a little more just to overcome the unpreferably having scars in the face. So nowadays they are talking about transcanalicus DCR, which was actually first introduced in 1963. It was only an idea when the laser has been introduced at that time after the Second World War. So they thought, why not to go through the canal, lacrimal canal, and then made another opening over there. And then 1982, the silicone intubation has increased the successful rate of the DCR. So this is a huge good outcome, which was through a small instrument which is placed there for 3 to 6 months. First laser was 1990. So the first operation was done on cadaver. So the idea was 1963, and on cadaver was studied in 1990. Then, with the time, the laser has been improved. So they start with different type of YAG laser. 2000, they started the diode laser, and it's important to know that the wavelength of it, it's 810 nanometer. It has less damage to the tissue and has insufficient osteotomy. So we will talk about this later on, how did this also improve in the last 20 years. So that was a brief history about the how the DCR started and where we reached. And now for the diagnostic method, as a surgeon or before planning the DCR, we have to check most of the part of the anatomical part, for example, the lid, punctum, if there is any abnormality, because sometimes with epiphora, we might mix ectropium and tropium with that, so we have to make sure that the patient doesn't have any other reason for epiphora rather than the blockage of the canal. Otherwise, if we open the canal, but still the epiphora will be there. And also, I have seen many patients that they go to CT scan, MRI before they are doing the dilatation and irrigation of the canal. I think it's more convenient to do the canal dilatation and irrigation before planning to do any CT or MRI, because it's almost a clinical diagnosis for them. Some cases, for example, we have to be very clear and very obvious to the point that they don't have any nasal abnormality, because I think 40 to 60% of the cases which are coming with EP4 and blocked canal, mostly they have a chronic sinusitis or nasal deviation, or they can present after a short period of flu. So that all has to be excluded, otherwise the successful rate of the DCR will not be as convenient as we wanted. So, external DCR, still the gold standard. Successful rate very high, 90 to 94, but always there is an alternative. And I think it's one of the operations which will be continuing to be done even in our days now, because not all the transcanalicus or nasal DCR is coming with high successful rate, and there are some alternative things that can present with the patient, for example, tumors, or if we want to have a biopsy, which will not be done only with the external DCR, the gold standard. Disadvantage, medial canthus disturbance, and also the skin incision, this destruction of the tissue, and it's always a surgeon dependent. So, and now we have the advantage and disadvantage of both the endonasal and the transcanalicus laser-assisted DCR. Both of them have almost the same advantage and disadvantage, with the minimal inflammation, ecchymosis, and also edema of the eye or the lid, and mainly no scar tissue. This which has encouraged the patient to go through this rather than the external DCR, even if the external DCR has higher successful rate, but still they want to do the operation only because of no scarring. Bleeding also minimal comparing to external DCR, fast recovery, risk of inflammation is less, and some cases for endo or transcanalicus laser-assisted DCR, we can do it under local anesthesia or sedation, because it has minimal bleeding and minimal irrigation which you needed for the operation. So, whereas the disadvantage, contraindication, as we said, sinusitis or acute sinusitis and neoplasm in the sinus or lacrimal canal. So we cannot do both of them, transcanalicus laser-assisted or the endonasal DCR. And those are the dacrylithiasis and the canalicular obstruction are also a relevant contraindication for that. So the message to take home, external DCR still is the gold standard with highest successful rate, but endonasal and transcanaliclar laser-assisted DCR also a very convenient alternative with much more higher advantages, and nowadays it's becoming the first line treatment in most of the clinics, just because it's had less destruction of the tissue and less disadvantage. So, thank you with that. I came to the end.
Thank you, Doctor. It was very helpful. A couple of questions we have. Please, Dr. Farzad.
Your nice presentation. So about the contraindications, I would like to mention that colitis is relative contraindication for both external and endoscopic and transcranial for any kind of the DCR surgery, because the problem is something else. Regarding the tumor, I would like to mention that in the case that you have diagnosed, you have some possibility about the lacrimal drainage system neoplasm any kind of DCR is contraindicated. But sometimes you go through the operation, you find out your lacrimal sac is bulged, like a tumoral involvement. So it's very important that the surgeon should be brave enough to stop the surgery, take biopsy, and do not do DCR and come out. So never ever open another compartment when you have tumor in one compartment. It's really, really important. About the insertion of the tube, do you want to make any comments? Do you need to put a silicone tube in for DCR?
I usually do that, all of the cases.
You know, there are some debate. There are some RCTs that's showing for the PANDO, primary nasolacrimal duct obstruction, for both endoscopic and external DCR. Putting the tube does not increase the chance for success rate. But for the recurrence or failed DCR, that's true. In the case you have canalicular punctal stenosis, it's important to put the silicone tube as well. But sometimes I agree with you. There are some techniques for endoscopic DCR that you use the tube to push the flap aside and keep that flap aside, not just for keeping the lacrimal drainage open, but just actually pushing the flap aside. Sometimes I use that technique with the tubes as well.
Well, I try to be on the safe side just to keep it over there for 3 months. Maybe the patient will complain about tearing afterwards, as if we didn't do any operation. But after 3 months, when we remove it, I'm 100% sure that we did all what we needed.
But for laser surgery, I think it's kind of outdated. I'm not sure about my colleagues here. Do you ever do laser surgery? What about you?
No, I don't.
Okay. So do you do laser surgery?
Yes, I started in Dubai since June this year. I practiced in Germany in a small village, but they have most of the oculoplasty surgery, which is done in Germany over there. And I think that they started it since 2016. My chef, he wasn't convenient with it because of the previous experience that he have with the laser, transcanaliculus, and he said it will not work, but we will try. Since 2016, I was planning to go back to see the result of it, like 3 years after that. But unfortunately, we were trapped in COVID. So I extended the journey, and I went in 2022. The beginning of this year, in February. So they collected the data for the past 6 years, and they are doing only transcanaliculus DCR. The thing is that the laser, as it has improved over the past 20 years, so the laser machine has been more targeting the osteome just to penetrate it and not to cause an extra distraction to the surrounding tissue. And so now they are doing it as a first-line treatment unless there are any contraindication, for example, tumors or whatever, they definitely go with it.
I assume you use diode laser, yes?
Yes.
So I remember one colleague in Basel, I'm not sure if you visited Basel, he's still doing laser, one of the
what's his name?
Persons that doing laser surgery.
Professor Merrick?
Yeah, maybe.
Yeah,
so,
retired.
I would like to mention, we have RCTs published about 20 years ago in ophthalmology. That's compared the laser surgery to the cold steel one, and they used diode laser. They concluded osteotomy is smaller, we have more sharp formation, more scar formation, and about 70-75% success rate compared to above 90% success rate with cold steel endoscopic surgery. So after that RCT, maybe my colleagues agree with me that we prefer the cold steel one.
Thank you, Dr. Farzad. Thank you, Dr. You're lucky to have these good results. We'll stand up for a short picture.
May I call on Dr. Basil Faouri and Dr. Walid Ghubashi to join us? Okay. So our next session is going to be on glaucoma, and you know how we glaucoma specialists always suffer from hypoaudiensemia. So we decided to make a session today targeted to all non-glaucoma specialists. It will look at the comorbidities that we all face with glaucoma in the different specialties, spanning the basic to the recent updates. So our first speaker for the session will be Dr. Winnie Nolan, who will talk about angle closure for the cataract surgeon.
Thank you, Yasmin. Is it possible to turn the lights down? It's quite dazzling up here. Thank you, and thank you for inviting me here to Dubai. Okay, so good afternoon, everyone. My name's Winnie Nolan. I'm a consultant in the UK, and I've had a research interest in angle closure for quite a long time, and so have quite a lot of experience of operating on these eyes, which can be quite tricky. So what I'm going to do is just outline some areas in where you can try and anticipate problems, look out for them, and maybe prevent them as well. So if we think, first of all, when you're looking at a patient in clinic, what might be the eyes that are at risk of problems and what those problems might be? So I think one of the most important things to look out for is hypermetropia and small eyes. Small eyes often mean big trouble, and that, I'd say, is the most important thing you need to try and identify. Other things that would flag up potential problem are an attack of acute angle closure, because that can result in an ischemic iris, corneal endothelial loss, and zonular weakness. And also be aware of if they have angle closure glaucoma, what the degree of damage is to the optic nerve, because this, in advanced cases, you can get intraocular pressure spikes, which can be quite difficult to manage. And so just be a bit wary of people with very advanced angle closure glaucoma may not always do well with a lens or cataract extraction. So in your clinic, get your biometry and look at their refractive error. And spend time on counselling patients. So I discuss the known potential problems, which are aqueous misdirection, depending on the axial length. Cystoid macular edema is commoner with more inflammation after surgery. Corneal decompensation, particularly in those patients with a very shallow AC and previous acute angle closure. And the refractive outcome is not always that predictable. And obviously, if they have a big hyperopic refractive error, you need to think about the other eye as well. So with regards to biometry, I think now with the sort of third and fourth generation measures and calculators, there's plenty of options. I think often it still comes down to something like HOFA-Q, which we have a sort of big amount of information on, which does fairly well compared to the other calculators in minimizing kind of post-op refractive surprises. I would caution you in hyperope to aim for emetropia or slight hyperopia. That's what they're used to. They don't really like being myopic, and they often have very good accommodation. So they'll do very well with that aim. And if they're very hyperopic, a bit like a myo, aim for about +1 or something like that. And don't do piggyback IOLs, because that can lead to problems. There isn't that much space in the anterior chamber, so you can get problems later down the line if you have 2 IOLs. And this is just some work from the National the Cataract Database in the UK, which has vast numbers of cataracts looking at the different formulas. And you can see there that the HOFA-Q, which is, I don't know if that's working. Anyway, it's the bottom one with the triangles, and you can see at the lower axial lengths, you're getting less error. And again, Barrett's quite good, the newer generation ones are quite good, but you get, I think we've got a lot more information in the database with HOFA-Q. Endothelial cell loss is connected to the distance between where you're working and the cornea. So the smaller the eye, the more likelihood of endothelial cell loss. And if you've already had some kind of surgery, or an acute attack, you'll have lost endothelial cells as well. So these patients may be at higher risk, and a post-operative IOP spike can also make them vulnerable to endothelial cell loss. So worth cautioning them about that and protecting the cornea. Okay, so just some tips which I'll show in a video as well. So the iris can be quite floppy and the chamber's shallow, so it's worth doing very long tunnels for your paracentesis and for the main wound, and you can use intracameral phenylephrine and iris hooks if there's posterior synechii or a ring. If you have a poor view due to corneal edema, which sometimes you can see in phacoemorphic glaucoma, you might want to reduce the pressure with general anesthesia and use vision blue and sometimes do corneal debridement. And if you have a very shallow, unstable chamber and a bulgy vitreous, you can use an anterior chamber maintainer, particularly after you've got the lens out. Be very careful with hydrodissection. And also ask your anaesthetist to use a small volume if you're using subtenons so that you're not pushing everything forwards. And just be aware of zonular weakness. Can we run the video, please? Yeah. So this is actually a 24-year-old with recurrent angle closure symptoms. You see I'm doing a very long tunnel there. I'm putting HPMC in the eye first to do a soft shell technique and protect the endothelium. Again, a long tunnel here, so you can see this iris, you'll see later, is very floppy, so it just wants to come out of the wound. Now this is a clear lens, so it's quite easy to actually get it out, but you need a good technique. These young hyperopes, the rexis can travel out very easily, so use something like Helon GV and keep control of your capsular rexis and don't make it too large. And then when you do hydrodissection, be careful, pump out some of the viscoelastic, be very focused on your hydrodissection, so you're not just injecting it into the vitreous, because you can get this phenomenon where you almost get an aqueous misdirection on the table, and I think that's due to too much fluid going behind the lens. Once you've got that bit done, it's very easy in a clear lens to get this out. And she's got a nice dilated pupil. So there isn't anything else to say really about this except beware of the floppy iris, which is a pain if you get it. And don't leave the eye too firm at the end. That's another way to avoid a pressure spike. So post-op, you can get the corneal decompensation. So post-operative Diamox is good. Counsel the patient and maybe give them atropine for a while after surgery and on the table. And give them extra steroids. So 2 hourly drops is a good idea. This is just a case of a 38-year-old woman referred with early PACG and high pressure. She ended up having a clear lens extraction, which was her choice. And these are her anterior segment OCTs pre-op showing appositional closure. And she had quite a small axial length, 19.85. So we warned her. And post-operative, she was fine. She did have an outcome of about -1, which wasn't what we predicted. And her pressure was good, but she then developed a high pressure and a myopic shift. And you can see from the scans on the right that the volume of the anterior chamber has changed. So in aqueous misdirection, everything shifts forward. And that's what she had. So even if you have normal pressure with a myopic shift post-operatively, have a look at the position of the lens and the pupil. You shouldn't get a forward bowing, iris in a pseudophakic. I haven't got time to talk about management, but I'm happy to if anybody's interested. But these are just the differential diagnoses of a shallow AC post-operative. It could be aqueous misdirection, where you'll get axial, central shallowing, and peripheral with raised pressure or normal pressure. Pupil block, the central AC will probably stay deep, but you'll get iris bombay. And suprachoroidal hemorrhage, everything will be pushed forwards, and you'll see hemorrhage at the back. And effusions are often due to hypotony, but they can shallow the anterior chamber. So in summary, spend time counselling these patients for surgery. It's really important to manage expectations, particularly in clear lens surgery where their vision's good, and prepare for aqueous misdirection, which is difficult and it's no fun to manage. And make sure you look at the biometry preoperatively. Thank you.
And next, Dr. Noha, yeah, we'll keep the questions last. To the, Dr. Noha Fayoumi will talk about glaucoma with the phakic IOLs.
Bismillah ar-Rahman ar-Rahim. Good evening. It's such a pleasure to having me again in this glaucoma session, in this wonderful meeting. Why this topic? Because as you know, the phakic IOL now for the correction of the emetropia is becoming increasingly popular throughout the world. It is reversible refractive procedures and receives the accommodation, and it's a promising treatment for the high myopic patient. It involves placing the IOL in between the posterior layer of the iris and the crystalline lens in the sulcus. The procedure is fairly easy. The lens gently folded and injected into the anterior chamber through 3 millimeter temporal clear cornea incision. And the lens carefully positioned by manipulating the foot plates posteriorly to the iris plane in the sulcus. And the preoperative YAG iridotomy is essential. The potential of the unique complication has been reported, and the development of the secondary glaucoma is very well known, and it can lead from the transient increased IOP to the development of the refractory glaucoma. The most common glaucoma complications are the pigment dispersion and papillary plaque, and there is an overlap between them because the excessive volt of the lens can cause the direct compression of the angle or malignant glaucoma, and the precising the size of the lens which avoid the excessive vaulting, which can lead to anterior displacement of the iris and iris chaving, and eventually pigmentation with narrowing the angle structures. The central flu is a technology, has a central opening in the lens, which eliminates the chances of the papillary plaque and also enhance the needs of peripheral laser iridotomy. The glaucoma account about 4% of the post-operative phaco-IOLs, and it can do an open angle mechanism from the retained viscoelastic steroid response, pigment release or inflammation, or can due to closed angle mechanism like an adequate PI or excessive lens fold, which can lead to the malignant glaucoma. Or we have to keep in our mind or don't ignore the missed primary glaucoma. The identification of the underlying cause of the glaucoma firms the crux of the management. There may be a response to the intolerant anti-glaucoma medication, or underwent our patient to the peripheral laser iridotomy. If there is no PI will done prior to the surgery. Post the explantation of the phakic IOL or filtering surgery like trabeculectomy are successful in controlling IOP in refractory cases. How we can choose between them, it depends on the cause of the glaucoma. It's malignant glaucoma, this is required to explantation the IOL. And this brings us to an important issue we have to pay attention to it, that this lens is accepted as to correct the high and to extreme myopic patient. And as you know, the optic disc in the high myopes are usually tilted, large, and associated with peripapillary atrophy, which can make difficult even for the experienced ophthalmologist to identify the glaucomatous changes. Visual field may be difficult to correlate with the disc, and this is due to chororetinal degeneration. High myopes are also predisposed to open-angle glaucoma. For all this, we have to keep in our mind the missed primary open glaucoma as a strong possibility. And this is also a good opportunity to point out an essential message for all the refractive surgeon that the performing refractive surgery on a glaucoma patient certainly creates two kinds of issues. The first one is completely medical, and the second one is medical legal, could put you at the risk of lawsuit. So you have to take a picture of the optic nerve before and after the surgery, and this is for the legal protection for you. Explantation of the phakic IOL with the trap as a combined surgery indicated in advanced pigment dispersion glaucoma, in malignant glaucoma, and in phacomorphic glaucoma in high myope. To conclude, management glaucoma in eyes post-operative phakic IOLs creates some challenge for the ophthalmologist, and the essence of the management is to identification the underlying cause of the glaucoma. We have to keep in our mind and detect primary open-angle glaucoma, and the explantation and the filtering surgery are successful in controlling the IOP in refractory cases. Thank you.
Thank you very much, Dr. Noha. Next, may I present call on Dr. Ali Sheikha to present on refractive cornea surgery and glaucoma.
First of all, thank you for the invitation. My speak at this point, I will go through as introduction. When we speak about refractive surgery, not as usual for glaucomatous. Glaucomatous always we speak about older patient. Here we speak about young patient. Why this is? If we look this study from King Saudi and Arabian, who are looking for refractive surgery, which refraction error? More than 90% with myopic, hyperopic less than 5%. There is combination around 78 with astigmatism, low to medium in 69, and almost 9% with high astigmatism, more than 3 diopter. Myopia is a big problem for all the world. Is from this increased very, very quick. If we look, this is here from 2000, almost 23 of the world is myopic, and 10 of them with high myopia. And this will increase to 50% of the population in 2050, 10% of the population with very high myopia. And this is make a problem if we look. More than this 50 of the population. Now there is many areas of the world as East Asia and Asia Pacific. From now, more than 50% of the population are myopic. Why this is the myopia? Myopia is a risk for glaucoma. For that, if you go for refractive surgery, your role at first to exclude the juvenile open-angle glaucoma. Why? We know this is juvenile open-angle glaucoma in the same group, less than 40 years, the same group. But what is the problem with this glaucoma? This very rapidly progressive, more severely elevated IOP, and less response to anti-glaucoma medication. Mostly you need for surgery. For that, you should diagnose this, because myopia is very high risk in this population, and male on very severe elevation. You should diagnose this. If you diagnose, this is not indication for refractive surgery. Now, if no juvenile open-angle glaucoma, your patient either normal or suspected glaucoma. Suspected glaucoma, you have some problem. Some make the suspect for glaucoma, but if the patient is normal, that means now normal, but maybe in the future will develop glaucoma. For that, there is many bears should be taken care before the surgery. For that, ask your patient about the family history. Yeah, inform your patient you have very high risk to develop glaucoma in the future. Make comprehensive examination. From this examination, measure the IOP. If you have access for more instrument, measure with many instruments for the IOP before the surgery, especially if you have access to instrument not affected with the corneal thickness as the aura or DCT. If you didn't have, at least if you have tonoben, measure the cornea in the middle at the periphery. You will see why. Secondly, make gonioscopy. This should be in your protocol as a refractive surgeon, because documented for hyperopic patient, many cases of angle closure glaucoma attack after LASIK and during LASIK, as that's documented. For that, very important to make diagnosis. For myopic patient, also is very important to make gonioscopy. We see this is angle, this is wide angle, this is I am comfortable. No, should you make this is the gonioscopy to exclude pigment dispersion syndrome. If you didn't find any Sampoliza line, any Krokenberg spindle, if you didn't find anything, only if you find, or you are happy, you find the anterior chamber is very deep at the periphery, at the same at the center, you are at high risk. If you go for LASIK BRK, you are on the safe side, but you have risk for pigment dispersion syndrome or high response to steroid. But more problem, if you say that this is not indication for BRK and LASIK, this patient is contraindication for ICL, because most of this patient have reverse iris, and if you go for ICL, only you press the trigger and you start the problem for the patient. For that, be careful if you find the anterior chamber is very deep at the periphery as the same as the center. What you should do also, OCT visual field and fundus photo, if you can have access, because we know this is the fundus photo is good for documentation. Not all of us can make, but at least dilate the pupil to see, because the optic nerve in a glaucoma patient is very shallow, and you can see the changes in the vessel. But the OCT is very important as baseline for your patient, because there is many changes, and we didn't have database in this group of patients. For that, at least there is thinning on the optic nerve, there is thinning in the RNFL, there is posterior staphyloma, and most important, that's documented, there is temporalization of nerve fiber layer, and that led to red disease. When we make OCT, no database, we found this is red, and most of us saw this, the pressure on the border, this patient may be as a glaucoma. But remember always, this is not any cylinder at the back of diver is oxygen cylinder. This is maybe fire extinguisher. Should be careful. Not everything grid on the OCT. For that, it's important to make OCT as baseline. If you have access for ganglion cell, it's very important. If you're a patient without any maculopathy, is very good relation between the ganglion cell complex and the visual field, and this is not related with the optic nerve head. For that, make OCT and compare. And OCT is not changed with your refractive surgery. For that, you didn't need, if you didn't make any damage for the patient, you didn't need any new baseline directly after the surgery. You should make visual field, because 80% of myopic patients without a glaucoma without glaucoma have visual field changes, same as the glaucoma patient. For that, it's very important to have baseline in your patient. And can you, and there is a change between, because this is the lens make magnification for the target, or maybe the visual field will be different. For that, you need, after stabilization the condition, after refractive surgery, to make a new visual field as baseline to compare with before the surgery, and to make the baseline for follow-up in the future. Also, give all the reading for your patient, give all documentation for your patient, and give the CCT before and after surgery for your patient as refractive surgeon. What you should consider during the operation. During the operation, if you can avoid the LASIK, this will be better, because either femtosecond or microkeratome increase the pressure during the operation. If you can go to the BRK, is more safer, but be cautious, because this is, you need to use steroid for longer time, and this is maybe make steroid-induced glaucoma. More safer nowadays is to go SMILE if this is available, I've indicated. After surgery, why this is important? To look the complications, especially with BRK, to look for steroid-induced glaucoma. For LASIK, it's very important to diagnose pressure-induced stromal keratitis BISC. This is the same as the synonym as pressure-induced interface keratitis, interface fluid syndrome, pressure-induced stromal. What the cause for this? That's the cause is the increased intraocular pressure, and this makes as inflammatory under the flap, on the fluid under the flap. If you measure the IOP, you find the IOP is very low. On the problem is increased IOP on your diagnosis, or this is diffuse lamellar keratitis, and you start steroid. This is steroid inducer. You increase the pressure. This is go on the problem more. For that, is very important, if you have tonopene, at least measure the IOP in the middle at the periphery, and you find a very big difference between the two measurements. And the difference is very important in DLK. This is in the first, second, 3-4 days post the operation. This is happen, and the treatment is steroid. But in BISC, the steroid is contraindication, or should tapered or stop, and should start anti-glaucoma medication. Otherwise, will not find the solution for your patient. And in this case, it's very important to measure the IOP with tonopene at the periphery and at the center. Also, can you calculate the IOP? Almost, this is 1 millimeter for 1 diopter. All this equation, this is published one Egyptian group to calculate the IOP after the surgery. On the best way, if you calculate, you measure the pressure for your patient as same time after the surgery when you stop all the medication, to know how much the change in the pressure in with your patient. If you can do axial length, is very important to predict the risk of glaucoma, because patients with axial length more than 25.5 have risk 16 times more the norm, the patient with less axial length. If you can do, this will be great. As a summary, pre-op, perform comprehensive exam and investigation, monitor your patient regularly in the years after refractive surgery. And always remember, myopia is high risk for glaucoma in the future. Thank you.
Thank you very much, Dr. Ali, for this very comprehensive talk. May I call on Dr. Suresh Gupta to present on post-vitrectomy glaucoma.
Thank you. Very good afternoon, dear friends. I'll be speaking on post-penetrating keratoplasty glaucoma. So with the introduction of more complex and complicated vitreoretinal surgeries and use of vitreous substitutes like silicone oil and gas tamponade, all of us as glaucoma specialists, we are going to encounter more and more such patients in future. And I won't be wrong in saying that we should be friendly with our retina colleagues. Next slide, please. Okay. So no financial disclosure. the incidence is pretty common, and if one study of 285 eyes undergoing vitrectomy found that late onset POAG was to the tune of 11.6%, and another study undergoing PPV for epiretinal membranes of 198 patients found that the incidence was 19.2. So it's ranging from 15 to 20%. And what could be the reason? What are the mechanisms? So the IOP rise could be acute or chronic. So in acute rise of pressure can be because of silicone oil hyperfilling. You have aqueous misdirection, malignant glaucoma can be there, or there can be iris lens diaphragm shifting, again because of either gas tamponade or silicone oil overfill. Then inflammation is going to be there, and it can cause glaucoma by various mechanisms, leading to peripheral dyssynechiae, secondary angle closure glaucoma, or by filling the outflow channels by inflammatory mediators, gas expansion, posturing. All these can cause acute glaucoma. And the mechanism for chronic glaucoma could be your emulsified oil, silicone oil, again affecting the outflow channels. You can have NVI, NVG. You can have steroid-induced component. So all these patients, they receive topical as well as oral steroids. So steroids is a two-edged weapon. It can cause rise in pressure. So how does your glaucoma, especially open angle, occurs after vitrectomy? If we look at post-vitrectomized eyes, there is increase in oxygen in the vitreous cavity because now it's not being used by the vitreous. So this oxygen, how will it affect the eye? If eye is phakic, this excess of oxygen will be consumed by lens and it will have cataract formation. So in pseudophakic eye, this excess will come anteriorly, excess of oxygen. It will be forming H2O2 and free radicals. So this oxygen-free radicals will be affecting the trabecular meshwork at cellular level, leading to decrease in outflow and rise in pressure. The human crystalline lens is good friend of glaucoma as well as retina specialist. So this acts as an anatomical barrier and prevents movement of harmful inflammatory mediators to the anterior segment, and it also squenches the free radicals from surgically induced oxidative stress. And a vitreous surgeon should avoid removing cataract if possible. And phakic eyes, they are reported to develop a delayed raise in intraocular pressure in response as comparison to the pseudophakic eyes. How does silicone oil affect? Again, we see glaucoma to the tune of 11 to 48% in eyes who have received silicone oil. So it can be acute glaucoma, overfill of the vitreous cavity, pupillary block, inflammation, or sometimes patient is having pre-existing glaucoma. And late rise can be the oil is going to undergo emulsification, and emulsified oil is going to damage the outflow channels. You can have NVI, you can have all the problems with the silicone oil. Then gas injection, the incidence of IOP elevation is, it can range from 6 to 65%. And when we are injecting the expansile bubble, it's going to move the lens iris diaphragm anteriorly, leading to secondary angle closure glaucoma, and rise is maximum when volume expansion is at peak. And if you have non-expansile or less expansile bubble, like 20% of SF6 or 12% of C3F8, the rise of pressure is much less as compared to expansile bubble. And remember, when patient is having gas inside the eye, these activities have to be avoided, like traveling by air, mountaineering, or this deep diving, or in supine position. Patient should avoid lying in supine position. And then scleral buckling, sometimes it's combined with pars plana vitrectomy. It can lead to, can we move to the previous slide? So sometimes it can lead to, if buccal is tight, it can compress the vortex vessels, can raise the pressure by moving the iris lens diaphragm anteriorly. So these are the risk factors for high pressure after buccal, tight buccal anterior to equator, or you have choroidal detachment extending to ciliary body. Then NVG, my colleague will be dealing with this in detail in next talk. So if patient has not undergone PRP or has not received anti-VEGF or there is silicone oil, these eyes are more prone to have NVG, and NVG is very, very recalcitrant glaucoma. So we should try our best to avoid this because managing this is a big challenge. So coming to management, treat the cause. So we have to remove the underlying mechanism responsible for glaucoma. So silicone oil, if it has been emulsified, and we can't keep the silicone oil forever in the eye, it has to be removed. You can have better control of pressure. If buccal is tight, loosen 270 bad or decrease the height of the buccal. Gas tamponade, don't use very highly expansile bubble. And if patient is having steroid-induced component, decrease topical or systemic steroids. And if there is depot steroid like triamcinolone, try to remove it. Your control of pressure will be better. So then if eyes having inflammation, steroid topical have to be given. Cycloplegic like atropine works very well in malignant glaucoma. Aqueous suppressant to control the spike of pressure. However, most of them require surgical treatment, and unfortunately trabeculectomy doesn't work nicely. So we have to go for glaucoma drainage devices. Then choice of device again depends on its discretion of the surgeon and availability of the device. If AGV is available, it works well. There is Burwell implant or whatever is available in your area. Sometimes the tube of the glaucoma drainage device, it can be put into the fibrosis around the buccal, and it works well even without the plate. However, complications of implants can be there. Hemorrhage, retinal hemorrhage, tube block, tube erosion, so many things can occur. So many studies are there in the literature showing the efficacy of implant in patients with post-vitrectomy glaucomas. So this study, basically just tube has been put into the fibrosis around the buccal, and that it worked well, and they had control. 85% of the eyes had controlled intraocular pressure. So few of our patients who have undergone implants for post-vitrectomy surgery glaucoma. So carry home message from my talk is it's pretty common. 15 to 20% of these eyes can have glaucoma. Most of these eyes have silicone oil or gas injection or scleral buccal, and mechanism can be secondary open angle, secondary angle closure, inflammation, steroid-induced glaucoma or NVG, and management is mostly surgical with glaucoma drainage devices, and timely intervention is key in saving these eyes. Thank you very much.
Thank you, Dr. Suresh. Our next speaker, Dr. Walid Ghubeshi, will present on neovascular glaucoma management.
So this talk also directed to our colleague retina specialist about neovascular glaucoma. So neovascular glaucoma is one of the most serious types of glaucoma. We all hate this type of glaucoma, and we know it is serious and blind disease. However, it's also one of the most preventable type of glaucoma. So here, prevention is better than cure. Who are high-risk patients? Those patients with proliferative diabetic retinopathy, patients with central retinal vein occlusion. Those two causes are responsible for 2/3 almost of our patients with neovascular glaucoma. And also the third cause is ocular ischemic disease. There's a long list of diseases and syndromes associated with ocular ischemic syndrome, ocular ischemic disease. Just go for those three types and just look for patients with peripheral diabetic retinopathy and central retinal vein occlusion because they are responsible for the majority of our cases. So why retinal ischemia happen? This is some sort of disequilibrium between those angiogenic factors like the vascular endothelial growth factor, interleukin 6, posterior capsule rupture during phaco, aphakia, and vitrectomy. On the other hand, these are anti-angiogenic factors, including the pigment epithelial drive factor, having the lens and with the vitreous in place. So in patient, you're operating for parsiplana vitrectomy. In a patient with aphakia, consider them also with high risk of developing neovascular glaucoma. So we have 4 stages of neovascular glaucoma: the pre-abusus, the pre-glaucoma, open angle, and angle closure. And I believe the two stages of those are manageable and preventable by retina specialists. However, the third and fourth one are not, and they are really serious, and we have to refer for glaucoma specialists to deal. Again, in the first stages, pre-abusus or pre-glaucoma, the pressure is normal, and this is, again, remember, prevention is better than cure. So actively look for neovascularization. Where to look for that? Look for the pupillary margin. This is the first slide. Look for the margin of previous peripheral iridectomy. Look for the angle of the anterior chamber. Look actively for that to prevent this patient from developing glaucoma. If you have any doubt, go for investigations. Do fluorescein angiography, do iris angiography, which can be performed with the same fundus camera, just defocus from the posterior segment to the anterior segment. Do systemic workout, check the blood pressure, blood sugar profile, lipid, kidney. And the prophylactic treatment is possible. You can start with intravitreal injection of anti-VEGF. It gives you something between 3 and 6 weeks of window until you can do effective PRP. Whenever you have established case of proliferative diabetic retinopathy, go for meticulous PRP. If you have a patient with central retinal vein occlusion, with 2 clock hour of neovascularization of the iris or neovascularization of the angle, still this is an indication for PRP. In a patient with ocular ischemic disease, ischemia documented by fluorescein angiography, also go for PRP. This is very crucial for prevention. Also, you can go for doing gonio photocoagulation. If you are comfort with the structure of the angle, you can do it yourself, photocoagulation. Although the parameter is a little bit different, we go for time 0.2 seconds, size 50 to 100 microns, power 100 to 200 milliwatts, only very low power of laser, and apply to the neovascular tufts as they cross the scleral spur. If you are not comfortable with that, refer it to glaucoma specialists who are going to do it for you. This is the end of story of prevention. From now, the pressure is high, stage 3 and stage 4, open angle glaucoma and angle closure glaucoma, and this is the start of our nightmare. What to do at that time? Better to refer. However, you can use all the medical treatments in the arsenal, except the miotics. There was some controversy about the role of prostaglandin analogs. However, there is no clinical evidence enough to prevent or to avoid using of prostaglandin analogs in the development in the neovascular glaucoma. Use topical steroids and cycloplegic to lessen the inflammation, decrease the pain. Use anti-VEGF. You still can help in these patients. Surgical management is going to be the glaucoma specialist job, and from this point, go for PRP whenever possible. Tube shunts, we prefer it now rather than doing trabeculectomy because of the high failure rate with trabeculectomy in neovascular glaucoma. Cytofluorogulation, you can use a transescleral or micropulse. Usually we reserve the transescleral for poor vision, but still we do the micropulse even for seeing patients. So take-home message, neovascular glaucoma is a potentially blind disease. Early diagnosis is crucial. Once pressure is high, it is extremely difficult to treat successfully. And just remember, a clever person solves a problem, a wise person avoids it. Thank you.
Thank you, Dr. Walid. Now, Dr. Yasmin Al-Sayed will talk about glaucoma for pediatric cataract surgeons.
Good afternoon, everyone. So my talk is going to be on glaucoma following cataract surgery. And GFCS is one of 7 types of pediatric glaucoma. It's actually the second most common type after primary congenital glaucoma. So it's the most common secondary childhood glaucoma and one of the most serious causes of late visual loss after successful lensectomy, unfortunately. The incidence is very hard to define because it depends on how long you're following up the patient. So the longer the follow-up, the more you will find more and more of these patients, because there's a lifelong risk of having a high pressure after pediatric cataract surgery. So the range is anywhere from 6 to 100%, depending on how long the studies have followed up these patients. There's also a variability in the definition of glaucoma in these studies, because a lot of them relied on ocular hypertension as a definition because of the difficulty of examining the discs and performing visual fields in these patients. So a lot of these ocular hypertensions may not turn eventually into glaucoma. There are several risk factors. A younger age is probably the most important, but there are other factors like microcornea, microphthalmia, undergoing different procedures like membranectomy. These patients are at high risk of developing glaucoma over their lifetime. The pathogenesis is still uncertain, so there are chemical theories that have to do with inflammatory cytokines blocking the angle, mechanical theory, and there is a developmental delay. If we intervene early in the eyes of these young children, it may affect the angle development. There are other causes that we can easily spot, and these contribute to the early onset glaucoma, which is easy to spot. It's not the malignant type that appears years later insidiously. So you can spot a steroid-induced glaucoma if you stop the steroids, synechial angle closure or pupillary block, and these can be treated accordingly. So these contribute to the acute type, which appears in the first few weeks postoperatively, but the most serious type is the chronic type of glaucoma that presents itself on average 1 to 12 years postoperatively. And there's an annual incidence of around 5% in the first 7 years. So if we don't keep on looking for glaucoma and warn the parents of the risk of developing glaucoma in their children, then it can easily be missed. There are special considerations and challenges with with glaucoma following cataract surgery in the pediatric age group. First of all, they tend to be asymptomatic, unlike primary congenital glaucoma patients that come with corneal clouding or globe enlargement. For some reason, with glaucoma following lensectomy, the globe does not grow as rapidly or doesn't grow at all. And again, in terms of signs, you may not find the HAP stria or the increase in corneal diameter. The IP is often overestimated because of the cornea thickness. It's very difficult to visualize the disc unless you're really vigilant and looking for it, up to doing EUAs to examine it, but sometimes it's even impossible with that due to the lens remnants, the narrow pupil, and the nystagmus if the patient is awake. And of course, doing a visual field assessment in this age group with low visual potential may not be always feasible. And the major problem is that the glaucoma manifests late. When all has been said and done, the patient is coming back for glasses, or they stopped even returning back for their prescription. So if you're not looking for glaucoma over their lifetime, it's very easy to miss. One recommended frequency of screening is to teach the parents to have their child examined every 3 months in the first post-operative year, and then twice annually for 10 years, and then annually for the rest of their lives. Of course, you can modify the frequency according to the risks that can be individualized. IOP measurement in these patients is challenging. We know that the cornea thickens in the range of 800 and 900 microns, so we tend to overestimate the pressure reading, but even though in some patients the cornea is thick and the pressure may be overestimated, they still do develop glaucomatous optic neuropathy. So regardless of the cornea thickness, the most important thing to look for is the optic disc appearance. If the cupping starts to increase, then there's something going on there. Another question is the IOL protective? Because originally we thought that aphakic and pseudophakic glaucoma, we started out 15 minutes late. So yeah, if anyone, yeah. For a while there, we thought that putting a lens would prevent the cytokines or whatever it is that is increasing the pressure
from going and blocking the angle. And earlier studies showed that aphakic glaucoma is more common than pseudophakic glaucoma. But with more and more studies that started to stratify aphakics and pseudophakics according to the age groups, it turns out that there's a confounding factor that most of the aphakic patients are of the younger age group, which is a known risk factor to develop glaucoma overall. And on the other hand, they're followed up for a longer time. Being younger, they've seen for a longer time, so you can spot glaucoma more often. And finally, because aphakics, if the patient is left aphakic, it's like he's more likely to have had a problem with the surgery or to have an associated comorbidity like microcornea or a small globe. And with more and more studies, including the infant aphakia treatment study, the studies are unfolding the fact that both aphakic and pseudophakic glaucomas, if you make up for the other confounders, have similar incidence. So the treatment can be challenging. Medical treatment, only 50% of the patients would respond to medications. Trabeculectomy has a very poor success rate, down to 0%, and it also precludes the use of contact lenses because of the bleb. Site reconstructive procedures are an option, especially in patients with low visual potential, but you need multiple treatments usually over the patient's lifetime, and there's always the risk of phthisis, especially in microphthalmic eyes, which are common in densectomy patients. Glaucoma drainage devices used to be the best option until recently, and they allow the contact lens use, but there's the risk of developing suprachoroidal hemorrhage, especially if you develop hypotony in aphakic eyes. More recently, angle surgery has come forward as a very viable option, a very promising option in treating these patients, especially if you treat them, if you open up the angle circumferentially, either with an illuminated microcatheter. We published one study on doing it through two-side trabeculotomy, and that's performing two trabeculotomies 180 degrees apart in the same sitting, one based on the supranasal quadrant and the other in the infratemporal quadrant. So you're basically covering as much of possible of the angle, and the results showed around 50% IP reduction at 1 year, and 60% of the patients were off medications by the first year. Only 1 in 10 went on to have another glaucoma procedure. But the problem with angle surgery is that it bleeds, and in aphakic patients, the bleeding can pass posteriorly to the vitreous, and one eye out of the 33 in this study required a vitrectomy for vitreous hemorrhage. So now I'm shifting to doing that, which is basically the same thing but through an ab-internal approach. And if you have a clear view of the angle, you can do the circumferential incision through an ab-internal approach. There aren't many studies that have looked at that in particular in aphakic glaucoma, but well, we'll wait and see. So to sum up to half the pediatric cataract patients will go on to have glaucoma over their lifetime, so it's very important to keep an eye and be vigilant in the examination. Mostly monitor the optic disc. It's your the thing to follow up and diagnose glaucoma in these patients. If they develop glaucoma that is not responding to medications, then angle surgery or glaucoma drainage devices are the preferred treatments to go for, especially if you incise the angle circumferentially. Beware of vitreous hemorrhage in these patients or expect it and counsel for it. Thank you very much for your attention. So I think we have some time to take a few questions for each speaker and for the panel. My first question to Dr. Winnie and to the panel. So when you have angle closure glaucoma, what is your threshold to combine phaco with glaucoma surgery? When is it that you expect that phaco alone would be effective, so you would do phaco alone? Or when is it that you combine it with glaucoma?
Yeah, so most of the time I wouldn't combine it with glaucoma surgery for angle closure, and we don't tend to do that much phacotrabeculectomy because of the trabeculectomy doesn't seem to work as well. So I think the cases where I'd actually do a primary trabeculectomy with a clear lens would be patients with very advanced glaucoma.
Mm-hmm.
So, 10 degrees of field, or maybe sort of loss of, 70 to 75% of the field. And then the other scenario would be extensive synechia, like more than 3/4 of the angle.
Right.
So it's not very often, but I think you have to weigh up the risks of doing a trabeculectomy in an angle closure eye, which can be quite high if it's a small eye, versus the risk of doing a lens extraction and then not getting the pressure under control and it goes out of control. Then you have to do an urgent either trabeculectomy or tube. Obviously, if they've got cataract, then again, that balances things as well. But I had one patient who was referred to me who had a cataract surgery, advanced angle closure glaucoma, and then his vision had dropped due to CMO, and it never recovered due to the inflammation. So, and the pressure was high as well. So I think there is a few cases where you might be better doing a trabeculectomy first.
Right.
Yeah.
Okay, one more question to the panel. When is it, would you consider refractive or recommend refractive cornea surgery to glaucoma suspects like ocular hypertensive, pigment dispersion patients that have not gone yet into glaucoma, or cup patients with a normal pressure?
Indeed, always we facing this question from the patients themselves. Coming to us, I have a suspected glaucoma or mild glaucoma or early glaucoma. I have refractive errors. I'm willing to do refractive surgery. Can I proceed or not? And always the answer will be upon the patient's case. Is he has a damage in the retinal nerve fiber layer, the visual field, the pressure, is it controlled or uncontrolled? Is he progressive quickly, or his case is stable? I think for patients whom minimally damaged or no damage up till now in the visual field at least, their pressure controlled, and we can proceed with the PRK, for example, not to go for LASIK and to apply much pressure for the globe during the surgery. And if the patient cooperative enough to continue follow-up and to document all the basic investigations for him before surgery or before refractive surgery, I think we can go for refractive surgery in this case for him. But from my side, if the patient have a notable damage, or his pressure fluctuating or not stable, or he is using more than one eye drop, I will advise him not to proceed for refractive surgery.
In my opinion, the pressure exerted by the microkeratome maybe yes high during the surgery, but using femtolasic, it's about 28 millimeter mercury to 30, and it just lasts for about 30 seconds. And I'm not in favor of doing refractive surgery for glaucoma patient. However, I will go for doing femtolasic rather than PRK, because PRK I have to give steroid for a long time to avoid corneal haze, and this is not avoidable. We have to keep it for a long time. Even using mitomycin C during the surgery is not alternative to using steroid for a long time. So PRK for a glaucoma patient, I would be a little bit reluctant to do it. But as you mentioned, I'm still not in favor of doing refractive surgery on the corneal level. Maybe I think about like clear lens extraction, but definitely not on the corneal level.
Right, thank you. I think we have time for one more question, one last question from the audience. Yes, go ahead, please.
Just one question. Do you just start with clear lens extraction in angle closure glaucoma as first line of treatment?
So if they have established glaucoma, so narrow angles is a separate thing, but people with angle closure glaucoma, then depending on a few things like their age and the level of their pressure, I'd offer them a clear lens extraction if indicated, but I'd also counsel them quite a bit about the pros and cons of that and offer them laser iridotomy as the other option, explain the results of the EAGLE trial, because I think, there are some patients who will start with 6/5 vision and end up with slightly worse vision after a clear lens extraction. So I think you have to discuss it with the patient. But generally, I'd offer them clear lens extraction if indicated and they fit the EAGLE criteria. But I'm just a bit wary about doing it in young patients because they often end up with suboptimum vision.
One last question.
I thank you for the presentations. I have a question about if you prefer a specific shunt device in neovascular glaucoma, or does it not change your decision?
Usually we use Ahmed valve. This is usually working with us. We just do an intravitreal injection of VGF, anti-VGF before the surgery to avoid intraoperative bleeding. Do a particular PRP if this is possible, and then Ahmed valve is a good choice. Belvert also is a good choice if you're aiming for a lower pressure. So both of them will work.
Dr. Walid, also I will ask you about the neovascular glaucoma cases. About the prostaglandin analogs for those patients, usually we are trying to avoid to minimize the inflammation for those patients. As we know, prostaglandin analogs will increase it. Do you think we can use it for them when we are controlling the neovascularization? I mean, if there is no active rubiosis or no active neovascularization, can we use prostaglandin analogs in these cases for those patients if other medications not enough to control the pressure?
So primary neovascular glaucoma are considered surgical phase. So anyway, there's no, in my opinion, any medical treatment will solve the issue. So any medical treatment just temporary to control. We have been told for a long time that this is contraindication in the prostaglandin because it leads to inflammation, but there is no enough data in evidence-based medicine that this will with the situation. We have enough data in the myotics, but not in the prostaglandin analogs. So anyway, if it works, use it. We have now the new molecules with prostaglandin analog with rho kinase inhibitor as well, and prostaglandin with nitric acid donors. So use it because it's a really heavy gun. It reduces the pressure up to 30%. So if it is necessary, we use it until we do surgical correction.
Thank you, Dr. Reed. Thank you, everyone. I'd like to thank all the eminent speakers for their excellent talks today. We'll have to conclude the session. Thank you to the audience for staying with us. And next, the refractive session, Dr. Yahya will proceed.
Good evening. We have to move directly into next panel session. The 5 commandments of refractive surgery. We are going to have great speakers, Dr. Saleh Mahjoub, Dr. Jorge Aliou del Barrio, Dr. Safwan al-Bayati, Dr. Sam Ibrahim, but I don't think he is coming. And I have among the panelists, Dr. Professor Ahmed Ghunaim, Dr. Osama Al-Husseini, Dr. Aaron Siti. So I think I will start. Ahmed, I will ممكن لا خلاص خلاص يا أحمد. I'm going to talk about in the available time about the complications that you should what you should face and how you could stay calm and think of it. To start with, you can have complications because of bad selection of a case, intraoperative or post-operative complications. It's better to prevent the complications, and the main intraoperative complications are flap complications or decentered ablation, or you can have epithelial defect during dealing with the flap. Flap complications, incomplete cut due to obstruction of the microcratome buttonhole. Buttonhole or free cap, each has its reasons. And if you have a complete cut, incomplete cut like this, reaching to the pupil, definitely your ablation will affect, you will get into this part, this hinge, so it's best to abort the surgery and reschedule the patient after maybe 1 month, 2 months, until there's complete healing. You can do a deeper flap. Buttonhole, it can occur because of central corneal buckling, either inadequate suction or steep cornea. And in this case, again, if it is central, not peripheral, then abort the surgery. It's very important to be brave to take a decision to hold the surgery and postpone it and give the patient best chance. Free cap, here is with an SB microkeratome, you can have a free cap, and you can see here 3 marks to avoid the flipping up of the cap, not to place it upside down. You have to stretch it and put it back into place. And this is said to be more common with microketones in general. If you use the wrong ring, you have to be careful in repositioning the flap in the correct place and give it time to dry, to stick, and then maybe you can use a contact lens and to remove later on. But I can tell you that this can happen even with FEM2. And this is, as you can see, I have only 1 mark, which many people doesn't put a mark for FEM2 flaps, but as you can see here, it can occur with a FEM2 flap. So be aware of this complication. If it happens, don't panic, just evaluate the condition, make sure where to reposition the free cap. It's no problem, you continue the treatment as usual. The only trick here is to replace it in the proper place. Post-operatively, there can be early complications like flap dislocation, stria, microstria, epithelial growth infection, DLK, CTK, steroid-induced glaucoma, and this is something that you have to put in mind, particularly with PRK patients. If you have a flap dislocation, just mark again, enter the, get the patient back into the OR and under the microscope, reposition, dry well, put contact lens. Dislodged flap, some patients can come. Next day, they squeeze and say suddenly they feel foreign body sensation. The flap is, they cannot see well, and you look at them and you examine, you will see the flap squeezed. Don't panic, just irrigate, wash properly the bed, reposition the flap, contact lens again. Usually this go well. The stria, you can see it more with the microkeratome flaps, and if you have microstria or macrostria, don't hesitate, even up to 1 month to get the patient in, mark the flap, elevate the flap, reposition it, and then wet it all with saline. You don't have to use even distilled water. Maybe distilled water after 1 month, but before that, just wet it for 1-2 minutes with the flap, and then put a contact lens, just massaging. You will not observe correction of this microforce intraoperative, but next morning it will be away. So don't be afraid to do this. DLK is an infection. You have to separate between DLK and CTK. And DLK is an inflammatory process, and you can see it early, and it will respond with steroids and have different grades, as we can see. But steroids is the hallmark. CTK is non-inflammatory. There is no treatment. Just don't panic. But one of the clues that this is CTK is the extensive hypermetropic refraction. You will see a hypermetropic refraction. It is not, once you know it is not DLK, just observe the patient, reassure him, and then follow him up. He will improve. Maybe it will take 1 month or more, but he will improve without treatment. Infection is very serious, and you have always to make sure to avoid infection by precautions during surgery, observing the patient post-operatively. This is a patient early infection, post-LASIK, and everything was done, washing under the flap, amputating the flap. He was not improving, and then we decided to do cross-linking. This is an option. You can see the improvement of this problem with the cross-linking, and this is after 5 months, leaving a faint opacity. This is a patient that had bilateral corneal infection post-LASIK. She went all over, and she came after 3 months almost, and I decided to do in one eye penetrating keratoplasty hot, in the other eye I did amniotic membrane. I didn't put the movie because there would be no time, and this is the remnants in the left slide, remnants of the amniotic membrane, and I have been following this for a year. You see this is 1 month after post-operatively, the cornea is clear, the graft is clear, the eye is quiet, all the signs of inflammation, vascularization has disappeared, and the other eye, the left eye, which had only amniotic membrane, it is, as you can see, after 1 month, there is remnants in the center, and the cornea actually is regaining clarity. And this is after 3 years post-operative. This is the side of the cornea after removal of the sutures. You can see the hallmark here is that you have to take a decision of hot keratoplasty if medical treatment is not working. It is not something that you hesitate, you don't, most of the people will tell the patient, wait. You see, this is the left eye, the cornea completely regenerated. And this is 3 years post-operative. This is 5 years post-operative. There is faint opacity, posterior subcapsular cataract, but the cornea is 250 microns, and clarity is regained, and the vision was corrected. I see this patient now more than 13 years, and she's now coming to do a cataract in the left eye. So this is very important to know that infection is a serious problem. You have to tackle it properly and take hard decisions in the proper time. In conclusion, complications with LASIK flaps can occur. It can be serious and vision threatening. You better avoid and prevent it, and you should know how to manage it in a timely manner, and you should stay calm. Thank you for your attention.
Oh, thank you, Dr. Yahya. Very nice presentation. Can I ask you, do you have any precautions or any parameters you can advise for doing cross-linking in such case of infection?
When or the parameters? The typical scenario is if you have a case of infection, post-LASIK or corneal infection, you try to, if it is not in the interface, or even in the interface, you left the flap, irrigate with antibiotic, it's a broad spectrum, and try before that to take a swab or a culture. If you get a positive culture, you can give treatment. Sometimes you will not get. Many of them are atypical mycobacteria. Very rarely in the early period it will be fungal. Usually it's bacteria. So you give treatment. If you give treatment and there is no improvement, then you don't wait. And there are specific signs of improvement that you see, like decreased inflammation, decreased pain, all the signs, decreased edema, all this are signs of improvement. And you have to know that one of the reasons of failure of treatment is not a resistant microbe. It is the non-compliance of the patient. You have to tell the patient, first 48 hours, you'll take these eye drops hourly for 48 hours. Hourly means hourly, day and night. And you see the improvement. No improvement, then you should decide either you change, if the patient is compliant and the microbe is sensitive, then you should decide to do into cross-linking. Cross-linking became now a very important tool in tackling corneal infections. And as you saw in that case, the improvement was very remarkable. We used to do a Dresden protocol typical, but now we do accelerated protocol, and you can actually, in corneal infection, use higher parameters, higher energy. You're not worried to affect the endothelium. So corneal cross-linking is a very important tool nowadays.
Thank you.
Do people still do photorefractive keratectomy or PRK? And if yes, what are your indications for that?
PRK? Yes, we do a lot of, I still do a lot of PRK. It's a very good choice of surgery, particularly some patients, They are not fit for LASIK or SMILE or whatever technique like this. On the other hand, also for lower refractive errors, and the patients, if they have some time and they understand that the recovery is a little bit slower, it's very good way to treat refractive error. PRK is not obsolete. Actually, it's a very good choice.
We now invite the next speaker. Please come.
I would like to thank again the organizer for the great effort for organizing such a nice conference. So high definition OCT is now a must in the management of laser vision correction, and especially to diagnose unusual complication. As an illustration, you see here at the slit lamp, you have the usual aspect of epithelium invasion after LASIK, but when you look at the OCT image, you have much more information. So as you can see here, you have different thickness of the corneal flap. In some area there is melting, and especially you see here there is a scar that this patient had actually a perforation during surgery. So before going to the unusual cases, we have to be familiar what's the normal pattern of OCT after laser vision correction. This is a case of myopic LASIK. And as you see here on the pachymetry map, you have a lot of information about the stromal photoablation, like the centration and the size. And the epithelium mapping will show the central and paracentral epithelium hyperplasia. So you see here topography post-LASIK, both eyes. And you see here you have a pattern which looks like decentration, and the other eye looks absolutely normal. But when you look at the high definition OCT, you have much more information. You see here there is a decentration of the thinnest point of the cornea, which is opposite to the area of flattening. So this is not a decentration, but actually it's in corneal ectasia. And when you look at the epithelium map here, you have epithelium thinning just in the area of stromal thinning. So it's definitely corneal ectasia. And the other eye, which has a normal topography, when you look especially at the epithelium map in here, you see the diffuse epithelium thinning, which is unusual after LASIK, like I mentioned previously. And this is a very early sign of corneal ectasia. Also, we have been familiar the aspect after myopic PRK. The pachymetry map will give you information about the centration and the size of the stromal ablation, and the epithelium mapping will show just the central epithelium hyperplasia. So this is a case that we have saw at our institution. So as you see, preoperatively, the topography was suspicious, so I've elected to do surface PRK. And a few weeks later, you see the topography is very irregular and getting worse with time. And here it looks like corneal ectasia. So we said, this is the first case of corneal ectasia after PRK that we have seen. But when you look at the corneal OCT, then you have other information. So as you see here, the aspect of the pachymetry pack is very reassuring. So you see the stromal ablation is centered, regular. And when you look at the epithelium map, you see that the problem is at the level of the epithelium. So you have area of hyperplasia and you have area of epithelium thinning. So actually this is not a case of corneal ectasia, but rather a case of hyperplasic haze, and just waiting for a few months and the topography is back to normal as you see here. Another case had LASIK both eye for -8, 11 years ago. And on the right eye, you have almost a total regression of the LASIK effect. And the topography looks like a corneal ectasia, as you see in here. And the other eye, also there is some kind of regression and looks like a decentration. But when you look at the OCT, you have other information. So as you see here, the pachymetry map, there is no thinning, so it's not an ectasia. And also the epithelium looks almost normal. The other eye, there is a decentration of the photoablation, but there is no thinning there. And most importantly, there is about 50 micron difference between the two cornea, although we have done the same photoablation. And the most common cause for this is a variation of the corneal hydration. And actually, when you do a specular microscopy, you found out the etiology. This is a case of Fuchs endothelial dystrophy. And this Fuchs endothelial dystrophy is more common than we think. It's 8% of the patient after 40 years. And they will give you this kind of abnormal topography. And just another case referred to me for bullous keratopathy with a history of LASIK. And after doing DMAC, you see here the cornea is very edematous. So I thought this is a case for rebubbling and the endothelium was not very well attached. But you look at the OCT, you see here the endothelium is well attached, but you have an area here of fluid accumulation between the flap and the stroma. And this may happen after any intraocular surgery. Even after phacosurgery, you can have this. But the good news is that it's very easy to treat. You just have to wait a few weeks and everything is back to normal. The same here for the OCT. You have the normal aspect of LASIK surgery. Okay. And the last case, also LASIK in both eye, -7 diopter, 100 micron femtolasic flap. And on the left eye, you see on the day one, the patient was plano. And you see here on the differential topography, it looks very nice. And then at 1 month, you have a regression of about 4 diopters. So what's the cause? And the cause here, you found it also again on the OCT. Almost finished. This is the last case. So, and you see here, you don't see the normal photoablation of the LASIK. And the key, it was not a problem of endothelium, of course. And the key of the diagnosis, you see here you have 160 micron flap, although you have planned for 100 micron. And this is the typical feature of pressure-induced stromal keratitis. And just by lowering the intraocular pressure, you see here the topography is back to normal. Thank you very much.
Thank you, Dr. Saleh. Very interesting. So your recommendation that we always use an OCT, any anterior segment OCT, to give us more insight of the problems?
Okay. Yes, you don't need to invest in an OCT which is dedicated to refractive surgery. Just any retinal OCT with a high definition, you just need an anterior segment adapter and you get all the useful information you're looking for.
And your recommendation to use it when the diagnosis is not clear or always?
I use it mandatory. You know, I'm not a big believer in tomography. And every year, you notice, you know, the consultant for tomography just moving back now and giving more and more talks about high definition OCT. And almost all of them now are switching to, for example, MS39, but CSO. But any regular OCT will give you nice information.
Thank you very much. It's very important information. And he moved the diagnosis in each case to another completely think that the management is completely different than one will think with the first impression. Thank you, Dr.
Thank
Saleh.
you so much.
And now we move on to Dr. Jorge Alio de Barrier. He will talk about an interesting subject, be brave. When should you go back to the OR?
Hello, good afternoon. Thank you very much. Again, so my presentation is going to be a combination of the previous two, more or less. So the first thing when you have a serious complication is to avoid denial, because it's the denial what makes the patient unhappy. And remember, most of the patients, at least, they are not stupid. Okay, and if something is going on, they will realize. And what you have to do is to stop that denial, be brave, and face the situation. Because if you make your strongest effort, you invest all what you can do, and the patient sees that you are doing your best, actually, a patient that could be seeing you in court actually is going to be your greatest fan, okay? So that is very important in order to convert these very unhappy patients in actually fans. Of course, I cannot go through all the complications that can force you to go to theater, but nevertheless, I recommend you this book, okay, that actually we are now working on the 3rd edition. So I'm going to focus on some of the complications that actually some of them have not been discussed in the previous lectures. The first one is specific of a SMILE, and is the fact of having retained fragments. Okay, this is an uncommon situation, but when it happens, it usually is in difficult dissections on very thin lenticles that are very usually associated with very low myopia. It's uncommon, but it can happen, and you should always try to extract it. But sometimes it's just not possible. If the lenticle the fragment has been retained, is small and peripheral, it's not a great deal because the epithelial remodeling is going to make the corneal surface good, it's going to regularize the topography, and it's not going to be any visual impact. The problem comes when you have a large or central remnant. Of course, if you are able to see and identify it, but you cannot remove it, then you will have to stop and convert it into a surgical procedure a few weeks later, and then take it out. Because the problem is this, that if the fragment is large, the epithelial remodeling is not going to be able to make the corneal, is not going to be able to regularize the corneal surface, and severe irregularity is going to remain. But the problem is that sometimes you know that something has been left, but you cannot see it. And if you cannot see it then, or the surgery was done in another place, and you cannot actually, you can see that something is going on in the topography, you suspect a retained fragment, but you cannot identify it, you will have to do a customized ablation. Other situation that forces you to go to theater, epithelial ingrowth. In a SMILE, is more a serious complication because you are in a closed space, but hopefully the epithelial ingrowth nests are usually close to the incision and usually can be managed by JAK laser. With JAK treatment, you can avoid any surgical procedure in the majority of times. The only thing is that it's true that after the JAK procedure in this epithelial ingrowth after a SMILE usually remains some astigmatism that occasionally might force you to do a surface treatment to correct and leave the patient hemetropic. When this epithelial nest is more close to the visual axis, as in this case, this is more a tricky situation because if you do JAK, the residual scar can affect the visual outcome, and then it might be better to do a surgical procedure and wash and clean very well the both interfaces. Of course, the epithelial ingrowth can happen after LASIK, mainly with something that we see when we do a late flap lift, when for example, we want to do an enhancement 10 or 20 or 25 years after the original procedure. The majority of times, and we have this published because we do late flap lifts when we need to do a refractive enhancement, the majority of the times this epithelial ingrowth is very mild, is only grade 1, 30% of the cases. You don't need to do anything. In grade 2, when this is progressive and goes more to the mid-periphery, we treat those patients with JAK, and then no surgical procedure is needed. When actually this progresses and go to the near the visual axis is when you have to bring the patient to theater, do flap lift, treat, clean, and then later in the post-op close the fistula with Jack laser. If you want more information about the Jack laser, we can later discuss it. Here you have the reference that our group published many years ago, and here you see some cases of mine just after treating the epithelial ingrowth with the Jack laser. Within an hour, all these bubbles are gone, and actually this is really, really, really effective in order to treat and stop the epithelial ingrowth, and you avoid any surgical procedure in the great majority of times. Here you see a quite grade 2 epithelial ingrowth treated with Jack and the residual scar that resolves the problem. And then I'm going to end with the infectious keratitis because this is the most severe complication. Hopefully it's rare, but it's more common after a smile, then after PRK, and then after LASIK. LASIK, it has the least percentage of cases compared to the other two refractive surgery laser procedures, being the smile with the one that has the greatest risk. The majority of the times are gram-positive cocci from the flora. Actually, it's an intraoperative contamination because the reason of this, if you have done your job properly, the reason for this almost always is very uncollaborative patients, patients that behave very badly during the surgery, and then you end up contaminating your instruments and disseminating the infection throughout the surgical interface. And for these cases, you have to lift the flap or the cap, take scrapes for culture, irrigate with fortified antibiotics the interface, and then empirical treatment with fortified antibiotics. And here you have a very scaring case of mine. This is a case I had about 3 years ago. This is for it. 1 day post-smile, patient was perfect. 1 day later, appeared like this suddenly. Of course, I was about to cry. A vision dropped from 100% to counting fingers, redness, pain, very tricky situation. Here you see on anterior CT, there were infiltrates everywhere. This is a patient that behaved very, very badly during the surgery. Hopefully it happened only in one eye. And here you have the video, so I think we have a minute to show it. So here I'm doing the corneal scrape. Okay, at the beginning, the problem is that this patient behaved very badly, so I had to stop, I had to cancel the procedure. I couldn't finish actually the smile, and the lenticle was retained, and later the patient actually developed the infection. So here I was taking the scrapes from the anterior cornea. Then here I'm trying to finalize the dissection of the fragment because of the bad behavior, I had a false plane. Here I'm implanting some fragments from a spear to basically scrape very well both interfaces of the lenticle in order to send this swab for culture. And then after this, I decided that really I need to open this surgical interface, and I decided to do a manual surgical procedure, basically with scissors. I'm converting the cap into a flap. Well, here I am still trying to remove the lenticle, but it was a false plane, I couldn't. So here with Vanna scissors, I'm trying to open I'm actually converting the cap into a flap. Then I will remove the lenticle. And in this case, basically, because I don't have much time, what I did is to irrigate very well the surgical interface with fortified antibiotics, and actually I did an intrastromal injection of fortified antibiotics with a 30 gauge needle in order to make sure I am making all what I can in order to treat this severe infection in this refractive surgery case. And as the first speaker said, our colleague said very nicely, and I totally agree, you have to be calm and wait, okay? This is 1 day, 5 days, 7 days, vision hopefully was improving, and then 1 year later, unaided distant visual acuity in this, remember how was the picture before treatment, and 1 year later, unaided vision was 0.5, corrected vision was near 0.9, minimal astigmatism and with rigid lens vision was 100%, and see how bad it looked at the beginning. I thought actually that was gonna be a transplant case, but look how it ended in the end. In the end, we didn't have to do anything. So keep calm and be brave for refractive surgery complications. Thank you very much.
Thank you, Jorge. Dr. Ahmed, he has a long experience with SMILE, so it was very interesting to see that SMILE is the highest percentage of infections.
Yes, actually that data, I took it because I reviewed a paper for GRS 3 days ago, and actually I updated the presentation in a series of 10,000 eyes. These were the percentage of infections they had in a study period of 10 years. And it's actually they found that SMILE had the highest risk, and this was in agreement with previous literature suggesting that. And that makes sense because in the end, when you deal with a LASIK, you've really washed out very well the interface, but in a SMILE, you are working in a close environment, and if you are not careful, actually you might end up disseminating the infection. So LASIK was the lowest, followed by PRK, and followed with the highest rate in SMILE.
Maybe you're speaking in the right way, that it's a closed system, but maybe you're just using just one instrument. You don't have wash with a cannula, with a fluid. That means you can get infection with a cannula, with a fluid, with a spatula. So in my opinion, since 2015, we worked more than 8,000 cases we didn't face. But anyway, it doesn't matter. But just tell me, very nice management of this infection with the SMILE. After you just put the sponge inside to just, you elevate you convert it to as a flap, then you remove it, or you just keep it again?
No, I removed the lenticle.
You
because
remove it.
the lenticle was totally infected.
The cap or the lenticle?
No. So basically, I converted the cap into a flap. Then I finalized the removal of the lenticle that was trapped. Okay.
The thing you remove is the flap. This is the cap, not the lenticle.
The flap, I repositioned it, I sutured it, and I kept it. I didn't took it out.
You keep it?
I kept it, yes. I kept the flap because the majority of the infection was in the lenticle that was infected and on the underlying stroma. And on that time, I rather preferred to save the flap. Why? Because if the infection goes well, the visual outcome is going to be better if I save it. And even if it goes badly and the majority of the scar is retained within the flap, I can always take it out. So basically, I can always make that decision later if I need about removing the flap.
Just a question. Yeah, but the place for infection in LASIK, it will be on the, sorry, Dr. Safwani, go on.
Just one thing.
Yes,
you left the lenticule. You couldn't remove it in the beginning, right?
Because the patient was...
So this is the scenario. You left the lenticule, you return back to it, you found that it's infected. You couldn't remove it in the beginning, right?
Yes, so the thing is I couldn't present the whole case because of time, but basically the patient became in panic.
Yeah.
So during the severe movement, I made a false plane. So then after detecting the false plane, the first time with a lot of difficulties, I was successful. This was in the second eye. And then after detecting the false plane, I decided to stop. And then whenever later, finalize and remove the lenticle.
Can I ask you here, what's the machine that you are using?
The Visumax.
Visumax, okay.
The Visumax.
Please.
And then is one day post-op he was fine, but then 2 days post-op is when came with infection.
Okay.
And then at that time is when I decided to convert the cap into a flap, remove manually the infected lenticle, and then, but I preserved the flap, okay, I preserved the hinge. To put it back, I put a couple of stitches because the tissue is so friable that you need to give some support, otherwise will dislocate. And then I put antibiotics, and here the clue is that with a 30-gauge needle in the percentile area, I injected intrastromally the fortified antibiotic, and with that responded very well and very quickly.
You are not using antibiotic post lenticle extraction?
Topically, yes.
Topically, yes.
Topically.
All the cases?
100%, of course. As any other laser procedure, always 100% cases
Okay,
antibiotic.
we will move on. Thank you very much, Jorge. Did you know the organism?
Yes, it was Staphylococcus. Just Staphylococcus, regular Staphylococcus. Probably from the eyelids.
Yeah, but
I guess in the difficulties, I contaminated the spatula and then I end up disseminating everything because actually the main focus was in the false plane.
Okay, last comment from Dr. Ahmed. We will move Dr. Safwan.
Okay, just I want to ask that you wouldn't have this infection if you don't have the problem in the technique in the beginning. So a lot of trial to dissect the lenticule. May put infection, and then you leave the lenticule for a while, because if you didn't touch the lenticule and you just have the SMILE on, then you didn't remove the lenticule, the femto laser on, and you didn't lift the lenticule, the cornea is a virgin cornea after a few days. But if you just put your spatula and try to separate it, that means you have problem with the technique. That's why you have an infection. So there is no primary infection happened.
Nevertheless, the rate of infection is reported by using different spatulas on each eye, and basically the evidence is there, and I think it makes sense. I'm a SMILE user, and I love the technique, but it's true that we have to accept the reality, and to work in a closed chamber, it has its drawbacks.
So you think that the infection
Thank you.
Dr. Safwan, we have to...
Yeah, for sure.
Thank you, Jorge. Very interesting. Now
So
we
good
move Dr.
afternoon.
Safwan Al-Bayati. Last but not least, talking about be updated, new technology can save you.
So I think that here the question is very important after all what we saw. Is the technology can save us? Well, yes. Now, good separation, and I will talk about the SMILE, but a new technology, and good separation, easy to separate, manipulate for all power and the spot size and arc size, and centration, track system, static preoperative track system estimation, and intraoperative track system that can do a lot of us. So let us start with this. Financially, I'm the clinical representative of Schwint company here in UAE. We will start with this new technology. That's the registration. Here in SMILE, here in Atos, we have a registration. We are using MS39 for registration. That will show us the centration intraoperative. Apart from all the PRD, brachymetry, all the information will be transferred to the machine. To treat any kind of astigmatism, so we can reach up to -5. Now, that's the machines that are available in the market now, at least in a trade. The Pro, that should have the torsional track system started from Escars. Well, I'm not sure about whether it's registered or not, and Elita, and Femto LDV, Z8, and Atos. Now, Elita is not in the trade, but the others in the trade. But Femto's Z8 doesn't have torsional track system till now. Pro, it should be registered and should be done using IOL Master 700. We are using, in Atos, we are using MS39. Now, why it's important? This intraoperative, during the ducking, there is a movement. In the moment that we are ducking, the eye will move in cyclotorsion or excyclotorsion, and you can see it here. That's our target. If we will not reach, if we don't have the track system, we will end up with this distance, and that's the cause of the coma post-op, or inducing astigmatism if we are treating astigmatism. definitely all this discussion is not related to the problem that we will discuss it later. So here, again, when we are targeting the center, we have a circle, and within this circle, we need to target and to keep the green circle within the yellow circle. And that, in this, we will reduce the induced comma and induced spherical abrasion to the lowest form. And that video shows how we are reaching to the yellow circle. See the patient, how it's moving. This is the reality. Then we reach to the, and then we start. Now, is that important? This is very important, especially in suction loss. Now, that's a problem that I need to talk about it. Suction loss is a big problem in SMILE. In suction loss, when we are discussing with any SMILE users, we will say that, well, we will go to do PRK after 3 months. The best surgeon, he said that, I will do PRK directly. Is that right, Dr. Ahmed, or not? So
it depends on what.
Yeah. Amr Agarwal, he present one presentation in one of our meetings. Dr. Ashraf was with me. He did ducking again. So he re-duck again, but he don't have centration. And he end up with a disaster related to the multiple layer in the periphery. And that's what's happened. So if you don't have centration and a track system that assess the track system that we reach to, we can't reduct again, and that's what I agree about. But if we have the centration, we can reduct again. In spite of that, the new software will estimate the time where the suction loss will be stopped, and it will return back to that time, deduct from it few seconds to return back not to the same point, previous point, and then it will continue. That's the new software. So I will show you a case. That case, can you play the movie, please? A very nice posterior. And then a very nice anterior beginning, but you can see that the patient start to move and moving, and then I lost it. Now here, we return back. I did high resolution image through the MS-39. That's all the data that's coming to the lenticule in details post-op, the lenticule parameters. So I have it all, and it's reserved, and I can return back to it again if I need to do a ducking again, because I have centration and track system. And that, the high resolution, it's immediately post-op, using the MS-39 high resolution image, and this is 1 hour post-op. I don't have any remnant. It shows that there is, but this is only an air bubble. And this is 1 day post-op. Now, one say, you need 1 day? No, I would say, no, I don't need 1 day. This is only the first case, because corneal edema. So I don't need to go through corneal edema, in spite of the patient was on treatment. Anyway, that's again, the same case, using same parameter, ducking, the same centration. Still he's moving. In spite of that, a lot of pre-medication. Anyway, now I start, posterior, anterior, yeah, just few seconds. Yeah, this is the last. Easy to remove. I'm just showing that there was no any level in the periphery. Here I'm in the interior. And the lenticule will remove 360. I'm sorry that I'm exceeding the time. Hopefully that it will be helpful. Now I'm removing the lenticule, nice lenticule. (360). You can see all the borders of the lenticule. Now, second day, that's the data that I used, the same data that is before. And the second day, you can see that's the margin of the lenticule. There is no any remnant. This is post-op immediately. And this is post-op 3 days. And this is post-op 20 days. And thank you very much.
Thank you very much, Dr. Safwan. دائما معاك الجديد دكتور أحمد غنيم بقى.
He's the best hand in Smile. Thanks for this nice presentation. You say that if you have a loss, you have a suction loss, you will try PRK. You still have the chance to do Smile, or?
For sure.
Yeah.
If you have the centration, if you have the ducking with the tractional.
What about if you just postpone the case for 1 day or 2 days and then you can redock?
I prefer to do it immediately because the issue is that
Yeah.
Corneal edema the corneal edema can interfere with the thickness and can interfere with our nomogram.
Okay.
So I prefer to do it immediately.
At the same time, yeah. Thank you. Nice presentation.
Thank you.
Dr. Ghanem. Yes. Why there is no OPL? This is cornea without any, you are doing Smile.
Yeah.
So the anterior and posterior, you cannot see during the dissection. Tell me why. This is different than any other machine.
Well, first of all, when I did it, I was waiting for a while of time only for this case. But there is an OBL. Only for this case, I wait to see the demarcation. And then I pass through. Yeah, this is the first case. I'm showing the first case, and now it starts to be a nomogram for all users for Atos to use. If we have suction loss, we are doing it immediately, going back to the old nomogram that we are using until this new software appears where we can go back and do it. We can, for example, in this case, we can return back to the anterior part, and that anterior part about 30% done. So we deduct about, let us say, 3, 4, 5 points from the 30, and then we will start from that point till the end. For sure, we will have the same and easiest. Yani immediately we can return back. Just turn on to the return back to the same phase.
Quick question before we end. At 6:15 we have the Roche Symposium. So I will ask those who do you do Smile? I don't do Smile. Okay, so I'll ask Dr. Ahmed Ghanem, Dr. Safwan, Dr. Saleh, Jorge, what's the percentage you do Smile in your cases? Ahmed Ghanem?
For me, in the last two years, more than 60% now.
Safwan?
Same.
And do you have a reason to be that big difference from them?
Yeah, that's another issue that we need to discuss.
In my case, I do about 30% PRKs, 30% LASIK, 30% Smile. And the reason why, actually, I have a whole lecture about that, is quite evidence-based. The first one is, I don't do femtolasic if there is refractive astigmatism over 2. Why? Because it still works, full stop. Doesn't matter. If you look at the evidence, it's our evidence, is everybody's evidence. There is astigmatism over 2, even if you mark, is worse. And even if both, and you could argue, okay, but with an astigmatism over 3 diopters, even if femtoLASIK undercorrects, yes, I agree, but there is one big difference, that if you need to retreat, that is about 25% in LASIK over 3 diopters of astigmatism, it's just a flap lift, and it's zero cost. While if you have to enhance a smile, it's a circle, and you pay, because you have to use another cone. So for astigmatism over 2, despite you can do a smile up to 5 diopters, and that's true, is obviously worse than femtoLASIK, and this is evidence-based. The other reason is over 40, patients over 40 years old. I have a paper, we published it, and also Jot Mehta in Singapore published that. In people over 40, the efficacy, the refractive predictability is worse in SMILE than in LASIK. Why? We hypothesize that is the elasticity of the tissue, and this makes sense because as you become older, the corneal stiffness changes, and so the elasticity, because once you remove the lenticle, the cap has to remodel. And it's obvious, so you could argue that the elasticity of that cap is not going to be the same in a 25 years old person rather than in a 45. And actually I saw that because systematically when I was doing a SMILE over 40, there was residual astigmatism. Even if it was not preparative astigmatism, the patient ended up with about 0.75, 1 diopter astigmatism. And then I did a study, I published it in JRS, it's there, you can see it, comparing the refractive outcomes in a SMILE over 40 and patients under 35, and there were statistically significant differences in the efficacy, not in the safety, but in the efficacy index. And that's the reason why, for me now, is I have to do a laser treatment in a patient over 40, that usually I will do it with monovision, I don't do a SMILE. And the other reason is, and the other indication is, I don't do LASIK, I don't do a SMILE in myopias under 1.5. Why? Because it doesn't make any sense. Because the advantages of a SMILE in a very low myopia are totally lost. And you have, on the other hand, a surgery that is much more risky because you are dealing with very thin lenticles, and if you end up with a tricky dissection, you might end up with a retired fragments. So the thing is that, why I'm gonna do a SMILE in a -1 when it's a more difficult surgery, it's a more risky surgery, and all the advantages of a SMILE are lost. The thing is that people many times does a SMILE because if he's the only one in the city doing a SMILE, if prescribed a SMILE, he's the only one doing it. But while he prescribes LASIK, many other people can still do, and then has higher chances of retaining the patient. But this is a commercial reason, a commercial bias. So according to that evidence-based and reasoning, for me, a SMILE is 30% of my cases.
Thank you very much. I think, thank you for all the panels.
One comment for George.
I think Rosh, I have to be ready, but say the very fast comment.
So just I agree with George for the over 40. The issue is that when we are imagining that how the cup sits on that bed after removal of the lenticule, then 100% we are agree that post 40 it will be difficult because when we are doing LASIK, the bed, when the cup is resets on that bed, it has a distance. It's free cup. It's a flap. So in myop and hyperop, it will go in and out. But in femtosmile, no, it will fold. In over 40, it doesn't have this ability to fold. And this folding will be in the periphery. That's why in below 40, we have a negative spherical abrasion induced. And this negative spherical abrasion that induced in the periphery, it will neutralize the positive spherical abrasion. That's why we don't have a lot of positive spherical abrasion, and these are published a lot. But in over 40, we will not be able to have this fold because of the resistance. So we will have a lot of issues. So I do agree with it. Second part, now I don't have time to reply.
Thank you very much. Thank you, Dr. Safwan, for all the speakers and the moderators and panelists. Thank you very much.
Can we have a photo before Rosh? Yeah.
Thank you. Thank you. You are leaving tomorrow or tomorrow? In the advantage of in the morning, so one at night. One hour. Yes. I did it, yes. Several. Actually, I was this year in the with invited by several class to Chennai and next year I'm going back to Chennai to Susan Deco invited me to the her local meeting as well in Chennai.
Why don't you come over to Delhi on the way? You'll be host to that. And that would be a good idea to
Great.
Yeah,
absolutely.
My number is +91.
So I'm going usually the date is end of June.
Next year.
Yeah, next year. The only thing is that going twice to India in the same year, for the following years, yes. Because otherwise my wife will kill me if I go twice to India at the same year. Well, she usually does, but the thing is actually
I will bring you water. So Dr. Forwards, backwards, and then this will be magnifying for you. So you want to go say here, can you press next? This is the data. This is forwards.
I think it's that twice.
No, backwards is smaller. Yes. And I'll bring it from here. I'll keep it here. You want water?
So good evening, everyone. In the interest of time, we will go ahead and proceed with the symposium. Welcome to the Roche Symposium. So I will just basically give a couple of minutes of introduction to the idea of why Vabysmo is or faricimab is a different molecule in the armamentarium that we have for management of macular disorders. So as you know, for the past over a decade now, 2 decades, close to 2 decades, we've been actually suppressing the VEGF molecules in the macular diseases. And this has been actually a new standard for us to actually control these medications. But this particular molecule provides an additional augmented, let's say, mode of action by addressing a different pathway. So as you can see here to your right, the blue part of the molecule is the anti-VEGF, which is what we have been used to for the past 10, 15 years. But the one in the orange and yellow to your left is actually what's addressing the new pathway, which is the Ang2 pathway. Now, of course, the safety is always in the mind of every physician, so we also want to make sure that we're addressing the problem without creating issues, so that's why the modified FC fragment is actually what reduces the systemic exposure and also the inflammatory potential. So this is just a cartoon to try and illustrate what happens with the macular diseases in general. We know that the green part here where the VEGF pathway is, and we're suppressing it with the anti-VEGF, but also we know now that the data and studies have shown that the Ang2 pathway is also important in increasing the inflammatory reaction, augmenting that inflammatory reaction that's happening with the parasites dropping off and causing the endothelial cells to be a lot more leaky. So this is why it is important to try and address as much as we can the pathways that lead to the clinical picture that we see. And with that, today we will have two presenters, Dr. Amr Farid from Maghrabi, and from Cleveland Clinic, just arrived fresh from Abu Dhabi, Dr. Ani. So they will be each presenting their experience with DME and then with AMD, and then we will have about 10 to 15 minutes of discussion. So without any further ado, if we can have Dr. Amr with his presentation.
Good evening, everyone. Thank you, Dr. Ammar, for the introduction, and thanks for Roche for the invitation. I'm going to speak today about diabetic macular edema and how Vabysmo is working with this disease. So let's first go a little bit fast with the Yosemite and Rhine trial, which is the trial that got the approval for DME treatment for Vabysmo. We have three arms, as you can see here. One was for the aflibercept arm, and it was the same as the label. It was starting with 5 injections, followed by every 2 months. And we have other 2 arms for Vabysmo. One is the same as aflibercept, and the other one is personalized treatment. After 4 loading doses, we have to personalize the treatment for this patient according to his best corrected visual acuity and as well the OCT. So if the patient have a stable CST plus best corrected visual acuity is stable, you can extend by 4 weeks, and this can be extended until 16 weeks. If there is worsening, you can reduce until 4 to 8 weeks. And the extension or reduction criteria was not met, then we have to maintain the dosage, whatever we are going on. So this is the visual gains from the study over 2 years. As you can see here, the primary endpoint was the first 1 year here, then the second endpoint was here, and we can see non-inferiority or with the aflibercept, both arms for the faricimab were comparable with the aflibercept in terms of the visual gain. In the reduction in the central retinal thickness, it was really more a little bit for the faricimab arms in both the first year, and as well it extended for the second year. As we can see here, there was improvement more than the aflibercept regarding the central retinal thickness. Also, more patients achieved the absence of the intraretinal fluid with faricimab versus aflibercept through year 2. As we can see here, in all the 8 weeks or 16 weeks throughout at the end of the 2 years, there was more achievement of reduction of the intraretinal fluid with the faricimab than the aflibercept. In terms of durability, the faricimab reached about 62%, reached 4 months or every Q16 weeks, while 15%, 0.8, reached about 3 months. So in total, it's about 80% have reached at least 3 months of treatment. So this is a very good durable drug that's keeping the dryness of the macula. About the side effects or any adverse events that happened, there was the intraocular inflammation, which is the most important thing for us. As you can see, it was comparable with the aflibercept. These are the mild things like uveitis or some iritis a little bit. But the most important for us, like the retinal vascular diseases or the occlusive diseases, was 0 in the 3 arms. So this is just a collective data from what we all have said now. I want to just highlight that 80% of the cases have reached at least 3 months of treatment. So I'm going to go now with some of my cases. We have the Vabysmo since almost 1 year, 1 and 15 months right now, or 1 year and plus. And this is what we have to follow during the treatment for diabetic macular edema. We have to have a loading dose of 4 injections, which is followed by treat and extend in the personalized treatment. According to the condition of the patient, if he is improving in the best corrected visual acuity and improving in the central retinal thickness, we can extend by 4 weeks. And later on, we can extend more and more. So this is a case which is a naive patient, and he is 48 years old, male, diabetes since 12 years, and he is not controlled. HbA1c is 10. He came with decreased vision in both eyes. Actually, the vision in the right eye was 20/50, and the vision in the left eye was 2400. He never had any treatment before in his life for his retina. This is the fundus image. As we can see, it's a little bit extensive, but still his severe NPDR. We have here a lot of exudates near the macula or almost in the center of the macula, a lot of flame-shaped hemorrhage. He's really not controlling his diabetes. So the treatment, of course, we started with the faricimab treatment for him, as we can see. This was the treatment in the right eye. The vision was 20/50 in the right eye, and you can see there was a lot of intraretinal fluid as well as subretinal fluid. This improved after the first injection, and the second injection were given 5 weeks after, but you have to notice that the patient improved a lot regarding his edema. As you can see, the subretinal fluid is almost gone after the first injection. The second injection was given 6 weeks after. This is real life cases, so we don't have the fancy that we have to give every 4 weeks, the same as the studies. So this is real life cases. But again, he is improving more and more, and the visual acuity is improving. The patient is happy. And this is 6 weeks after, so the patient really extended himself by himself. And now, as you can see, there is almost no edema, no diabetic macular edema, and the vision improved to 20/30. This patient will be extended for more 4 weeks. The same as the left eye, although the left eye also, it has more subretinal fluid, as you can see, but it acts well again, the same as the right eye, and it improved by time. And now, as you can see, barely we can see any macular edema. Also, the patient will be extended for more than 4 weeks. So this patient was treated in both eyes between May and September 2023. He was injected only 4 injections. Visual acuity improved to 20/30 and to 20/40. Also, the central retinal thickness improved to normal levels, and the patient was extended to 8 weeks due to his excellent response after the treatment. So this case gives us an idea that the drug is effective, even if the patient is naive, and is giving very good results if we follow up the rules, or we follow up the protocol of giving the first 4 injections. Even we are late a little bit, not every 4 weeks, but as well it's giving us good results. The second case is one of my patients. Actually, is an old patient, 58 years old, and he is, I know him since 5 or 6 years. He has been treated with me since then. He has diabetic. He is not controlling his diabetes that much. He is also not compliant. He's not coming every on the same visits. But he is my patient since July 2018. So he has a history of multiple anti-VEGF injection. As you can see, he received Lucentis injections, 5 Lucentis injections. in July 2018 to April 2020, then 5 Eylea from September 2020 to April 2021. Then he felt that he was good with Lucentis and his vision was improving with Lucentis, so he went back to Lucentis. And he had a little bit of cataract, so we decided to do cataract surgery for him. Before the cataract surgery, he received Ozurdex because he was all over the course of the anti-VEGF treatment. The OCT was always having a cyst and he was not improving that much. So I did Ozurdex injection for him before the cataract surgery. So when he came in August, we were at this time, we were having the Vabysmo, and this is the OCT for him. He's always having this macular cyst, which is always humping up. It's never going down. And so I decided to try the new drug with him, which was the Vabysmo at this time, and we started to do the injection. He took the first injection, and this, as you can see here, there is improvement in the macular cyst or the macular edema, which continued to for improvement after the second dose as well, as you can see here, 10 weeks after the second injection. So as well, this patient, he is not compliant, so he is coming late a little bit, or he is extending himself as well, the previous one. Then again, he is improvement, as you can see, through the macular cyst. This is his 5th injection, and this was his last visit 2 months ago. He received the 6th injection at this time. As you can see here, still there is some macular edema, as you see here, but I never saw him going down. It was always having this hump up. So he started during 1 year, he started in August 2022 with this, and he ended by this after 1 year of having 6 injection. And I noticed this not only in these patients, in many patients I noticed this effect. Maybe we'll discuss this after I finish the presentation. But this was the case. His left eye was always affected, but it was less, so there was no time to give it here. So this patient improved. He has 6 injections between August 22 and August 23. In the right eye, he improved to 20/30, and the macular cyst, which was really resistant for treatment, responded well under the treatment. Thank you so much.
Thank you. Thank you so much, Dr. Amr. Very nice cases, a very nice presentation. Now we'll go to Dr. Ani for his presentation about macular degeneration cases.
Thank you very much to Dr. Amr for leading this, and my previous speaker, Dr. Amr, for focusing on DME. Thank you, Rosh. So I will be focusing on neovascular AMD and faricimab. And like it was discussed before, we know that we have to focus on 3 aspects when it comes to faricimab: the drying effect, the durability, and the convenient dosing protocol of this agent. So we know that with the neovascular AMD, we have Tenaya and Lucerne. From the clinical trials, we know that Vabysmo offers us both stability of vision and a good anatomic control of the fluid. As you can see here, that the best corrected visual acuity and the macular thickness, they work very well over many weeks once the drugs are initiated. And the highlight really is that over 75% patients would require an injection at 3 months or more. And this is something which is very desirable and unique about faricimab. One of the important aspects when it comes to neovascular AMD is the anatomic response and macular thickness. As it is important in DME, so also in neovascular AMD, we would like to have a good drying effect and reduction in macular thickness. And as you can see with the head-to-head dosing, you realize that with faricimab and aflibercept, the initial dosing phase, you can see that you have a very good result with faricimab. And over time with the macular thickness, you can see at week 12, you have a much better response with faricimab at 16 weeks compared to aflibercept, which is Q8 weekly. Again, here you have higher number of patients who have a dry retina with faricimab versus aflibercept in neovascular AMD during the head-to-head dosing period. And you can see here that the absence of SRF and IRF is significantly higher in more than 77% patients at week 12. So in my experience, I'll again share 2 cases of neovascular AMD. But before I do that, I just want to highlight once again the difference here in faricimab is that we would always like to load the patients with 4 injections every 4 weeks. And this is as per the label. And then you could directly go to 16 weeks after the 4 initial injections. So keeping this in mind, I'm going to go to my cases. Of course, based on the response, you could call some patients earlier if you feel that the fluid is persistent or it is recurrent. So let's see the first case. This is neovascular AMD with macular neovascularization. This is a treatment-naive patient, a 58-year-old with a type 1 neovascular membrane, and he has noticed decrease in vision only since 3 days in the right eye. He's a non-smoker, no family history, and there is no previous treatment, and the visual acuity is 2100. So you see, at baseline, you have a very characteristic type 1 macular neovascularization with subretinal fluid, and this is after the first dose. In this patient, I gave faricimab, and you can see at 5 weeks, there is a good reduction in fluid. He's not dry. Of course, he needs more treatment. The visual acuity has improved to 20/80. And following that, we do the second injection, and 4 weeks later, the patient is now dry. So at week, almost 9 weeks into treatment after 2 doses, the visual acuity has improved from 2100 to 20/70. And further, after the 3rd injection, you have further improvement. Patient improves to 20/60. And one of the important components that I personally look at in my patients is also the height and the dimensions of the pigment epithelial detachment. So when it comes to type 1 macular neovascularization, you look at the pigment epithelial detachment. And when it comes to type 2, you can also look at the dimensions of the subretinal hyperreflective material. So we give four injections of faricimab to this patient, and you can see here at week 20, from almost the previous every 4 to 5 weeks after 4 injections, the patient remains well and has recurrence of fluid after 20 weeks. And you can see here this patient was almost fluid free for about 4 months. So number 5 injection of faricimab was given 20 weeks here after the 4th dose, and the patient is maintaining good visual acuity. The last follow-up of this patient is 28 weeks, and you can see the patient is dry at 28 weeks after the 5th dose, and so no further injection was given at this particular visit, and the patient has improved to 20/50. So the patient started with 2100. It's a naive patient, received 4 loading doses. Doesn't happen all the time in real life, but this patient came, had the loading doses, had a good outcome, and directly required the next injection at 20 weeks. So we were able to keep the macula dry 20 weeks after the 4 loading doses. Let me show you the second case. This is a patient who was switched, and this patient is 62-year-old female with neovascular AMD, macular neovascularization. The patient has a long-standing disease since 3 years and has received 5 injections of intravitreal aflibercept almost 4 to 5 weeks apart, and then was switched to faricimab. So when the patient came, the baseline visual acuity was 21/50, and you can see here the patient received the first injection of aflibercept, and 4 weeks later the patient continued to have some amount of fluid. So there was some improvement subjectively in the visual acuity, improved to 2100. So we persisted. We persisted with aflibercept, gave the second injection, then gave the 3rd injection. But you can see here, after 2 injections, there was some increase in the fluid. The 3rd OCT here shows you some increase, and the visual acuity did drop to 21/50. And at 5 weeks, after the 3rd dose, the patient was almost fluid-free and received the 4th injection. But what was surprising is, after 4 injections, this is how the patient comes back, 6 weeks after the 4th dose. So you can see there is a significant amount of fluid. And this fluid is, in fact, much more than baseline. And this is when we decided to switch to faricimab, and the patient received the first faricimab. Also note that the visual acuity actually decreased to 2200. So the patient started with 21/50, came down to 2200, and that's when we switched. And 4 weeks after the first dose, the patient was dry. The visual acuity improved a lot, 20/80. There was a dramatic reduction in the macular thickness, so the patient decided to proceed with faricimab. We also thought faricimab is a good choice here, and the patient went on to receive 2 more injections. And now, after 3 doses, 15 weeks later, the patient is dry. So here, the injection was withheld. We plan to extend to as much as possible. So this is the second case scenario here, where you have a patient who was switched to faricimab and improved to 20/60 -2 from, at a point where he was 2200, and the thickness was 319, and the patient had a suboptimal response, I would say, to another agent, and with faricimab could stay dry for a longer time. And thank you so much. With this, I'll hand over back to Dr. Amar for discussion. Thank you once again.
Thank you so much. I'm going to stand here just mainly because of the light. So thanks again for a very nice presentation and cases. And now we're going to go with the Q&A. And there will be some questions that we prepared to basically try and address, but also other questions. And if anybody in the audience has any question, please let us know. So the first question that I'd like each one of you to address, first of all, we'll start with Dr. Farid. Amr, what is the typical profile of patient that in your practice you feel is a good patient to use faricimab on?
Okay. First of all, we have to know that this is an anti-VEGF. It's controlling or the VEGF2 and also the VEGF-A, sorry, and the Ang2, and it's a new one. So it's doing the same effect as the previous one. So it has to be used in naive patients. You can use it in naive patients. You can use it in resistant cases. In any case that you want to use diabetic macular edema, it can be used. As you can see, the 2 cases I presented, one of them was naive, which is ActSwell, and the other one was switched. So in my practice, I can use this in naive patients, no problem, and as well in the patient that I showed that is not having optimum response with other anti-VEGFs, or even that they need more durability because this drug is more durable. So I can use them in these 3 cases.
So Amr, you mentioned your second patient, and I'm quite interested in looking at that patient because I have a lot of patients like this where they haven't responded to, ideally responded to anything pretty much. They respond, but not really very well. You switch them to faricimab. You see they're getting better, but their vision is improving, but their cysts persist. Do you have any theory about this?
Maybe the Ang2 is working through this. I don't have a theory that really give us a solution why this cyst is really going. But this is what I'm seeing in many patients, that this cyst is decreasing with the faricimab. Vision is improving. Maybe the Ang2 behind this. This is the only different thing between this and the previous.
This patient of yours had Eylea 5 times, Lucentis a couple of times, even Ozurdex.
Yeah, even he didn't improve.
He never dried out completely.
Yes, no.
Yeah. So, I don't know the answer to this, but honestly, I have a lot of patients with the same kind of profile, and they do improve. They tell you, I'm feeling better, I'm seeing better, they improve, but we keep focusing on the central foveal thickness. While if you look at the color map, it's actually much better. So if you haven't looked at the center and you didn't look at the foveal thickness, I think we would keep basically treating the picture more than treating the patient. So I don't know, I've actually learned internally to look at these patients differently and potentially say, no, it's working actually, because their vision is improving, their entire macula is improving, and now we have the post hoc analysis that shows that by fluorescein angiogram, actually the dryness effect is quite severe. For time, again, we have only 4 or 5 minutes. Annie, in your AMD practice, any profile that comes to mind when you see a patient say this is a good patient for faricimab?
No, I actually echo Dr. Amar's comments, and I use it for naive patients of AMD fearlessly because I'm not worried about inflammation. I like to use it as an agent where I'm switching from another agent, again, for the fear that, in AMD eyes especially, we have other agents where the level of inflammation could be very high, and that could be concerning. And so faricimab gives you the option of using it. Many of these patients are single-eyed, one-eyed. I feel comfortable using faricimab in those patients. So again, the anatomical response, when I feel is suboptimal, I do go for a switch.
Okay, so I have only one question for you in one of your cases where between injection 3 and 4, there's really no change, but you stuck with the protocol. In your practice now, do you actually continue to do this all the time, or do you sometimes, if it's dry, you just go right away and extend?
No, not always. Not all patients are amenable to treatment when they look at the OCTs and they feel it's dry. But I feel when you're giving an agent a chance, it's to be fair to the drug, you should try to do loading as far as possible. I don't really, put the gun on the head and say that you must receive. But especially if it's a naive patient, we would like to start with loading as far as possible.
So I believe you may have answered already some of that question. So how were you able to get the best outcome for your patients from applying the results of the clinical trial into your practice? And I guess you just basically told us. Amr, do you have anything to add to this?
We just try our best to mimic the protocols as much as we can, but usually in real life you cannot do this. But as well, even with the faricimab, if there is a little bit of gap between the first loading doses, it really have a good effect at the end.
So if you have a patient that you want to switch, like in your case, you always load them again or not?
Usually if I will switch them, they will be not good. They will be not treated well. So usually I will go for a loading dose. If I'm searching for durability, it might have a little bit of change, but I will start and follow up the patient closely to check if there is any changes to know the efficacy of this drug with him. If it's effective, I can extend straight away. But if I see any changes, we have to have the loading dose as well.
And have you had a patient that came to you and said, look, doc, I heard that this is new medication. I'm fine with the Eylea, but I want you to switch me to that medication.
Yes.
So do you load them or do you switch them?
I wish I could load all patients when I switch. I'm
Why?
often
Why?
not able to do
Why
that, to
do you
be
wish
honest.
that?
Sorry?
Why do you wish that you want to load them?
Because I think, again, to be able to achieve the level that you want, 70% or 80% having Q 16 weeks as shown in the trial, you should start again, like I said, with the label of loading and then to get the maximum
But the
effect.
patient is dry already.
If the patient is dry already, I think just for durability, it is very difficult decision to load the patient. I would probably not do that in my practice. I would probably just use treat and extend or as needed.
Yeah, one answer to that kind of convinced me a little bit is that it takes a little bit for the Ang2 cascade to be blocked. It takes at least 2 to 3 injections.
Yes.
So that's why probably it's a good idea to actually load them, even if we're switching them from dry to a different medication.
Yes.
I think the final question we have right now is in your opinion, how was the dual inhibition of Ang2 and the VEGF pathway, how did that translate into better outcomes that you noticed in your practices? So we'll start with Amr again.
As I showed now, there are many cases that is not responding that well previously, and now they are responding to the Vabysmo. So probably the Ang2 is the key for this, because this is the difference. And as well with the post hoc analysis that we were discussing before, that there is a decrease in the whole diffusion area. Maybe this is the cause. It's working.
And since you are a very, you're also uveitis and inflammation is a big thing in your life. Yes, go ahead.
I was going to say that, so very quickly. So I think the fact that Ang2 offers vascular stability and control of inflammation makes me very comfortable to have an agent that also controls an alternate pathway, which is probably pro-inflammatory, along with the anti-VEGF action. I think that's a very attractive kind of a proposition that this drug has. And so it makes me very comfortable to use it.
Okay, thank you so much. As a closing comment, if I may say, I actually have learned from my own experience that this medication does not give me the wow effect. I guess we live in Dubai and everything needs to be wow. this medication doesn't give you a wow effect, but it does give you a long-standing, you know, comfortable, kind of like Abu Dhabi more than Dubai, if you want to think about it from this kind of. But it's durable. It gives you the effect, but not in a very wow fashion. So thank you so much for your attention. If there's any second question or last-minute question from anybody. No? Thank you so much. Thanks for your attention.
Thank you.
Thank you.
Hello. Dr. Mohammed Ahmad Alilu here. Dr. Tamer Kamali. Welcome as a panelist with me. Hello, everyone. Thanks for staying late. I know we have a very rich program throughout the day, and hopefully this is going to be the best session. I'm very optimistic. We have a great number of speakers, and we are going to go through the cornea journey, and hopefully we'll be covering every layer by layer, right? All right. All right, we will be starting with Dr. Osama Jaledi. Dr. Osama will be talking about the superficial layer, starting with the BTK.
Good evening, everyone, and thank you to stay late for this session. So basically, I'm going to talk about BTK and its use for corneal eye disease. It's FDA approval since 1995, and by using excimer laser to treat variety of anterior corneal pathology. It's still nowadays, it's still very useful for some of the anterior corneal disease. And for two reasons, either to prevent the discomfort of the eye, patient who had recurrent corneal erosion, or to improve the vision acuity, and that's by reducing the opacity, improve the transparency of the cornea, and also smoothing the ocular surface so to improve the vision. So that's the two reasons, and that's why it's indicated for too many corneal disease. The commonest one is recurrent corneal erosion. Almost 50% of the BTK used nowadays for this disease, but can be used for corneal scar, irregular epithelium for different reasons, trauma, post-BRK, keratoconus scar, post-pterygium haze, Salzman nodule, anterior base membrane dystrophy, or herpetic. And the other things is corneal dystrophy, all variety of anterior corneal dystrophy. It can be treated partially by the BTK. It can be used for band keratopathy. Usually we remove the calcium chelating agent and then we're smoothing the surface, or for bullous keratopathy. Preoperative evaluation is very important. When you examine the patient, very carefully look at that with the slit lamp. The disease extension, is it localized, is it diffuse? Check always corneal sensation, check for the dry eye. Take the history of the patient if had any systemic illness which can delay the healing, like collagen disease, diabetes. Check the refractive error, because that you can incorporate in the treatment plan. You could combine it, the BTK with some BRK. When they have opacity, sometimes it's important to differentiate. Is it the opacity make the vision blurry, or the irregularity? That's why hard contact lens can be a very useful tool to differentiate between the two things. And always we use some imaging in the cornea, corneal topography or OCT. Regarding in general, the BTK, we usually use it for treatment of anterior corneal surface disease, less than 1/3 of the cornea. At least you need to leave 250, but always nowadays we try to do limited our BTK to the 100 micron thickness, about 10 to 15% of the cornea thickness. So we don't like to go deeper with that. Corneal topography is very important. Always we have to do it to check the corneal pathology, check the regularity, thickness, and the plan the treatment. Also we use it after the surgery to see the effect of the treatment. But also you can use that corneal topography to measure the irregularity, and you could use topo-guided treatment to improve the surface of the eye. This patient had anterior base membrane dystrophy. By examination, that's why it's important to see with slit lamp, you can see the pathology, but look into the topography. Sometimes if you look at the topography alone, without know the pathology, you'll see that it's maybe suspicious of keratoconus, but technically the topography is mainly because of the anterior base membrane dystrophy. The other imaging which always we use it nowadays is OCT. As you know, OCT is high definition cross-section of the cornea, and using before surgery and after surgery, it will measure the epithelium, how much the epithelium smoothing, how much the epithelium masking, and the depth of the lesion and the irregularity. It's a really very useful tool. I think with OCT, nowadays you have to do OCT to measure. It will help you a lot. This patient had a complicated laser surgery with the flap, and also she had Salzman nodule. If you look to the nodule, so when you look to the nodule, you can see that it's very, how much the thickness, and you can see even the epithelial masking. So for like this patient, if you do transepithelial treatment, it will be much better than to do surgery, so at least very, you know, the lesion and you know the epithelium around it and the disease depth, and you can calculate the treatment, depth of the treatment. So it's very important. The other things, when you have a patient, you need really to explain to the patient about the disease, about the BTK, the post-operative management, and the recovery time, and the expectations. It's very important to have very good discussion about what's your expectation of the treatment of BTK, but also remember to this patient, always tell them that some disease like corneal dystrophy or anterior basal membrane dystrophy may recur. So it's very important to have very clear explanation to the patient. Some disease will improve you for years, but you may need another treatment later on. You could use a BTK like for focal lesion only, but if it's large diameter, you may have to diffuse a BTK. You could combine with different way how you do the BTK. You could remove the epithelium and do the BTK like for recurrent corneal erosion. But if you had a regular surface and lesion, you may have to do superficial keratectomy followed by BTK. You could combine it with some masking agent. When you're using any masking agent over the cornea, so the laser will remove the irregularity while keeping the cornea smooth. Or you could use what you call transepithelium, so using the epithelium as a masking agent, and really it's very useful for some of the treatment to use the epithelium as a help, not to remove it manually, because that will cause more irregularity. You could combine it with BRK, so you could correct some refractive error of the patient. You could use it topo-guided. And the other things you could do is 2 steps. So when you had too much irregularity, you could do the BTK initially to improve most of regularity, or do surgical and BTK, but after 6 months, 9 months with the epithelium heal and the epithelium have better masking, so you could do trans-BTK that to smoothing further. So these 2 steps you could be involved with, especially complicated case. Things to consider for BTK treatment, it's the pathology, the depth of it, what agent, masking agent you want to use. Always, most of the machine, when you do BTK, it can cause hyperopic shift, so you need to understand your machine, and also the depth of that ablation. The more deeper, the more risk of haze and hyperopic shift, and you have to consider using betamycin C. Recurrent corneal erosion, as I mentioned, the most common disease we use BTK. However, majority of the patient, good number of them, by medical treatment, especially sodium chloride 5% ointment, that majority of them, they can be cured with that. This patient had anterior basal membrane dystrophy. So basically for this patient, usually use alcohol, remove the epithelium, and then you do BTK for smoothing and also to prevent recurrent corneal erosion. Regarding the anterior corneal dystrophy, the BTK usually to remove majority of the opacity. Always the plan to remove most of the opacity, not to make completely remove all the opacity regardless of the depth. So you need to remove the majority of the opacity and also to smoothing the surface. That will improve the vision of the patient and reducing the recurrent of corneal erosion. So this patient, like for example, I've done it 3 months ago. She is 16 years old. She had granular dystrophy, and that's just I did. This is a photo after 2 weeks. Just did the trans BTK only, and she's very happy with that. This is another patient from Indian Journal of Ophthalmology. That's also the same things like granular dystrophy with some haze, and just doing BTK. That can improve the surface of the disease. This is really to give the patient some time to see better. The disease may come back, but at least you can do different procedure, or you can repeat it according to how is the corneal thickness and the shape. You could use also after corneal haze, after BRK, and that's also, you could use the transepithelial mode in this way. This patient come to me also, they have Salzman nodule, and if you see the OCT, that's what OCT is very important. If you see the OCT, that's very clear cleavage plane. So you don't use the best thing for this patient because it's very clear cleavage plane. You do surgical keratectomy, remove it, then they do BTK to smoothing it after. The same things, this patient had small nodules, and with Salzman nodule with anterior surface, and that's straight after the surgery, the trans-BRK. This is, you could also use it when you had specific case of keratoconus, when you had small nodules affecting the vision, you could do focal laser to that nodule only. The same things when you had a corneal haze, after radiokeratotomy, you could do trans-BRK with BTK to improve the smoothness and the clarity of the vision. Potential complications, as we know, infection, delay healing because of like diabetes or steroid or toxic medication, recurrent of the epithelium corneal erosion, or recurrent of the disease itself, especially the anterior corneal dystrophy such as lactic and granular dystrophy. Always concerned about potential risk of haze. That's why always better to use mitomycin C for this patient. Recurrent of the primary disease, reactivation of the disease, especially if someone had herpes disease, or if someone you do it in corneal graft, there's a risk of corneal graft rejection. Conclusion, BTK is a treatment option for superficial corneal disease. It's really either to remove obesity or improve the regularity, so improve the vision of the patient. The good thing, so BTK is very easy, safe, and effective procedure, but you need to choose the right patient for this procedure, which is very important. And that's why it's very important to have corneal OCT, topography, understand the disease problem to have better result. And it's a good option always to use trans-BTK as a epithelium, as a mask is really very helpful. And thank you very much.
Thank you. Thank you, Osama. Any questions from my colleagues, or we'll keep the question maybe later for you, Dr. Osama. Very good, comprehensive, 30 seconds, okay. Very good comprehensive approach. I just want to make an announcement by the organizing committee that the opening ceremony is going to be at 8:30. It's going to be in Hall B after this session. And now I will go to the next speaker. We are going a little bit deeper this time. We are going for deeper scar. And Dr. Saleh Mahjoub will talk to us about DALK.
Thank you very much. So my topic will be on DALK, and I would like to share with you a technique which is assisted by femtosecond laser. So why anterior lamellar keratoplasty? Of course, to preserve the corneal endothelium. This is our own statistic. As you see in penetrating keratoplasty, after 10 years, almost all the patients will have below 1,000 cells per millimeter square. And this is despite of not having any episode of rejection. And in the lamellar keratoplasty group, there is almost no change after 5 years. Why deep anterior lamellar keratoplasty? First of all, there is more and more people want to change the name because deep anterior is not precise enough and should be predysmatic lamellar keratoplasty, because you have to leave less than 100 micron of posterior stroma. And the reason for that, because from previous experience with automated lamellar keratoplasty, if you make a cut in the stroma, the visual outcome is not good. You know, majority of our patient best corrected vision is less than 5/10 because interface stroma against stroma is not a good optical interface. And when you do DALK and you compare the result with penetrating keratoplasty, you see there is no significant difference for best corrected vision. Which technique to use? I think there is an agreement that the big bubble technique described by Dr. Anwar is the most efficient technique to separate the stroma from the endothelium. The main drawback is the lack of precision. So whether you go too deep and then you perforate, or you inject air in a superficial way, and you end up just with the corneal emphysema, and you have to finish your case by manual dissection. And the next day, always we have not a very good interface, as you see here on the corneal OCT. So how to get the big bubble all the time? There is one key point is to inject the most posterior part of the cornea, and actually should be injection in the 100 micron posterior part of the cornea. It has been shown by Dr. Buzin in an experimental study. And the reason for that, because the structure of the cornea is much more loose in the posterior part. So when you inject air, the air will diffuse in this loose part of the cornea and will separate the stroma from the endothelium. Another important step of the comprehension of DALK is since that Dr. Dua described a new layer in the cornea, the Dua layer. This is between the corneal stroma and the endothelium. And now we know there is two types of bubble. Type 1, which is the most frequent, it's above the Dua layer. And type 2, only 10% of cases between the Dua layer and the descemet membrane. And then even in some patients, you will have both type of bubble. Type 1, you recognize it by reticular and irregular aspect of the Dua layer, and the type 2 bubble, you recognize it by the smooth aspect of the descemet layer. So how you plan for surgery? Sometimes it's difficult to decide if it's penetrating or lamellar keratoplasty, and in this case, use HDOCT. You see this case of advanced keratoconus, the opacity did not reach the endothelium. And also the pachymetry clamp will give you very useful information, which is the thinnest part of the cornea, and this is very useful to plan your surgery. So we do mark the cornea because in keratoconus the cornea is irregular, and we plan for a stromal cut leaving 120 micron in the thinnest part of the cornea. This is the new Visimax 800. You see it's very fast. Finished in a few seconds. And then you remove the lenticule that you cut with the femtosecond laser, and generally will come very easy. And here, your creation of big bubble is very facilitated. You see the track of the needle is horizontal. You don't have to go oblique because you are sure that you are in the posterior part of the cornea. And this way, when you inject air, you will get a big bubble in 85% of cases using this technique. And this is type 1 bubble. You recognize it by the white ring all around. You have to know that DALK is more successful in a less advanced case. And here comparing less than 70 diopters pre-op, femto, DALK big bubble, 88%, in manual technique only 76%, and for very advanced case, success rate for big bubble is less, but still better with the femto technique. I use a non-penetrating technique because always we have a type 1 bubble and the dual layer is very strong. So I just perforated the dome of the bubble, and here you have access to the space above the descemet layer. So just advance for sake of time. And this is just using regular corneal scissor. You just make a 360-degree keratectomy, don't do any dissection. The big bubble already have done all the job for you. So I'm showing the last segment. And like I mentioned, this is a type 1 bubble. You're recognized by the irregular aspect of the dual layer. So using the femto technique, descemet bearing is achieved in 94% of cases using the femto technique, and only 60% in the manual technique. Nowadays, we use the same cornea for DALK or for DMAC. I'll pass on that. This is putting the lenticles. All the patients have a blue eye, but next day, don't worry, the dye will go off. And this is the OCT, looks like penetrating keratoplasty with excellent optical quality. Last case, in case of the cornea is opaque, this case of macular dystrophy, this dissection is less easy, but still possible. And use intraoperative OCT to guide you during the injection, but still, because we are sure we are in the posterior part of the cornea, it's an horizontal injection, and this is a type 2 bubble because it expands up to the angle. And you see here the smooth aspect of the descemet. Other thing, we thought that we may get less astigmatism using the femto technique, but actually it's not the case. It's similar to the manual DALK technique. So in conclusion, using the femtosecond laser, you can achieve a higher rate of big bubble formation. And also you can achieve much more Desmet bearing, almost 95% of cases. And using this technique, we have been able almost to do 2/3 of our keratoconus cases using the DALK technique. And finally, you have the advantage to use one graft for two keratoplasty. And thank you very much.
Thank you. Thank you. Great lecture. Just a quick question. We've seen the number is high with the FIM2. Is it a single surgeon or multiple surgeon?
Excuse me?
Success rate for DALK?
Yes.
When it's done FIM2 second, with the FIM2 second, it's higher, right?
Yeah,
so is
with
it a
the
single surgeon?
femtosecond is higher. And actually in this statistic, we compared our last 100 manual with our first 100 FEM2.
Okay.
And now it's even higher with the FEM2.
But you are an excellent surgeon. I'm sure the number is high.
No, actually, I'm not the only one doing this at our institution, and other surgeons achieve about the similar success.
Dr. Saleh, thank you for the excellent lecture. If you have a cornea with the previous high drops and some corneal opacity later on in the center, in your experience, how much the benefit of this technique, how about the penetration of the FEM2 to that corneal opacity and the previous Desmet membrane rupture?
Okay. The laser I'm using is the femtosecond laser. I was very surprised, even through opaque cornea, it cuts. So this is not issue. And regarding high drops, even Dr. Anwar, he's now saying to do DALK even in cases with the previous high drops because the benefits are such more compared to PKP. The only thing, if you inject air, you have to be very careful. Otherwise, you can, rupture your Desmet. What I suggest is to use the similar FEM2 technique and then finish the last 100 micron with manual dissection. And you don't need to get up to the dual layer. If you leave less than 100 micron, it's still okay. So now we are doing even more cases with Desmetic, but localized scarring, not extended. Extended PKP.
Yeah, I agree with you. And few cases, some cases of the post-high drops, you can achieve it with the DALK, either with the FEM2 laser and the, or manual. But the issue is, the larger the defect, the more difficult it will be, but you have to be very cautious, especially during the air bubble injection. And it gives good results. Even Dr. Anwar was doing what's called near Desmet membrane dissection at that point, but he's doing it manually. He's not using the
Also,
FEM2
we have learned this from, people with, Down syndrome, because you need to avoid to do PKP. Yeah. Even they have scarring of the endothelium, we do manual dissection, and they do very well.
Yeah.
It's not optimal, but it's better than PKP.
Thank you, Dr. Saleh.
Thank you so much.
Thank you. We'll move to our next speaker. Dr. George Alayo will be talking about stem cells.
Hello again. This is my last presentation, I promise. So, well, here the question is if we can treat corneal stromal diseases by minimally invasive procedures that could enhance or replace the corneal stromal tissue, avoiding corneal transplantation. So this involves tissue engineering, that is a combination of cells, biomaterials, and growth factors in order to replace any biological function of any tissue in the organism. And here we're interested in the corneal stroma, as I said, to avoid any potential corneal transplantation need. So we already did this. This was the first clinical trial ever using stem cells for the cornea, for the corneal stroma, and we did it in patients with advanced keratoconus, stage 4 keratoconus, and this was a trial that we did about 5-6 years ago, and this is all the scientific evidence that was derived from this project. And actually here, if you want to learn more, this, as you see, these American journals, cornea, IOBS, and here you have the references. I'm going to go through the most important points of this literature. So in our project, what we did, we used mesenchymal stem cells, particularly those derived from the adipose tissue. There are other types of mesenchymal stem cells, but we decided to use the ones from the adipose tissue because it's easy accessible. It has some advantages as the fact that it's easily accessible. And what we did is just a very simple procedure with topical anesthesia. The video is not running now. So under topical anesthesia with femtosecond laser, we created a pocket at half depth from the thinnest point of these corneas with advanced keratoconus. And then with a blunt spatula, we opened this pocket and then we injected a suspension containing these stem cells. Okay, as you see, it's 5 minutes procedure, topical anesthesia. As these were autologous stem cells, it did not require any specific treatment, just the normal one, similar to a cataract surgery. And then this idea of injecting stem cells into the corneal stroma to try to enhance it or regenerate it, it was not just an idea that we had in a party one day. Actually, this was preceded by our studies using animal models, where what we did is to inject human adipose-derived adult stem cells, and we injected them in rabbits in vivo, into the rabbit's corneal stroma in vivo. And we saw that the human stem cells are able not only to survive, but also differentiate into adult keratocytes within the rabbit's cornea without inducing any rejection, inflammatory reaction, or anything, despite being xenogenic scenarios between species. And these cells not only survive, but also differentiated in functional keratocytes, able to produce new human neocollagen within the rabbit's corneal stroma. So knowing this and having this evidence already published in the animal models, we decided to jump to the humans, and we selected this clinical trial using patients with advanced keratoconus. We got in all patients some visual improvement, but this visual improvement was quite early in the post-op, so we don't believe that this is in relation with injection of stem cells alone, but only because of the creation of the pocket, because already MEL has published one paper showing that if you create a pocket within the keratoconus cornea, that creates a redistribution of the aberrations that can make the patient to enhance a bit the vision. Okay, so really this visual improvement was more related with the surgical technique itself, but not the stem cells. But here starts the interesting stuff. In these patients, we saw a non-statistically significant improvement of 15 microns in the corneal thickness, but this improvement was real. Why? Because we could see it by anterior segment OCT. We could see that at the surgical interface, there was a new layer created from the stem cells, a layer that we could see and we could measure. The transparency was perfect, corneal topographies were unaffected in these cases, and by confocal microscopy, we could confirm the survival of the stem cells, because here you can see these are the normal stromal keratocytes with a fusiform shape in the anterior corneal stroma, and this is in the surgical interface where you can see these cells are different, these are rounded, these are 3 months in the post-op where the cells are alive, these are the stem cells, still not differentiated into keratocytes. 1 year later, some of these neocollagen layer already remodeled to the surrounding stroma, but in some other patients we could still see them even 1 year after the surgery. And here you can see the perfect correlation between the stem cells before injection in suspension and the microscope, and in vivo 1 month later we can see how you can even see the nucleolo of these stem cells in the cervical plane. So, and here it starts even more interesting stuff. So already from the preclinical, the animal experiments and the preclinical evidence from other authors, there was evidence that in animal models for corneal dystrophies, that there is a genetic knockout in order to create a scar in the cornea. If these animals received mesenchymal stem cells, these corneas created less scar and they were less thinner. So basically the stem cells were able to make the cornea more transparent and to be affected less about corneal thickness. But even mucopolysaccharidosis animal models, transplanted with also mesenchymal stem cells, it was seen that the stem cells itself were able to catabolize these accumulated glycosaminoglycans, and also by paracrine secretion awake the surrounded diseased keratocytes to start also making this catabolism, and that created an improvement in the corneal stroma transparency. So well, knowing this, we already knew that from the animal models, and surprisingly, well, or not surprisingly, we saw that this was replicated in the humans. This are the typical apical scars in a patient with advanced keratoconus. You already recognize these apical scars. This is before the implantation, before the injection, and this is, I think, 3 or 6 months, I think 6 months after the surgical procedure of the stem cells implantation. You can see how the scars have improved by only injecting stem cells. So basically what it was known in the animal and seen in the animal model, it was replicated later in the human. And this is another patient from our second trial that we finished last year. You can see this patient by heterosegment OCT, this corneal stromal haze, and how got better after surgery. And this is not, I'm not cheating you, because if you can see, this is the same cut, okay? You can see this is actually the same horizontal cut in the cornea with MH39, how the scars have got better in the post-op, and again, you can see this neocollagen layer deposited in the surgical plane. And even here by a slit lamp, you could see this improvement before surgery, after surgery, by only injecting the stem cells, okay? You can see how the haze has improved both clinically and by anterior segment OCT. So we wanted to go deeper and understand these changes in the corneal stroma to try to understand this important finding, because really this could change the treatment of many corneal dystrophies and even corneal scars from any origin. So we wanted to go deeper, and then we studied the optical corneal, the corneal stroma optical density with the topographer, and then we could see, this study was published in IOBS, that actually from before surgery up to 36 months post-op, so 3 years post-op, there was a statistically significant decrease in the optical density of the corneal stroma, of the anterior corneal stroma. Okay, so basically the opacity, the degree of density, the density of the corneal stroma got better along the first 3 years after the surgery. And this was all further explained by confocal microscopy. By confocal microscopy, as I said before, we could monitor the differentiation of the stem cells from rounded cells to fusiform cells and distinguishable from the regular keratocytes. And then we could see by measuring the cellularity of the corneal stroma that there was a significant increase in the corneal stroma keratocyte density from before surgery up to 3 years after surgery. So basically, what is happening here? What is happening here after, by injecting the stem cells, is that likely by direct differentiation of the stem cells into keratocytes, and also a probable paracrine secretion that attracts the host keratocytes that replicates, basically between direct differentiation and chemiotaxis from other keratocytes, the cellularity of the corneal stroma increases. We have more keratocytes. This increase in cellularity of the keratocytes is what it's gonna do? To enhance and make faster the corneal stroma remodeling. If we have more keratocytes, the corneal stroma remodeling that usually takes years, here is gonna be much faster because we have much more cells, okay? And by this enhancement and make faster this corneal stroma remodeling, we have the improvement in the optical density of the corneal stroma, and the improvement in the optical density of the corneal stroma by enhanced corneal stroma remodeling makes the scars to be better. And this is the way we understood and we could able to explain scientifically why the corneal scars are getting better by a mechanism effect of the optical density made by increased cellularity of the keratocytes. So as a conclusions, we could say the first conclusion is that the injection of at least autologous stem cells was safe, because in our trial, in our 2 trials, no complication has been recorded, no inflammatory response. And even according to the animal evidence, we know that even if we use cells from other patients, it should not have anything should happen. So a rejection is not expected because the stem cells internalize the HLA antigens, and this is the reason why they don't create a rejection. We have demonstrated not only in the animals but also in the humans that the stem cells survive, they differentiate, and they produce new collagen. We still don't know what is the role of this new collagen band. We don't know what is its biomechanical effect. We don't know. We need to study biomechanics in these patients, and I cannot give you the answer what is the biomechanical effect of this new layer. But definitely, it might not be enough in order to restore the healthiness of a keratoconic cornea, but definitely the injection of the stem cells could be a very promising therapeutic approach for corneal dystrophies, where we don't have a problem with the thickness of the cornea, but we have a problem with the opacity and the transparency of the cornea. Thank you very much.
Thank you. Very, very promising. Looking forward to hear more about future results. any of my colleagues would like to have any question, or we can open a question for Dr. Marwan.
Thank you. It's very interesting. Do you label the stem cells and you monitor the transition from stem cells to keratocyte?
You can do that in the animal, but not in the human. Why? Because you can label them, but later to identify them, you need to either kill the patient or remove the cornea. So in the rabbits, we did. In the rabbits, you label the cells, and then later in the post-mortem analysis, you can actually see all these antigens, see the cells you injected, and also see by different markers, like the keratocan, see be a marker of keratocyte differentiation. In the human, you can't unless you are going to do a transplant on that patient. But the thing is that in this case, we are doing this to avoid a transplant. So actually, none of these cases up to date have required corneal transplantation. So this is the reason why the only way to monitor this is confocal microscopy.
And in confocal microscopy, did you find the population of the existing keratocyte get better when you inject the stem cells, or still the same?
So basically, what we see is that the amount of cells increases, okay? So this was the paper I saw, that up to 3 years post-op, the cellularity of the corneal stroma increased after the stem cell injection.
Thank you. Very interesting. Yeah.
All right, thank you. We'll move to our next speaker. Our next speaker, Dr. Mahmoud Ismail. He will be talking about corneal endothelial proliferations.
Bismillah ar-Rahman ar-Rahim. Thank you very much for introducing me. And of course, we've been doing keratoplasty for more than 120 years, and now it's not the issue of making a penetrating keratoplasty. We are dividing the cornea. As our colleagues have described different techniques for lamellar keratoplasty, our nightmare actually is the primary graft failure, and that's why everything have changed since Muhammad Anwar have created his big bubble and then named the lamellar surgery. Actually, we have presented a very promising video about how to divide the cornea and to use it for 3 patients, 1 tectonic and 1 lamellar anterior and 1 lamellar posterior. But you still need a cornea, and that's the issue. Actually, endothelial expansion was complete failure. And it stops in G1 mitotic cycle because the mesenchymal transition actually ends always by fibrotic or fibroblastic phenomena. So, does it multiplicate? No, it does not multiplicate. It does not regenerate, but it can proliferate. And this is a big difference between both. Kinoshita in Japan have made a lot of work about how to expand corneas, and this is his technique that he sent to me. And imagine, can I do this in Cairo? I don't think so. And this is his lab and the technique. He expanded the cells outside in vitro, and then he injected, and he obliged the patient to lay down for 4 hours, gave the patient one kind of laptop or mobile phone to watch for 4 hours and charge him the mobile phone or charge the laptop after a while, and then keep him face down like in this position in order to lie down the endothelial cells and to stick to the back of the cornea, which is, in my opinion, impossible. So what's missing? Of course, we need an agent that can help the endothelium to proliferate. And this agent was discovered long time ago, and it's in the market actually, which is the ROCK inhibitor, or HO kinase inhibitor. And there was a lot of work about it. Kinoshita has the initiative, and it promotes endothelium healing. And since it promotes endothelium healing, it can help the endothelium to expand and proliferate. A lot of ROCK inhibitors are in the market, but none of them are suitable for the ophthalmology, except one, an old friend, the ibuprofen. It's not in the market actually in ocular suspension or ocular solution, but the cousin is there, which is the amniotic membrane. Amniotic membrane, as all of you know, It holds the growth factor. And 8 types of the growth factors are very helpful in promoting the growth of the endothelium, but only for expansion and proliferation, not for regeneration. And this is a big difference. And what's missing? We need an amniotic eye drops. How to prepare them? We had to go back a number of years ago, 25 or about 28 years ago, when we discovered that by collagenase B, we can dissolve tissues and break the bonds and have a very neat solution without any suspension of tissue with the help of the nanofilters. In 1996, I had the pleasure to win a prize with Professor Alio, the father of Jorgito, or Jorge Jr., and it's about the secondary cataract and what is something related to antimitotic drugs. But at that time, we needed the technique how to transmit a tissue to a solution in order to examine it by the fluorocytometry, the mitotic branding at that time. It was difficult, but we did it. So, with this old technique that we have left 27 years ago or 28 years ago, we can do amniotic membrane eye drops. But in the market, we need some RHO kinase. The fluorobibuprofen, which is a fluorinated ibuprofen, is already in the market. It's Ocufen. We all know that. But it has 2 disadvantages: the low dose and the instability. It's not stable. It's only dedicated for anti-inflammatory decision. Kaufman and Pineda have set a new technique, which is the DIWIC, which is the removal of a tiny part, 3 to 4 millimeters of the center of the cornea, and they decided this is enough only. You don't need a DIMEC. So we picked the idea, and we did some confocal study, and the creeping of the endothelium appears. Actually, yes, the endothelium can appear, can creep, can expand, but again, it does not regenerate. So, what to do? Remove the cattata from the center. You need the RHO inhibitor, ROCK inhibitor, and you need the amniotic membrane. To do a corneal cattata in a patient like this in Egypt is a crime because this patient is still seeing well. But a patient like this, yes. So the best corrected visual acuity should be poor and has a peripheral healthy cornea with some of the endothelium nesting there, waiting for us. Of course, the pachymetry should be less than 800 because more than this means that the cornea is already decompensated. The most crucial thing, the patient should accept an initial severe worsening of his case because corneal edema will happen, which will take about 6 to 8 weeks. That was written in the article. So I decided to take the chance and do it, to do my 2 cases of DUIC. And it looks very nice. Central part of the cornea without endothelium. But the post-operative was horrible, completely horrible. The patient stayed with the corneal edema for more than 6 to 8 weeks. And this is his picture after 3 weeks, even with a lot of treatment. So, what to do next? The amniotic membrane eye drops and the RHO inhibitor. We should add them to the technique. We took a grant from Pharmaceutical Talent Pharma, and we promise you, in the near future, we can develop a small amount of ROCK inhibitor, preservative-free, and I think in the next 2 weeks we will have it in our clinic. Something very interesting. In Egypt, in the temple of Edfu, the couching technique for cataract, and in the same technique was in Cordoba Museum in Spain, in the south of Spain. So it was transmitted from south of Egypt and went there in Cordoba. I would also like to invite you all and mark your calendar, April, Next year, we will have the National Egyptian Society of Ophthalmology, and we will be hosting all the societies of the Arab world. Thank you very much.
Thank you. I'll have a small question for you if you don't mind. Thanks for the great presentation. I think what I would like to ask you, because you mentioned the criteria of selecting these patients, and what I've noticed here that in our country and in our region, this phenotype of patient have central gutata and healthy peripheral is rare. I've seen a lot in Western countries. It is common in Western countries. That's why where they publish the DWIC procedure, or now they call it DSO. When I came back, I was seeing quite a good number of fuchs here in our region, but I didn't find this a good candidate to perform DSO
DWIC,
or DWIC
yes.
procedure, because I don't think in our region we have a lot of it. I got a lot of Arab people from different parts of the world coming to my clinic, but I didn't find it. What's your experience? Do you see those?
Actually, my experience is the same like you. To find a candidate for DWIC in our region is very difficult. To have central gutata with nesting endothelium in the periphery and clear cornea, less than 800, and best corrected is less than 0.2. A patient who's very agreeing and easygoing to accept worsening and then wait 6 to 8 months, 6 to 8 weeks to improve, this is very difficult. By the way, the two patients, even I have explained everything for them. Everything. And the second week, they started to complain, saying that I am getting worse. The technique that you did me is not worth nothing. And they have tracked everything they have said and agreed for, because he is suffering.
This is true. Doctor, thank you for the excellent lecture. I want to ask, you mentioned something about you were successful in preparing eye drops from amniotic membrane. As we know, amniotic membrane has two faces. The one which is having cellular and the other one which having this mucus. So can we have a hint how you managed to do that?
Yes. The two layers, one of them is the amnion and the other is the terion.
Yes.
The cellular part and the acellular part. Actually, you cannot differentiate them by the collagenase B. You cannot dissolve one and leave the other. It's impossible.
Yes.
You have to dissolve. Let me be honest with you. All of the experience that I had number of years ago during my PhD, at that time, and this is the video with Professor Alio at that time, and it was a miracle to have transmitting tissue to eye drops, and this is a patent. We call it investigative patent. It's not a patent to sell. It's an investigative patent just to say that these people were the first people who did so and so. Now, we go to the amniotic membranes preparation. Collagenase B just cuts the bonds. It does not affect the growth factor, and this is the beauty of it. And with a small nanofilter, you have your eye drops ready. The only thing is, these are freshly prepared, and you have to advise the patient to finish the eyedropper for 1 day or maximum 2 days, because you cannot put a preservative in these eye drops.
Yes.
It will destroy the growth factor.
Because I have some experience with the fresh amniotic membrane. I was preparing it myself. So once we take it from the uterus
OR, yeah.
and we clean it, with just a simple stick, you can feel the difference. If it's
Yes.
still fresh, you can feel the difference, and you can feel this thick mucus layer which is enriched with all of
Sticky.
these growth factors.
Yes.
So
The terion is sticky.
thank you for this very.
Unfortunately, the result was not good at the beginning, but I'm not down yet. I will go for it.
I think this might be an area for further development
It needs a lot of
focusing
work.
on this. Thank you, Doctor.
Thank you, sir.
Thank you very much.
Thank you. Thank you. We'll move to our next speaker. Dr. Rohani Sakla will talk to us about DMEC surgery.
Good evening, my dear colleagues and friends. I'm very happy to share the podium today with my colleague, Dr. Mahmoud Ismail, and with Dr. Jorge Alio. I was a fellow of his father in the early 90s, and I'm very proud of that. He's a legendary figure in our field. Today I'm going to discuss the posterior lamellar keratoplasty or endothelial keratoplasties. And my lecture, actually, it is directed to those who are not performing this kind of surgery. So I'm directing this to my colleagues who are afraid or skeptical or worried or they need a push to go in this direction. And why we should do that? Because of the faster recovery for our patients, the better visual results, and the lower rejection rates. And actually, because we can, and it is an easy technique. Posterior keratoplasty, lamellar keratoplasty, was first advocated by Dr. Melis, who participated a lot in the development of endothelial keratoplasty in Holland. He's a Dutch surgeon. He performed the first posterior lamellar keratoplasty in 1998, and then that was a big procedure through a lamellar dissection, corneoscleral large wound. But he invented the desmatorexes in 2004, and so the era of DSEK, Descemet stripping endothelial keratoplasty, or DSEK, Descemet stripping automated endothelial keratoplasty using an automated microkeratome started. And in 2006, also Dr. Melis performed the first DMEK in the history. In 2009, we started to have the ultra-thin DSEK, in which we have a thin stroma with Descemet membrane and endothelium less than 100 microns, which is very popular now. In 2018, we started to receive from the Lions Eye Bank a pre-stripped, pre-stained, pre-cut, ready Descemet membrane for the DMEK procedures. We see a trend here in the number of keratoplasties performed for the pseudophakic bullous keratopathies or for the Fuchs endothelial dystrophy, that there is a decrease in the number of PKPs in the last decade and increase in the number of DSEK and DMEK. And in the graph on the right side, we can see that from 2005, there is a very steep increase in the number of DSEK performed, and with the popularity of the DMEK procedure in 2011, we see that both of them are more now than the PKP performed. And why is that? Why more surgeons are adapting these techniques these days? Because the tissue preparation nowadays by the eye bank made this procedure very simple for us. We don't have to lose tissues. We don't have to waste time to prepare the tissues for the surgeries. Also, the ease of handling of the lamellar graft is much simpler than the PKP. The aspects of the recipient's ocular anatomy, the anterior chamber complexity, sometimes the presence of anterior chamber IOLs, the peripheral synechia, the presence of tubes, corneal opacities, wide pupil, big iridectomies, aphakia, the presence of vitreous prolapse, all these sometimes can be addressed with the endothelial keratoplasties even better than with PKPs. Intraoperative complications are much less, and the early visual recovery compared to PK and the survival of the grafts are very encouraging. Tissue preparation, before the surgeons used to do the scuba technique to prepare for the DMEK graft, or they used to use the artificial chamber to make their own graft for the DSEK, but nowadays we are very lucky generation that we receive this already prepared by the eye bank. For the ultra thin DSEK, we have to do 2 passes with the microkeratome. to reach a thickness of 100 microns of stroma and descemet membrane and the endothelium. Each pass is opposite to the first one, and then it is cut and sent to us. For you or for those who are starting DMAC, in my opinion, they should develop certain set of skills through the practicing of DSEC first, because DSEC is a little bit simpler in the manipulation of the donor tissue. Here in this case, we do a scoring of the descemet. First, of course, we mark an 8.5 millimeter, and we do the descemetorexis with a reversed Sinskey hook. Then with this stripper, without injuring the endothelium to avoid any detachment of the graft. We are doing an inferior iridectomy with the vitrector, very important to avoid the post-operative pupillary block. Here I am not staining the donor tissue, the graft in ultra-thin DSEC, although I recommend to stain it and to have a mark, the letter S or F, to know the orientation of the graft. I am using a Busen glide and a Busen forceps, and through a 5 millimeter incision, temporal incision. First I enter the Busen forceps, and I pull the graft. I stop immediately the anterior chamber maintainer. We inject air and we close the temporal suture, and that's it. We put a bandage contact lens. We should not leave the anterior chamber full of air. I would leave about 80% of the anterior chamber full of air. The inferior iridectomy should be open and not covered by the air bubble to avoid any pupillary block. We leave the patient 10 minutes in the supine position. Then we can reduce again. We introduce BSS to reduce the air bubble size, and the patient stays for 2 days in a supine position. Every 1 or 2 hours, he can walk for 15 minutes to go to do his needs. This is the patient, the same patient that I showed the surgery now, the preoperative on the left, the postoperative after 1 month. This is ultra-thin DSEC, and the vision improved from counting finger 1 meter to 0.5 after 1 month. This is another case, but for the sake of time, I'm going to pass it to go to our subject, which is the DMAC. The DMAC today, it's very easy, as I told you, because the graft comes in this cornea chamber, transparent cornea chamber. We can see here on the right side how we receive it. In a Stryko Jones modified tube, and the set for the injecting this graft is very simple. It's a syringe and a tube, or we can use any catheter or any gastric tube. This video, actually, it's from the iBank. It's an educational video. Sometimes the graft is adherent to the wall of the reservoir in the Stryko Jones tube, so we have to wash the BSS with BSS, the Optisol fluid that the graft comes in it, and we have to dilute this Optisol in a basin of BSS, and we have to make sure that the orientation of the graft in the injector is proper with a V-shaped figure. And once we enter the graft inside the anterior chamber, we have to look at the orientation and we have to look at the configuration of the graft. Once the graft is inside, we have to depressurize the anterior chamber. We have to press at the wound to remove the injector. And by simple tapping, there are certain rules here to how to open the graft. This technique is called Derry-Sammer technique. We use cannulas to change the position, to center the graft, and to open the graft. One cannula is always stationary, the other is dynamic, as we can see. And with the waves of the fluid inside the anterior chamber, this is enough to open the graft. Once the graft is central, and all the edges are open, we enter air, or I prefer SF6 20% at the end of the procedure. And again, we have to wait for 2 minutes, then we wash some of the gas. The cannula for the air should be exactly in the middle, in the center of the pupil. And then we close the wound, we wait for 10 minutes, we reduce the volume of the air bubble to 80%, and again the same as usual with the DSEC. Here, the orientation of the graft, it is very important. There is one sign. The one on the left, on the top left, this is the correct orientation. If we enter a cannula and we pass it to the right or to the left, if we see the tip of the cannula disappears, this is the correct orientation, and this is known as Mutsuori's sign. But if we move the cannula to the right and to the left and it does not disappear, then this graft, it is inverted, and we have to flip it to make the endothelium facing backwards. And this is simply by injecting BSS, flushing BSS at the level of the iris, and the graft will immediately unfold. These are the shapes and the configurations that we might face, and I would encourage every one of you to go to this video by Dr. Peter Veldman and the commentary by Dr. Uday Devigan, because it is the only video that is showing the 8 configurations that we might face in DMEC and how we can address each one of them. From up left, clockwise, we have the normal scroll, edge fold, double fold, double scroll, inverted. We see the inverted S there, inverted graft, simple fold, taco, and taco, there are 3 different types of tacos, bouquet, and origami. How to open the graft? Basically by doing one of 4 things. Either to roll the graft with BSS at the level of the iris, or tap along the longitudinal axis, and in simple fold, we do the Derry's hammer technique that I just mentioned. One cannula is static, the other is dynamic. Only doing tapping will push the fluid inside the anterior chamber and will open the graft. And in edge fold, we can do just pressing and release at the anterior chamber. This will open the fold. There was a study comparing, sorry, how can we go back? There was a study comparing the DSEC in one eye and the DMEC in the other eye in 15 patients, and it was found that the rebubbling rate was less in the DSEC group. There are certain tips here to avoid the high rebubbling rate. Mainly, we should not overlap the edge of the dysmatorexis with the donor tissue. It should always be smaller than the dysmatorexis. And we can see that the vision, of course, the best corrected vision, more than 50% of the patients in the DMEC groups achieved 20/20 vision or better, and this is because the interface in the DSEC, the higher order operations created by the interface, the stromal interface, makes the quality of the vision in the DSEC group is less. However, we, as Dr. Ismail mentioned, here we do DMEC in patients with Fuchs dystrophy with relatively good visual acuity. So they should achieve better visual acuity. It is like the phaco in the early times. While DSEC, when we do it in pseudophakic bullous keratopathy that was there with some corneal scarring and it is long standing for 2 years or more, then usually we have issues with the vision, but still it is much better, like the case that I showed the video. Again, if we compare the SEC and the MEC, we can see in terms of the vision, there was a statistically significant difference in terms of the visual quality at 6 and 12 months, better in the DMAC group. Endothelial cell loss was slightly more in the DMAC group than the DSEC group. Changes in the central corneal thickness, of course, the cornea is thicker in the DMAC group because it is thicker already, the donor tissue. The complications are more or less similar.
Sorry, Dr. Hani, if you could summarize for us.
Yeah. Complications were similar, and the rejection rate in 10 studies, almost 1,000 eyes, the DMAC was much higher, the primary graft failure because of the manipulation, while the rejection was higher in the DSEC group. The take-home message here is that tissue preparation in the beginning was difficult in the DMAC, but now it is easy because we get both grafts from the eye bank. Tissue handling is more or less similar. The visual outcome excellent in the DMAC, very good in the DSEC. Complications is higher in the DMAC. The rejection rate is lower in the DMAC. Primary failure is higher in the DMAC. Survivor is similar. Thank you very much.
Thank you, Dr. Hani. For the sake of time, we'll move to our next speaker. We are about 5 minutes behind in our time. So our next speaker, Dr. Nancy, she will be talking about keratoprosthesis burls.
Good evening, everyone, and thank you for staying that late. Actually, I'm afraid to present my presentation among all these beautiful procedures and clear corneas and beautiful surfaces because my presentation is about a very hostile environment. So let's talk about keratoprosthesis. And let's go about flashbacks of the PKP that started in 1905. It's all about selective corneal transplantation, the lamellar keratoplasty, DSEC, DMAC, DWEC, and they are all the best or better option in an optimal environment. But what are the drawbacks? What about rejection? And what about the desperate corneal blindness? So keratoprosthesis is a transformative procedure. It's not an effort to replace the cadaveric cornea, corneal transplantation. We aim to bypass the ocular surface and cornea and the hostile environment. So these are desperate cases with multiple comorbidities, and it's never a magical spell. It's helping hand in the right time and for the right people. So basics about keratoprosthesis, it's usually plastic or artificial optic. There's no epithelium, no endothelium, and there's no rejection. The concern is about the retention rate, the biointegration, and the loss of self-defense mechanism because this is a static tissue. Now, the types of keratoprosthesis, we can divide them into two types, those with biological support and those with non-biological support. The biological support, they include the tooth root, OOKP, or modified OOKP, osteodontokeratoprosthesis. If we don't have a tooth, we can take a tibial bone or a cartilage. The non-biological support, we have lots of devices, the PMMA, Dolman, Duane, Boston type 1 and 2, the Dacron from Pentucci, the hydrogel alpha core, the hydroxyapatite from Leon Paracare. But among all these, there are two winner devices, the osteodontokeratoprosthesis, and they are reserved for the dry, non-blinking keratinized eye or the eye with a lead defect, and the Boston type 1 keratoprosthesis for the wet, blinking eye. And this is the line that I draw between deciding which way to go. So a wet, blinking eye, I go for the Boston, and the dry, keratinized eye, I go for the OOKP. Now, before you offer a keratoprosthesis, remember that these are special needs, desperate eyes, they have comorbidities, whether local or systemic. They need longer commitment, stricter compliance, understand what you offer before you offering it, address the challenges, optimize the surroundings, and chair time is crucial because you need double the effort compared to a natural corneal tissue. As we said, indication, multiple graft failure, and these hold the best prognosis, neovascularization, infection, rejection, stem cell failure, etc. Chemical burns, limbal stem cell deficiency, mucous membrane pemphigoid, and they are all patients who are scarred physically and psychologically, and you have to be up to their challenges. So let's talk about Boston keratoprosthesis. As you see, it comprises a front plate, which is a 5 millimeter, and a back plate, which is an 8.5 millimeter, and the cornea, the actual cornea, is sandwiched in between. So the procedure skills is needed a step further than a PKP. You assemble a device on a side table, prepare the eye, and I want to show a video that's only 1 minute. This is after 100 K pros done a few months ago. celebrated. Now, you can go a step further and reconstruct the anterior segment in case of severe disorganized bulging, such as in case of posterior infection, especially after fungal infections. And you can combine it also with simple limbal epithelial transplantation of cases of severe limbal stem cell deficiency. Now, the success rate is about retention and managing complications. So the most common complication in Boston keratoprosthesis is the retroprosthetic membrane. So it's important to pick it up from the beginning and to yag it, because if it becomes thick, you have to go posteriorly and cut it with a cutter. Glaucoma is also one of the complications, because you have decompartmentalized the anterior part of the eye. And you want to, if there any chance of glaucoma, you have to insert a tube. Melt or exclusion, it is common if there is dryness, retin detachment, infection, and endophthalmitis. Now, the latest advances with the Boston keratoprosthesis is that it comes with the titanium. The titanium now is better in retention rate than the PMMA. It has more holes, and there's the Lucia design that comes in colors with the brown, the blue, and green, because in the past it's only had a blue tinge, and the patient did not like that. So now the Lucia design, first of all, it's cheaper. Second, it has colors, so you can customize it according to patient eye. And they are working now in Boston, Massachusetts on pressure sensors in order to tackle the glaucoma. And they're working also on a hydroxyapatite, a different material that is more biointegratable. So after 100 Kibro, looking back, we had times of milt, to be honest, that were rectified and the graft was revised. We had infections that were treated. We had choroidal effusions that were also treated. We had extrusions that had to be reinserted again and redone. And we had a retroprosthetic membrane that was yagged. Now, I know a lot of people that are afraid to use the keratoprosthesis because of all the obstacles that are about it. But let me tell you that we have saved more eyes and lives that we have lost. So I encourage anyone who is thinking of starting keratoprosthesis practice to go ahead with it, because it's a game changer point. Now, another keratoprosthesis, I'm going to go through this quickly because it's kind of complicated. The osteodontokeratoprosthesis, known as the tooth in the eye surgery, is described 40 years ago, and it remains the keratoprosthesis of choice for end-stage corneal blindness that's not amenable for penetrating keratoplasty. It was introduced in 1963 by Strampelli in Italy, in 1973 by Facilenni, who's the son of Strampelli, and he is responsible for the success of this new modification. In 1996, it was introduced by Christopher Liu, my mentor in UK, and I was honored to introduce this to Jordan in July 2016. And it needs two teams, a maxillofacial team and ophthalmologist, because it's 2 stages, 2 to 3 months apart. Stage 1 is a lamina and buccal mucous membrane. You take a tooth root from the canine, and you literally work on the tooth root to bring a lamina as thin as 3 millimeter, and you drill a hole in the lamina. Can we play the video, please? So this takes like 8 hours in order to make sure does it work? So okay, let me tell you. So we try to just fashion a 3 millimeter by 4 millimeter block, which is 10 millimeter long, and we just drill a hole that is 3 millimeter hole inside the lamina, and we use this optic by morture. It's an optical cylinder according to the axial length of the eye, and we cement it into the osteodontolamina. And this is the osteodontolamina. It's a tooth root with an embedded optical cylinder. And we put it under the skin for a few months in order to gain soft tissue, and if any infection happens in the mouth, it's just externalized into the into the skin before transforming into the eye. And this is the stage 2. After 3 months, we open up the eye, we open up the buccal mucous membrane, we decompartmentalize the whole anterior chamber, the cornea, we open up the cornea, and we remove the iris, we remove the lens, we do a limited anterior vitrectomy, and then the lens by intracapsular cataract extraction, so the whole anterior part is taken away, and we put the lamina on top, and using a lot of sutures, Vicryl and nylon, we put it on the front of the eye, and we reflect the buccal mucous membrane on top and make a hole inside, and we just externalize the optic. So this is how the eye looks like at the end of the procedure. And this is a schematic diagram of the osteodontic keratoprosthesis and the changes that occur to the anterior chamber structure. As you see, it's an aridic and aphakic And the sclera is with the buccal mucous membrane is just becoming one aspect. The tooth is used as a support because why the canine? Because it's the longest lasting bone in the human body, so it prevents resorption, and it holds the optical cylinder that faces the wider part of it faces the inside of the eye, and it pokes outside into the outer world, let's say, the optical cylinder, and this is how it looks like at the end of the healing process and whatever. So what are the limitations and complications? For oral surgeons, let's skip that. Eye-related buccal mucous membrane necrosis, thinning, overgrowth, laminar resorption, and endophthalmitis, glaucoma, and the cosmesis. People are on Diamox for life. You have to just monitor the optic disc, and I let patients put the drops under the tongue for treatment of any glaucoma. It's important to choose the candidates carefully. They need a lifelong follow-up. It's not the happily adjusted, leave them behind. You need really motivated patients that are older than 17 and have normal posterior pole with reasonable expectations and are willing to look like an alien somehow with such prosthesis. Now, the success rates is defined in terms of the retention. It's the longest lasting keratoprosthesis in the world. It's 85% in 18 years, with 75% seeing 6-12 or better. It is the only hope for restoring sight in the long term for desperate cases for corneal blindness, not amenable for conventional corneal surgery. The take-home message is desperate anterior segment cases with normal or good posterior segments can benefit a lot from K-Pros. Know the visual potential of the patient before offering him a K-Pro. Make sure to spend time explaining the procedure, the risks, benefits, and the need for a long life commitment to clinical visits. Do not force K-Pro on the happily adjusted blind or the patient with unreasonable expectations. Teach your patient that every single day is a bonus. Vision lasts as long as the K-Pro lasts. So just to tell you that one of the Boston patients had been blind for 30 years and now he has a driving license. One of the OKP patients saw his grandchildren for the first time after 15 years of blindness. It's difficult surgery and these are difficult eyes, but yet rewarding for those in desperate need. And it's our mission to spread knowledge and light and pave the way. So it's better to light a candle than curse the darkness. And thank you very much.
Thank you, Dr. Nancy, and congratulations for doing 100 K-Pro. This is very impressive. And thanks for changing the life of those patients. Thank you. We will move to our last speaker, Dr. Ivana Romek. She will be talking about emerging management for neurotrophic keratitis.
Good evening, everyone, and thank you for attending the last session of the day. It's my pleasure to talk about emerging treatment options for neurotrophic keratitis. So neurotrophic keratitis is a progressive degenerative corneal disease. We know it's caused by impairment of trigeminal innervation, and this leads to corneal epithelial breakdown, compromised healing, and it can end up with a corneal ulceration, melting, perforation, and of course, vision loss. It is classified as a rare orphan disease. The estimated prevalence is less than 5 individuals in 10,000. However, the true prevalence is difficult to determine, and the best data are based on extrapolation from the most common conditions which are associated with the NK. So we know that around 6% of patients with herpes simplex keratitis develop an NK, around 13% of patients with herpes zoster keratitis, and around 3% of patients who had post-surgical nerve damage. Recently, there is a study that was published suggesting a higher prevalence, so it is thought to be 11 individuals in 10,000, so much higher than previously we were thinking. When talking about etiology, there are several conditions that may lead to impaired trigeminal innervation, and they can be divided into 4 groups. In the group of ocular diseases, of course, the most common is previous herpetic infections, but also ocular surgeries like laser vision correction, chronic contact lens wear, or chemical physical burns can also lead to neurotrophic keratitis. Among systemic disease, the most common systemic etiology associated with the NK is diabetes, so we should always have this in mind. And also, when we see patients who had neurosurgical procedures, especially procedure for trigeminal neuralgia or acoustic neuromas, they can develop NK, and it can also be caused by a stroke, neoplasm, or aneurysm. There are also some genetic diseases that can be associated with the NK, of course less common. But we should have them in mind, like Relay-Day syndrome, Golden-Hara syndrome, or Mobius syndrome. Neurotrophic keratitis is classified by severity using the Mackey classification. So we have stage 1, 2, and 3. Stage 1 is a mild disease characterized by punctate epithelial keratopathy. Stage 2 presents with epithelial defect, and stage 3 is a severe disease presenting with a corneal ulcer. Diagnosis of neurotrophic keratitis should be based on medical history associated with corneal epithelial changes and, of course, impaired corneal sensation. We should always think about neurotrophic keratitis when we see a patient who has dissociation between symptoms and sign. It is so-called corneal staining without the pain. When doing a clinical exam, exam should involve, of course, slit lamp exam with the use of vital stain, lacrimal function test, and we have to check also blink rate and the blink pattern. But of course, the key step to diagnose disease is to test corneal sensitivity. We can do qualitative and quantitative testing. Qualitative testing can be done by the use of cotton swab. We can use a cotton wisp, even unbox dental floss can be used, and tip of the tissue. So this is easy, and it's available in the everyday clinical practice. We also have a quantitative testing. We can use Cochet-Bonnet aesthesiometer or non-contact Belmont aesthesiometer, but this is mainly used in the clinical trials for research purposes. Important to mention that in 2021, an expert consensus on diagnosing and treating neurotrophic keratitis was published, and the expert panel strongly recommends corneal sensitivity testing in cases when we have a persistent epithelial defect that does not improve within 14 days, when we have a painless, newly observed epithelial defect of unknown etiology, if we have a patient with a history of herpetic eye disease, or a patient who had a procedure that might have damaged trigeminal innervation. So what is the aim of treatment? The aim of treatment is to restore corneal integrity and, of course, to prevent progression of disease. At the same time, we have to treat all the underlying or predisposing conditions. Treatments are typically used according to NK stage, according to disease severity, but they are not mutually exclusive of one another. And also, often we use combination of treatments. Treatment approaches can be divided into 3 groups. We have topical treatments, in-office procedures, and surgical interventions. The mainstream of topical treatments is, of course, the use of preservative-free artificial tears. We can also consider autologous serum drops, and there may be a role for steroids, cyclosporin, lifitegrast to control ocular surface inflammation, and the use of antibiotics if epithelium is violated. Nowadays, we also have recombinant human nerve growth factor, which I will be talking about a little bit later. In-office procedures available include therapeutic contact lenses. We have punctal occlusion, non-surgical eyelid closure, either by gluing the lids or Botox tarsorrhaphy. We can use a self-retained amniotic membrane or tissue adhesives. And in severe cases when a surgical intervention is required, we have several options. We can do tarsorrhaphy, conjunctival flap, corneal transplant, suture amniotic membrane transplant, or direct neurotization. In recent years, the development of a Senegermin ophthalmic solution has transformed the treatment landscape for patients who are having neurotrophic keratitis. So what is Senegermin? Senegermin is a new recombinant human nerve growth factor, which is structurally identical to the human nerve growth factor protein which is found in the ocular tissue. And this is the first FDA-approved treatment that targets the root pathogenesis of neurotrophic keratitis. In US, it's approved for all stages, and in European Union, it's approved for stage 2 and 3, and it's approved from the age of 2. That means it can be used in pediatric population as well. The efficacy and safety of Senegermin was evaluated in 2 main clinical trials. So we have 2 pivotal clinical trials. One was performed in US and the other one, Reparo, in Europe. And these 2 clinical trials enrolled the largest population of NK patients which are ever examined in the randomized clinical trial. And based on these 2 trials, Senegermin was granted orphan designation, as an orphan drug designation, a breakthrough therapy, and it was also FDA approved in August 2018. In the US trial, they enrolled 48 patients with unilateral and bilateral disease at 11 clinical centers, and they were randomly assigned either to vehicle or Saint-Germain group, and the duration of follow-up was 24 weeks. In the European Reparo trial, 156 patients with unilateral disease were enrolled at 32 clinical centers throughout Europe, and they were randomly assigned either to vehicle Saint-Germain 0.001 or Saint-Germain 0.002%. And the duration of follow-up was a little bit longer, 48 weeks. In both trials, the endpoint was at week 8, and that was a complete corneal healing. These are results. So at 8 weeks, 72% of patients who received Saint-Germain in European Reparo trial had complete corneal healing, compared to 33% of patients in vehicle group. In the US trial, 65% of patients had complete corneal healing, compared to 17% of patients in a vehicle group. What is important to mention is that 80% of patients who had complete corneal healing in the Reparo trial, they remained healed even 48 weeks after one course of Saint-Germain treatment. So since Saint-Germain was approved, of course, many studies were published showing real-world experience and the efficacy of medication. This is one of the studies published by Dr. Sacchetti and her colleagues in Italy. They did a retrospective study at 2 centers in Italy. They involved patients with neurotrophic keratitis stage 2 and 3 who were treated either by amniotic membrane or Saint-Germain. And they found that complete corneal healing was achieved in 86% of patients in amniotic membrane group and 96% of patients in Saint-Germain group. They were looking at the recurrence, and at 12 months, 46% of patients had recurrence in amniotic membrane group, but only 13% in Saint-Germain group. Also, patients in Saint-Germain group had a recurrence-free period which was longer, and they had a higher satisfaction rate. Another study published by Dr. Bruscolini and her colleagues, also done in Italy. This is a study, also retrospective study. They did a retrospective chart review of patients with stage 2 and 3 neurotrophic keratitis. They included 18 patients who were treated with Saint-Germain and followed for up to 48 months. So all of these 18 patients had complete corneal healing at 8 weeks. And among 18 patients, only 3 patients had recurrence of epithelial defect after 12 months and 1 patient after 36 months. What they also found is that there was improvement of corneal sensitivity at all time points, and also there was improvement in visual acuity and tear production at the end of the treatment, and also after 12, 24, and 36 months compared to the baseline. Now I would like to present a case, my first patient that was treated with Saint-Germain.
Summarize.
Okay, I think it's a few more slides. So I have a 64-year-old woman with a history of a large complex sphenoid meningioma. She did 2 surgeries in Singapore and Korea for a meningioma, and she came in May 2019 at the eye clinic, so this was her first visit. Her best corrected was 2025, her cornea was clear, she had anterior basement membrane dystrophy, decreased tear breakup time, but no epithelial defect. Of course, I tested corneal sensation. It was decreased compared to the other eye, so she was diagnosed with NK stage 1 and prescribed with preservative-free artificial tears plus cyclosporine. She was advised to follow up monthly or as needed. She was doing well. Then between March and August 2020, she lost follow-up due to pandemic. And in August 2020, she presented with a decreased vision. Her best corrected was 2200. She had a central stromal haze with the oval shape epithelial defect overlying. There was no thinning, no corneal infiltrate. Corneal sensitivity testing was repeated, and she had complete anesthesia. So at this point, it was neurotrophic keratitis stage 2. She was prescribed with moxifloxacin. She had bandage contact lens, 2 rounds of Prochera amniotic membrane. And once Prochera was resolved, epidefect was still there, but it was significantly smaller. Then I prescribed autologous serum drops, and in September 2020, epithelial defect healed. Stromal haze neovascularization stays stable, and best corrected improved to 2060. She was fine for a while, but then in August 2021, she ran out of drops. She came with a new epithelial defect, 6 by 1 millimeter, which was overlying the stromal haze. She had some thinning, and best corrected was decreased to 2200. So now we have a neurotrophic keratitis stage 3. She was prescribed with moxifloxacin, vitamin A, autologous serum, preservative-free. At that point, I was informed that Senegermint is available, so the medication was ordered, and in September 2021, she was started on Senegermint. Unfortunately, I don't have a picture of her eye before starting treatment. This is a photo 1 week after starting treatment, so we can see that epithelial defect is decreasing. 2 weeks after starting treatment, epithelial defect healed to a ridge with a surrounding punctate epitheliopathy. And the same finding 4 weeks, 6 weeks, and 8 weeks after starting treatment. At this point, she was saying that she feels overall much better. Her vision improved to 20/70. And then 1 month after treatment, we can see that not only epithelial defect heals, she had also this staining of the irregular epithelium resolved, so no more punctate epitheliopathy, and her epithelium was smooth. Stromal haze stayed the same. Neovascularization decreased, and her vision was 20/60. And she had no recurrence since then, so this is after 2 and 6 months. So as a take-home message, just to repeat, treatment of NK is based on its severity and the cause. Early diagnosis and intervention is crucial for the optimal management, for the optimal outcomes. Sometimes we need combination of medical and surgical approaches, and the new recombinant nerve growth factor has revolutionized our treatment abilities for our patients with NK. Thank you.
Thank you, Ivana. I think I'll close the session now because organizers telling me opening ceremony starts at 8:15 in Hall A. So I would like to invite everyone to join the opening ceremony in Hall A. Thanks for the speaker, and thanks for everyone for staying late. Thank you.